Good morning, everyone, and welcome to day 2 of the hot topics at the AASLD. And today, again, on the second day, we bring you a lot of exciting topics. This half-day session will go on till 2 o'clock. And thank you for joining us yesterday. And for those who were not able to join us yesterday, a very warm welcome to you. At the outset, a lot of thanks to our faculty who have put in a lot of effort and time to prepare the lectures and bring all this data to us so that we could have the benefit without actually being at the meeting. So I will start the meeting by requesting Dr. Sareen to say a few words, and then we go on to the first talk.
Thank you and welcome to day 2. We were very lucky that our speakers and moderators could attract close to 1,000 people who were glued till the end at about 10 p.m. We have a very exciting day today, and I would like you to join and have a good cup of coffee and keep participating in the discussion. And thank you, and over to Vinay.
Thank you, sir. And the first talk for which the moderators, I would like to invite our Dr. Premashish Kar, who's the Director and HOD of Gastroenterology at Max Vaishali. Dr. Kaushal Madan, who's the Principal Director and Head of Clinical Hepatology at Max Hospital, Saket. And Dr. Anurag Govil, HOD of the Department of Gastro, Santopa Hospital. So a warm welcome to the moderators, and let us start the first session by Dr. Arun Sanyal on cholestatic liver disease. The introduction is up there for you, and yesterday we already introduced Dr. Sanyal.
Hello, my name is Dr. Arun Sanyal. It's a pleasure for me to talk to you about the Best of the Liver Meeting 2021, and specifically talk to you about cholestatic and autoimmune disorders. Here are my disclosures. So today what I'll discuss with you is some basic biology of cholestasis, mainly because I think this is an area where many practicing clinicians may not be very familiar or may remember, and it also helps understand some of the newer developments in this field. We'll talk about pediatric liver diseases with cholestasis, and then we'll talk about some adult liver diseases with cholestasis. So just a quick refresher. This is an electron microscopic picture of the liver, and as you can see, there are hepatocytes, and in between hepatocytes are the hepatic canaliculi. Now, on the basolateral membrane of the hepatocyte, you have a space of Dissay, and you have in this space cells such as the Kupffer cells and hepatic stellate cells. The vascular sinusoidal endothelium separates the sinusoid from the space of Dissay and is different from other endothelial cells by lacking a proper basement membrane, and because of it is normally fenestrated. And you can see fenestrations in some of these vessels at the upper part of this slide. Okay. Now, moving on to this cartoon, one of the critical mechanisms by which bile is formed is by the secretion of bile salts into the hepatic canaliculus. Bile salts are osmotically active, and when you secrete bile salts into the canaliculus, water is drawn from the sinusoids through the space of Dissay via paracellular mechanisms into the canaliculus to maintain osmotic equilibrium. And then this flows down into the biliary tree and intestine. Now, this bile, when it is released in the intestine, as it flows into the ileum, it binds to apical bile salt transporters. It is taken up into the enterocytes there, and through basolateral transporters such as OST, they're then put out into the circulation, where they go through the portal circulation back to the liver, and where they are taken up by an active process using a receptor called the NTCP receptor. And as it goes through the liver, the bile salt export protein again exports this back into the canaliculus, leading to enterohepatic circulation. Bile salts are also synthesized within the hepatocyte from cholesterol and represent the principal mechanism by which cholesterol can be excreted from the human, or utilized and excreted from the human body. Now, all of the bile salts are not reabsorbed in the ileum. A small amount is lost in the colon, where there is also a possibility of uptake. But in the net, about the daily bile acid loss per day in stool accounts for about 500 milligrams of cholesterol. So by definition, uh, this is a critical pathway that links cholesterol metabolism with bile salt metabolism. And as we have known historically, the implication of this, of course, are twofold. One, that bile salts are important for digestion, which we've known for many decades, but more recently appreciated that bile salts are important signaling molecules, because every time you have enterohepatic circulation, the bile salts tell the individual cells that there is food coming and allows the metabolic machinery to be reset. So the critical path in this whole system is the flow of bile into the canaliculus. And at the level of the canaliculus, there are a number of different transporters that not only excrete bile into the bile salts or bile acids into the lumen, but also other sterols, phospholipids, and bilirubin and other organic molecules. And they have specific receptors, such as the bile salt export protein for bile salts, or we also call them bile acids interchangeably frequently, but usually they occur as salts. Sterols, ABC, G5 and G8, the MDR3 for phospholipids, and MRP2 for bilirubin, etc. And so if you look at the composition of bile, it reflects all of these things that are secreted. And normally bilirubin is 1%, cholesterol is about 3%. There's about 7% proteins, and glutathione-related proteins are probably the greatest amount of protein in here. But bile acids are actually the greatest single component of bile and constitute about 40%, about 30 millimolar in early bile. So now cholestasis is really an impairment of the flow of bile, as the name implies. But we need to make a clinical distinction between bilirubinostasis, which is retention of bilirubin, and cholestasis, which is retention of bile salts. So bilirubinostasis you see under the microscope, where you have accumulated bilirubin. You can even have inspissated bile over here, and these are seen in chronic, often seen in conjunction with cholestasis, but can occur separately as well. Cholestasis has a very different picture. And you see over here that this is called feathery degeneration in the periportal areas. You see these hepatocytes where the cytoplasm is completely broken up and has this very feathery appearance. Now, the physiological consequences of cholestasis. Let's talk about that. So for practical purposes in our clinical practices, the most common reason cholestasis occurs is because of sepsis. We see it with alcoholic hepatitis. And then they are called primary cholestatic disorders, such as PBC, PSC, pediatric syndromes, etc. But the consequences of sepsis is this close link with inflammation, and which results in decreased bile flow or cholestasis. And you have a number of receptors that are involved in this. Decreased drug metabolism, bilirubin metabolism, changes in bile acid synthesis and metabolism, and general effects on lipid metabolism, leading to a number of problems. So one of the key things that occurs in this setting is that many of these canalicular transporters are then pulled back into the cytosol. So if you were to just take the cell tissue and crush it up, you would see the transporter there, but the transporter is not in the right place. So it cannot get its substrate across the membrane. And this leads to accumulation of bile salts, a number of sterols, causes broad disturbance of lipids, leading to accumulation of injurious lipids such as ceramides, sphingolipids, etc., and as well as bilirubin and bile salts, which can be cytotoxic, producing injury to the liver. So by not getting rid of all of the functionality of all these different receptors explains the clinical consequences of cholestasis. Now, of course, now we have a much deeper understanding at a molecular level of the exact transporters involved, where we know the bilirubin uptake involves OATP-B1, and at the canaliculus requires MRP2, and for bile salts, the basolateral uptake is through NTCP, canalicular uptake is through MSB, bile salt export protein. Cholesterol goes out through ABCG5 and G8, MDR3 for phosphocholine, and ATP8B1 for phosphatidylserine. And we've just talked about the impact of TNF, IL-6, and other drugs, which can impact these transporters and induce cholestasis. Now, very important, when bile flows into the canaliculus, the unconjugated bile salts can be taken up by the cholangiocyte and by a intrahepatic portal system goes back to the hepatocyte and undergoes this cholehepatic shunting. And so this functional element, which involves the hepatocyte and these cholangiocytes, has been referred to in the past as the cholion as well. And then, of course, once it gets to the intestine, many of the same transporters are involved. Remember, the ABCG5 and G8 is an important transporter because it gets rid of cholesterol from the body. And this is what's called reverse cholesterol transport. And the ABCA1 and others are involved in uptake of cholesterol. And then when bile acids are taken up, they release FGF19, which feeds back on the liver and shuts down bile acid synthesis. Cholestasis also causes oxidative stress and promotes inflammation, leading to accumulation of neutrophils, release of reactive oxygen species, activation of stellate cells, and which can then result in a fibrotic reaction. So that sort of is the broad pathogenesis of these cholestatic disorders and how they can lead to secondary injury to the hepatocytes and the liver and lead to inflammation, fibrosis. So in this setting, now let's talk about some of the newer findings. And unfortunately, there wasn't a huge amount at this AASLD that was really focused on cholestatic disorders. But I think this is an important one. So this is by Kirsten et al. And so this group has recently identified annexin A11 as a IgG4 IgG1 specific autoantigen in IgG4 related cholangitis, which, as you know, is a variant cholangitis that is linked to high IgG4. So what they did was they took human sham and annexin knockdown cholangiocytes and did extensive physiological measurements and studies over here. And what they found was that the knockdown led to reduced plasma expression of the chloride channel, but not the chloride bicarbonate exchangers. So as a result, you get rid of chloride and you get excess intracellular alkalinization. And this allows more bile acids, which are acids, unconjugated bile acids, to actually enter the cholangiocyte. And as you know, the bile acids can be quite toxic. So bottom line here is that these annexin A11 autoantibodies may further contribute to the pathogenesis of IgG4 related cholangitis by weakening this biliary bicarbonate umbrella. And so this is an important, I think, addition to our understanding of how bile acids relate to genesis of cholangitis and cholangitis related issues. The second study is from Zhao et al. And they focused on sphingolipids, and they looked basically in an animal model of sclerosing cholangitis called which is the MDR2 knockout mouse. Now you can argue whether this truly reflects human sclerosing cholangitis or not, but regardless, in this mouse model, they have accumulation of number of ceramides and release of ceramides from the liver into circulation. And they looked at the brain effects of this, and they found that a number of these ceramide transporters were significantly increased in the liver and brain. And these are actually known to be pro-inflammatory and pro-apoptotic. So they hypothesized that this may contribute to neurological dysfunction in severe cholestasis. Of course, some of this is a big jump of leap of faith. So I think I would take this with a grain of salt. And I think there's a lot more to be done here to really make the claims that these authors made. Now, moving on to specific pediatric liver diseases. Let's first talk about biliary atresia, which is an obliterative cholangiopathy resulting in presenting in neonates. It is the most common indication for liver transplant in children. And even if bile flow is reestablished by a Kasai hepatoportoenterostomy, most develop biliary cirrhosis and associated complications. So in this setting, again, there's a lot of unmet need to better understand the disease biology and to find therapeutics, because many of these kids end up needing a liver transplants. So over here, basically, they looked at the mechanism. This is a study by Kim et al., looking at the mechanisms of ciliary loss using patient-derived cholangiocyte organoids in biliary atresia. And so they took organoids from livers of normal donors and then from patients at the time of diagnosis or transplant with biliary atresia. And they looked at normal, and within the normal, they then used a retroviral infected rhesus rotavirus, infection model to injure the cholangiocytes. And this is a model where they develop a biological clinical phenotype very suggestive of biliary atresia with loss of biliary canaliculi, biliary channels. And so here what they find here basically is that there is a loss of apical cilia, and all of the genes involved in ciliary biology are impaired when this happens. And of course, this is shown over here. And so this is fairly extensively characterized over here. Now, of course, they conclude that this is what leads to the biliary loss. And this may be part of the story. I'm personally not fully convinced that this explains the entire story of how cholangiocytes get lost. Now, another probably clinically much more relevant and important paper is this one by Pandurangi et al. From the US Children's Network. So this is, I think, a very important network. They're doing phenomenal work in pediatric liver disease. And where they looked at the accuracy of matrix metalloproteinase 7, MMP7, as a biomarker of biliary atresia. Remember, we historically diagnosed biliary atresia only when, the children's urine basically was bile stained in the diaper. And then that raised a suspicion that is there biliary atresia. So frequently in general routine clinic places, people don't look for it. And sometimes if there's delayed diagnosis, you miss the opportunity to do the Kasai procedure because it works best if you catch it within the first 3 weeks. So there's a need for biomarkers. And so they looked at MMP7 and tried to identify an optimal cutoff. So they did a case control study of 400 cholestatic kids, 399 to be precise. And of these, 201 had biliary atresia, about 198 had other diseases, non-cholestatic diseases, non-biliary atresia cholestatic diseases. And they looked at MMP7. Okay. So MMP7 at this cutoff of 67 at the Youden index provided a sensitivity of 90%, specificity of 84%, with a positive predictive value of 71 and negative predictive value of 95%. So the positive predictive value was good, but not great, but the negative predictive value was quite good. And so in a baby who has cholestasis, has dark urine, a low MMP7 identifies that the child is relatively unlikely to have biliary atresia. I mean, I don't think this totally changes practice right now, but this is an important tool that can be added to the armamentarium of clinicians to evaluate someone with suspected biliary atresia. Now, Alagille syndrome is another pediatric disease, and this is an autosomal dominant disorder characterized by bile duct paucity, cholestasis, cardiac defects. You can see the characteristic facies and with eye abnormalities and vertebral abnormalities, and they're of course associated renal and vascular involvement. Now this is related to a JAG1 mutation in 94% and Notch2 mutation in 2%. So there is a large cohort of patients that are currently being followed in this global cohort called the GALA Clinical Research Database. Now, what happens in this population is that, again, there's bile acid-induced toxicity. So one of the approaches to treatment is to use an apical bile salt transporter inhibitor. So remember, the bile salt comes to the ileum, gets absorbed, and the apical bile salt transporter is important for its uptake. And if you block that, then you dump all that bile acid and you basically suck the bile acid out of the system. You reduce cholesterol, you reduce bile acid toxicity. And so maralixibat is a bile salt transporter inhibitor, and there's this longitudinal global cohort. They now have 6-year data with clinical outcome. This is a fantastic study, very important in the pediatric hepatology world. And this is showing, as you can see, this is a picture tells 1,000 words. I don't have to really describe it. You can clearly see that compared to population controls over here, without therapy in the GALA cohort who are followed over here, you are seeing a substantial improvement or decrease in clinical events. And I think this is going to become the standard of care for Alagille syndrome from a medical therapy point of view. Now let's moving on to adult diseases. There is this trinity of primary biliary cirrhosis, sclerosing cholangitis, and autoimmune hepatitis. There's a lot of work going on with the use of JAK inhibitors in autoimmune hepatitis. And so the question is now, can it work for other things? And this is an animal model, basically looking at an animal model of autoimmune cholangitis. This is the model, which is the ARE-DEL plus heterozygote mouse model of PBC. And over here, what they found is compared to control mice, portal inflammation and bile duct damage were reduced by a JAK1/2 inhibitor, ruxolitinib, and the data are shown over here where you see the compared to controls, there's a decrease in portal inflammation, decrease in bile duct injury. There is a decrease in the amount of AMA and splenic CD4 cells. So very early data, but let's see where this goes. Probably from a more practical element, we know that obeticholic acid, which is the FXR agonist, has been now approved and for therapy of PBC in select cases of URSO non-responders. Here's a long-term cohort called the POISE study, which is a safety long-term extension study compared to non-OCA treated controls from the global PBC and the UK PBC registries. And this is, I think, a very important study because it's got fairly large numbers. And what you see over here is a significant decrease in clinical outcomes, whether you do it with univariate COX, multivariate COX, or a weighted COX, basically showing that the hazard ratio for clinical events is decreased by almost 70 to 75% with OCA treatment. Very important because this is actually where the rubber meets the road. You're seeing decrease in clinical outcomes. So I think OCA's place in the treatment of PBC is solidified. So unless there are toxicity issues that come up in the future, this is the way to do it. A key thing to remember with OCA is that you have to keep an eye out, and if you think people are developing progressive disease, you need to dose adjust, especially if you think somebody has developed cirrhosis, so that you do not induce OCA-related hepatotoxicity. Unfortunately, not much with PSC, no major therapeutic or diagnostic breakthroughs, and much more remains to be done for patients with cholestatic liver diseases. This is an area which is ripe for additional work. We have focused a lot on viral hepatitis. We made a lot of progress there. We focused a lot on NASH, a lot going on in NASH. We need much more work and advances, in my view, for alcohol-induced liver disease. We're doing reasonably with end-stage liver disease, but much of it, I think the quality of the science in end-stage liver disease is modest, in my view, and could be much better and rigorous. And it is improving, thanks to the bar being raised by trials in viral hepatitis and now in NASH, both for diagnostic therapeutics and development of new disease paradigms. And anyway, I'll stop over here, and hopefully this has been clear. Look forward to any questions. Thank you.
Thank you. Very exciting talk. And now it's over to the moderators to ask any questions or clarify or their comments, please.
Yeah, Dr. Sanyal, I would like to know from you, which combination of drug therapy would you prefer for the treatment and management of intrahepatic cholestasis of pregnancy?
I have a feeling that Dr. Sanyal may not have joined us because I was trying to see if he has, but I have a feeling that he has not been able to join. So maybe we can have some brief discussion on with the experts who are already here on the panel.
I think Dr. Sareen can
Sir
help us.
can answer, yes.
Sorry, I didn't hear the question, Dr.
The question
Kar.
is, Sareen, we see many patients of intrahepatic cholestasis of pregnancy, and conventionally, most of these patients are being started on ursodeoxycholic acid therapy. Currently, there are many drugs which are helpful in relieving the cholestasis, relieving the itching. In your clinical practice, which combination of drug therapy, either do you prefer to give a single drug or a combination of drugs to relieve the itching in this condition?
Interestingly, the pathogenesis of itching in ICP is still unclear. Many people think it is high bile acid levels, but it is not really true. So I would be still conservative in just giving UDCA and sometimes opioid receptor agonist. Otherwise, no other drugs are, and of course, antihistaminic. There is a very recent paper called mastitis, M-A-S-T. Mastitis is increased mast cells, and people believe that it is the mast cells rather than the bile acids. So any drug which inhibits mast cells, and that was our generic antihistaminics, that can be tried. This came just November 2021, mastitis. So we can try that, but other than that, I think it's anecdotal.
Okay, thank you.
I think we can have some discussion on this because we have fortunately some time left. And may I invite the other moderators also to
yes, Dr. Kar, thank you, Dr. Thor, for that. I think it will be, we can take this opportunity to ask Dr. Sain another question. And he obviously has done extensive studies on COVID and liver right now. And I was kind of intrigued by cholestasis in COVID liver disorders, and especially a lot of these formulations, these Ayurvedic formulations or kada as we call it, giving rise to deep jaundice with all etiological negativities, and then eventually going and passing off only with stopping the kada. So I don't know if Dr. Sarin believes in this concept. And there are some reports from Calcutta. Sir, if you could please.
Yes, there are apprehensions of going public. Other than that, all these indigenous agents, especially the Giloy and others, they have huge, challenges, seminal injuries to the bile ducts, rapid rise in ALK phos, bile acids levels above 250 to 300. Very severe injuries due to these, especially in obese and overweight people. So during COVID, we have seen a surge of few hundred patients of this kind, biopsy proven. They also look like as if they are autoimmune hepatitis, but by and large, they are of this nature. So restriction, plasma exchange does help. Sorry, I have to leave due to an urgent call. Apologies. Vinay, please continue.
Yes, sir. Yes, sir. We will do that. Yeah, I think we can take a few minutes more of the discussion between the experts who are already here. Kaushal, any comments on these papers or you can share your experience on management of cholestatic hepatitis in our practice, because right now what we are seeing is extensively the physician segment is using obeticholic acid without rationale, and that is our problem. And some of them come back actually with itching because of the drug. So what is your experience in practice? Are you seeing more of this rampant use of this new molecule because it's being promoted as some wonder drug?
Right. So I think before I come to that, I think something which Dr. Sanyal also presented was sepsis-induced cholestasis. And I think in our clinical practice, it's very important to remember we are often called upon in ICUs or critical care settings to give opinion about deranged LFTs in patients admitted in medicine or other disciplines who have been having sepsis for a while. And I think it's important to remember that inflammation-induced or sepsis-induced cholestasis plays a very important role in these patients for causing deranged LFT, especially rise in alkaline phosphates and gamma GT. So I think that's a very important distinction we have to make when we in our clinical practice. Second issue, the question you raised about obeticholic acid, I agree. I think it's with the surge of this generic obeticholic acid being available in the market with almost 15 to 20 companies promoting it, to physicians also, I think, which has led to rampant use of obeticholic acid as a first line treatment for NASH, even if they do not have fibrosis. So I've seen many patients who come back, they just die being obeticholic. So that is the problem. I think it has been specifically advised that it should be used for patients with fibrosis, not amounting to cirrhosis. So I think that's a very important subgroup which we have to remember, wherein we should prescribe obeticholic acid.
Yeah, because now there is no label on the drug and it's so freely available, and sometimes the prescriber is not aware of what happens with the drug after its use. So I think any more comments from Dr. Kar and Dr. Anurag, any more comments from your side? What you practically see problem with cholestasis in your practice? I think we can take a few comments before we move on to the next session, because we are early today. So I think we have that luxury of extending our comment section.
So I would just add that yes, obeticholic acid, the cholestasis incidence is fair. I mean, even in clinical practice, we do come across patients who have been given obeticholic acid for maybe no reason, but they do come up with itching. And I have my reservation, because when it comes to using in cholestatic liver disorders, I don't have that kind of experience. Maybe Dr. Kaushal, Dr. Kar, or maybe you yourself can tell us better. Then what really happens when you use these drugs in cholestatic liver disorders in patients who already have itching? So there is a fair chance that they might symptomatically get worse, but the literature, of course, says otherwise. Dr. Kaushal, I mean, any comments on that?
So I think for NASH, the recommended doses are 10 milligram and 25 milligram. So if you start at 10 milligram at a lower dose, the incidence of cholestasis is much lower, and it's tolerable and controllable with antihistaminics and symptomatic treatment. Whereas in cholestatic disorders, the doses recommended are 5 milligram or 10 milligram. So if you start with 5, I think I haven't seen any PBC patients having worse itching because of 5 milligram dose of obeticholic acid, usually.
Right. And would you always give it after a liver biopsy, or you would make exceptions there?
No. So if a patient has NASH and advanced fibrosis on non-invasive testing, even then I can give it. So I think biopsy is not a must for starting obeticholic acid.
Right.
So there's this area of cirrhosis and Child's A and obeticholic acid, where some trials have been stopped, but some people are still using it on once a week or twice a week basis. But there's not enough data. Maybe it is just people feel that something is better than nothing. So that's also happening in practice. I don't know if it's a good practice or a bad practice. But I think that is something that we have to look forward to. I think the data is the key now to all new molecules and this whole. So I now take leave of all the moderators. Thank you for being here with us on a Sunday morning. Dr. Madan, Dr. Kar, Anurag, thank you very much. And then thanks again to Dr. Sanyal for giving us his second talk in this meeting. He's a very big man, very busy man, chairing so many NIH committees. And thank you, Dr. Sanyal, again. So we leave this session. Thank you very much.
Thank you.
Thank you. Thank you, sir.
So now, may I invite the moderators for the next session. Joy, I see you. You're already here. Dr. Joy Varghese, very dynamic transplant person, and he is at the Global Hospital as the head of the Department of Gastroenterology. And Dr. Chandan Kumar, also from Global, and Dr. Ramesh Kumar from the Osmania Hospital. And we have a great team here today to take us through Dr. Puneet Puri's talk. And Dr. Puneet Puri's is, of course, a very well-known figure. He has been in so many meetings in this country, both online and offline. And he is based in the University of Virginia, where he's done phenomenal work on a lot of areas of nutrition in liver disease. So his talk today is going to be on nutrition, sarcopenia, and frailty in liver disease, which we know is a major issue. It's a lot of therapies, including transplant. So let's hear it from Dr. Puri.
Good morning, everyone. First off, I would like to thank the organizing team and Professor Ian and Manisha and their group for this opportunity to provide some insights on recently concluded AASLD 2021 hot topics covering areas of nutrition, sarcopenia, and frailty. So I would like to highlight these three facets and connecting them from the pre-transplant to post-transplant outcomes and how these three factors, nutrition, sarcopenia, and frailty, are interrelated and impact care in patients with advanced liver disease and post-transplant. My first abstract is one from David Lee and group from Tufts. They looked at the clinical impact of malnutrition on post-procedural outcomes in patients undergoing varicose ligation. Main aim was to evaluate the clinical impact of malnutrition on post-ligation outcomes in patients with cirrhosis. They used a national inpatient sample ranging from 2011 to 2017. This was in hospital cases of varicose ligation therapy, and the primary exposure was presence of malnutrition, and they categorized the groups into malnutrition cohort and malnutrition absent cohort. The controls were matched to the cohort using 1-to-1 propensity score, and then the subgroup analysis was also performed assessing the impact of age in those that are greater than 50 years. The primary endpoint was mortality, length of stay, hospitalization cost, and post-procedural complication. This graph or this table shows the health outcomes in those that were malnourished versus the controls. Of note, although the age was statistically older people in those with the malnutrition cohort, but that was only a difference of 1 year. Overall, the mortality, as well as length of stay, hospitalization cost, and where the patients got discharged, all were severely impacted and statistically significant in patients that were malnourished compared to the controls based on the multivariate analysis. Also notable was the post-operative infection rates were significantly higher, almost double in those that were malnourished. However, the respiratory failure was comparable and not different. So they concluded that malnourished patients are at higher risk of developing post-procedural complications following endoscopic varicose ligation therapy. In particular, those that were over 50 remained at a higher risk for post-ligation mortality. So that tells us like a good opportunity to intervene and optimize nutritional status in patients who are at risk of developing varices and varicose bleeding to minimize these post-procedure complications and outcomes. The next abstract that I picked up was a controversial topic, whether to give or not to give total parenteral nutrition. And again, retrospective large data that evaluated the impact of total parenteral nutrition utilization in cirrhotic patients. And the aim was to determine how it may impact use of TPN, may impact mortality and development of complications in patients with cirrhosis compared to those without cirrhosis. And again, it was a national inpatient sample database, and those that received TPN between the years 2016 to 17 were assessed. The presence of cirrhosis or absence divided the two groups. Multivariate logistic regression analysis was conducted to adjust for the confounders. The authors found that overall nearly 450,000 patients were admitted and that received TPN between 2016 to 2017. Of these, about 4,500 had concomitant cirrhosis at the time of their diagnosis, and patients on TPN with cirrhosis were more likely to be white, older than 65. Their Charlson comorbidity score was greater than or equal to 3. Their primary insurance was almost primarily nearly 50% of those that received TPN were Medicare, and they lived in western part of the US in general. Also, the multivariate analysis showed that patients with cirrhosis had higher in-hospital mortality. Those that received TPN with an adjusted odds ratio of 1.2. The rates of complications as listed below, respiratory failure, hemodialysis, kidney, shock, major bleeding, etc., were all significantly higher in those subjects with cirrhosis that received TPN. Here is a Kaplan-Meier survival curve. The red one demonstrates those that had cirrhosis compared to the blue. Of note, the majority of deaths happened within the first 60 to 90 days, and the mortality was high odds of nearly 2.6 unadjusted, and for adjusted odds ratio, the mortality was about 28% higher in those that received parenteral nutrition compared to those that did not. Similarly, the odds of length of stay were higher in hospital in those that received parenteral nutrition with cirrhosis. Now, of note, the total healthcare charges and the hospital costs were not significantly different. So the authors concluded that in-hospital mortality is higher in patients with TPN that also had concomitant cirrhosis compared to those without cirrhosis. And most likely the mortality is going to occur within the first 60 days from admission. So they do suggest that when there is a decision to start TPN in cirrhotics, it should be carefully assessed for possible risks and benefits. And if TPN is started, close monitoring is paramount to prevent possible complications. The next abstract is covering the outcomes of protein-calorie malnutrition in inpatient liver transplant population. So generally, pre-transplant or in cirrhotics, a lot of data have existed. So this particular work focused on inpatient liver transplant population. Their aim was to determine the outcomes of protein-calorie malnutrition in those that have received a liver transplant. Again, they used the national readmission data, and the primary outcome was to study protein-calorie malnutrition in liver disease. They used multivariable model counting for all the major comorbid conditions, cause of liver disease, as well as the insurance type. So during 2010 to 2017, there were close to 350,000 liver transplant patients that were hospitalized. Out of these, 43,000 plus had diagnosis of protein calorie malnutrition. And this particular table describes about the impact of protein calorie malnutrition on inpatient liver transplant population. As noted, there is a 2.4-fold higher rate of inpatient mortality. Liver transplant complications were nearly 2-fold higher in those that were protein calorie malnutrition. Also, their ventilator use, length of stay, and hospital charges was significantly high in those with protein calorie malnutrition compared to without. And similarly, a 30-day readmission was also significantly high. So the median cost for liver transplant was nearly double, about 75,000, compared to those that did not have protein calorie malnutrition. Also, the median length of stay was almost more than double in those that had protein calorie malnutrition for 9 days compared to those without protein calorie malnutrition, which is 4 days. So they summarized that the protein calorie malnutrition in post-liver transplant patient was associated with higher mortality, higher rates of readmission, liver transplant-related complications, as well as higher healthcare utilization. Next work focuses on a very common population, which is non-alcoholic fatty liver disease. And this particular abstract was presented as an oral presentation that evaluates the effect of low carbohydrate intervention with nutritional ketosis and its impact on liver markers and a real world experience. As shown here, the NAFLD in the normal glucose tolerant population compared to both pre-diabetes and diabetes has a significant higher proportion compared to those without, with normal glucose tolerance. And as noted, diabetics are at significantly higher risk compared to the general population shown in the left, and those here with the right have the higher proportion of NAFLD as well as higher proportion of NASH and advanced fibrosis. AASLD guidelines on non-pharmacologic approaches highly emphasize on weight loss that has shown to improve both markers of steatosis on liver histology as well as markers of NASH and fibrosis, with the extent of weight loss up to 7 to 10% being most useful for showing improvement in histologic outcomes. Also, exercise and bariatric surgery are the mains, but this particular work focuses on diet intervention and weight loss. Their purpose was to evaluate the role of telemedicine clinic in its effectiveness in outpatient setting on improving the markers for fatty liver disease in the high-risk individuals. And they use this real-world data to evaluate outcomes such as ALT, AST, triglyceride, body weight changes, glycemic control, and hepatic steatosis and triglyceride to glucose indices to assess improvement in their intervention. Their model for care is Virta's continuous remote care platform, patient being the center. There are measures that they call biomarker tracking. There are resources to educate, to reinforce learning and compliance and adherence. Same way, there is a joint community of patients who are part of this group, so can brainstorm and serve as a support group to the individual. There are availability of health coach and a physician that directs and guides the health coach and the team to intervene in appropriate manner and resolve any of the issues that emerge as a result of the intervention. So the study design and the baseline characteristics include that there were over 1,500 patients, mainly over 55. Mean BMI was 35, mean weight and A1C are 7.6%. These patients were receiving low carbohydrate intervention at least for 1 year, and they have had liver enzyme measurements at least twice, one from baseline and one between 9 to 12 months or 9 to 15 months of dietary intervention. Demographics, baseline and follow-up lab data were retrospectively obtained from the medical records. The mean baseline ALT was 31 before starting intervention, and AST was 24, and alkaline phosphatase was 77. This is how they offer the nutrition guidance. The carbohydrate is the primary restricted macronutrient with goal of achieving nutritional ketosis with beta hydroxybutyrate levels measured. Generally, it remains under 30 to 50 grams of carbohydrates. It's highly personalized because they take into account the socioeconomic, cultural, and religious factors in devising the meal plan. They continue to get educated and troubleshoot their issues. It is not a meal delivery or replacement program, so that is trying to empower the patients to adapt to a new lifestyle change. They are encouraged to eat delicious real food until they are satisfied. There's no calorie counting emphasized during this study. These are some of the key measures related to NAFLD with changes in body weight. On the left, you can see those the weight loss category on the top, less than 3%, 3 to 5%, 5 to 7%, and greater than 7%. And on the rows, you're able to see that what's the proportion of patients. So nearly 65% or 2/3 lost 5% or greater weight. There was an incremental decline in their ALT level, which was most pronounced with those that had greater than 7%. So nearly 25% drop in their ALT from the baseline with greater than 7% weight loss. Similarly, about 20% would decline in AST with greater than 7% weight loss, but these findings were even notable as low as 3% or greater weight change. Similarly, the change in the triglyceride index was also more pronounced as they lost more percent body weight. And same things were reflected in changing the steatosis index, hepatic steatosis index, suggesting that greater the weight loss, greater are the benefits in all these matrices that are shown here. So they concluded that a virtual outpatient, very low carbohydrate intervention targeting reversal of type 2 diabetes and pre-diabetes regression also improved liver enzymes and non-invasive measures of NAFLD. The degree of improvement in liver markers was associated with the degree of weight loss. And the key takeaway from their study was that a very low carbohydrate intervention might be an alternative lifestyle option to consider for management of NAFLD. This telemedically delivered lifestyle intervention can be successfully implemented in an outpatient clinical setting to initiate and maintain AASLD recommended weight loss of 3 to 5% or 7 to 10% in patients with NAFLD. So next we switch gears from the nutrition piece to the sarcopenia and how it again correlates with facets in pre-transplant population to post-transplant. We'll try and cover those with some new emerging data on the pathophysiology mechanisms and molecular signatures and mechanism for sarcopenia are also covered. So my rationale for choosing this particular study, the bioimpedance spectroscopy, a bedside tool to assess sarcopenia in cirrhotic patients with ascites, largely stems from the fact that most of the current methods of assessing sarcopenia heavily rely on expensive radiology tools such as CT scan or MRI, which are not only expensive but are also limited in its availability to a vast population that do have cirrhosis and would greatly benefit with more accurate assessment of their body morphometry. So this particular study from combination of like Baylor and the University of Pittsburgh tries to utilize bioimpedance spectroscopy, which is a more portable and point of care test that can be easily executed in an outpatient setting and more repeatable, reproducible in longitudinal fashion on same individual. The main concern that most of the literature raises is the fluid load in ascites could be a potential deterrent to consider. What these investigators have shown in this particular abstract is that both pre-ascites, pre-paracentesis and post-paracentesis comparison of fat-free mass or fat mass or phase angle which has been studied in relation to the CT scan related skeletal muscle index. And they did not notice any significant change in all these three parameters before and after the paracentesis. And the changes that were noticed were marginal and insignificant, suggesting that the role of bioimpedance spectroscopy can be further investigated and utilized in clinical practice that will benefit the patients a lot more than relying on more expensive and limited resource radiology tools such as CT scan and MRI. So this was the bottom line for this particular one. Consolidating on the same principle, this study from Thailand, which is again illustrating the value of using bioelectrical impedance in a resource-constrained setting, that the hand grip strength and the bioelectrical analysis can help in the diagnosis of sarcopenia. They compared the skeletal muscle index by bioelectrical impedance to that of CT scan and noticed that there was a good correlation of 0.54. Similarly, the hand grip strength also strongly correlated with the skeletal muscle index with CT scan. So both these tests indicate that these could be useful in evaluating sarcopenia in patients with cirrhosis, at least in the resource-constrained setting. These data are from those that all actually have sarcopenia group, which is N of 30. In this total population, which is N of 50, when they correlated the hand grip strength with skeletal muscle index on CT scan, their correlation was highly positive of 0.81. So their diagnostic performance to predict the skeletal muscle index, which may be low and define sarcopenia, using the cutoffs by the Japanese Society of Hepatology, they had a good sensitivity of nearly 90% with a specificity of 100%, high positive predictive and negative predictive value, suggesting a very reliable tool. And they had a very similar performance, somewhat lower with the cutoffs that were used for the European Working Group for sarcopenia. So suggesting that a larger validation is in the order that may help further define the cutoffs in these patient population and allow more and more patients to be accurately evaluated and cared in the clinical setting in face of limited access to expensive tools such as CT scan or MRI. So switching gear to the CT scan based quantification of sarcopenic visceral obesity, I would like to highlight two work. First, showing that there is a poor transplant waitlist mortality in patients with cirrhosis that also have sarcopenic visceral obesity. This work from Jennifer Lyson group shows that of the patients that had the highest mortality are the ones that are shown in the solid lines, which indicate the sarcopenic visceral obesity. So these subjects have both sarcopenia with the skeletal muscle index less than 50 in men or less than 39 in women, as well as the visceral obesity that they describe as the cutoff. And the outcomes are otherwise comparable of the other categories, which are either non-sarcopenic or even sarcopenia, but without visceral obesity, had lower risk of mortality relative to those that had concomitant visceral obesity as well as sarcopenia together. When they looked at the predictors of death or delisting because of being too sick for liver transplant, none of the markers that are used in clinical care, including their comorbid condition or complications of portal hypertension, such as ascites, encephalopathy, or MELD sodium, they did not pan out to be of any guidance in the multivariable analysis predictor of death. Also notable here is that liver frailty index greater than 4.4 also did not demonstrate that prediction for death or delisting while these patients were waiting for liver transplant. Most notable was the body composition, specifically a combination of sarcopenia with visceral obesity that statistically predicted the odds of nearly threefold higher odds that these patients are at highest risk of either dying or being taken off of the list due to being too sick. So this again highlights the importance of like using tools that can stratify the risk and target the patient population that may most benefit by early intervention. So they concluded the sarcopenic visceral obesity is associated with increased waitlist mortality in patients with cirrhosis in ambulatory setting awaiting liver transplant. Also, concurrent loss of skeletal muscle and gain of adipose tissue, which is seen in sarcopenic visceral obesity, is quantified by CT, may be useful and objective tool to identify patients at risk for suboptimal transplant outcomes. Along the same lines, there was a work on a small cohort of about 30 patients that were transplanted for acute and chronic liver failure in the US from University of Maryland or George Washington area. That showed that sarcopenia is present in almost half of patients with ACLF. And when it is present, it is associated with longer pre-liver transplant ICU stay and increase in the post-liver transplant infections. In their cohort also, the patients with sarcopenic obesity had higher post-liver transplant resource utilization, such as length of stay in ICU, hemodialysis use, or tracheostomy. And also, these patients were less likely to survive post 1 year liver transplant. So objective measurement of sarcopenia and visceral obesity offers additional risk stratification in this patient population with acute and chronic liver failure, which are being considered for liver transplant. Now, moving on to the post-liver transplant, how sarcopenic visceral obesity is associated with, again, poor or increased post-liver transplant mortality in patients that were acutely ill with cirrhosis. This work is again coming from University of California, Jennifer Lai and their group, that sarcopenia in combination with visceral obesity is an ominous sign in patients with cirrhosis. And they again utilize the CT scan as highlighted earlier to measure the sarcopenic visceral obesity. And they defined that using skeletal muscle index and visceral to subcutaneous adipose tissue ratio, and examined its association with the post-transplant mortality. What they noted in over 100 patients that were transplanted, 66% being male and nearly 70% were non-Hispanic white, median age of 53, and the merit score at liver transplant was 32. The median post-transplant follow-up was over 5 years, and of these 116 patients, 34, which is a third of patients, died in those 5 years. The higher median visceral to subcutaneous ratio for the fat was seen both in men and women compared to those that survived, suggesting there was 60% and nearly 40% higher odds of dying if there was a higher median visceral to subcutaneous ratio for fat, although they did not show any statistical significance. The optimal cutoffs that they were able to obtain for visceral obesity were VSR of greater than 1.5 for men and greater than 0.53 for women. Shown here clearly that sarcopenic visceral obesity has worst outcome of cumulative about 40% risk of dying in 3 years in comparison to either non-visceral obesity or non-sarcopenic obesity, or even those with sarcopenia and visceral obesity, but not concomitant presence of the other counterpart. And the hazard ratio when adjusted was close to nearly 4 times higher, adjusting for age, sex, diabetes, encephalopathy, and liver cancer, suggesting that the pre-transplant sarcopenic visceral obesity also indicates poor outcome in the post-liver transplant setting. While it is believed that post-transplant, many of these things will reverse, but despite that, the mortality is high. So the authors concluded that sarcopenic visceral obesity is associated with increased post-transplant mortality in acutely ill patients with cirrhosis compared to patients with sarcopenia or visceral obesity alone. CT-based quantification can serve as an objective metric to identify obesity-related morphometric characteristics associated with post-transplant outcomes in acutely ill patients. Now, this study comes from India that looks for just not the skeletal muscle or sarcopenia, but also the presence of fat in the muscle. And they observed that decreased muscle to fat ratio is an independent predictor of advanced fibrosis in patients with non-alcoholic steatohepatitis or NASH. This work from Institute of Liver and Biliary Sciences presented by Pooja shows that in this cohort of 75 patients with NASH, with about 1/5 of them lean NASH and rest obese, about a third or nearly 60% had advanced fibrosis defined by a KPA of greater than 8 on LSM or FibroScan. And notably, those with advanced fibrosis had also higher control attenuation parameter, higher AST and ALT. So also the subcutaneous adipose tissue and total adipose tissues were higher in those with advanced fibrosis. Muscle mass was comparable in both advanced and non-advanced fibrosis. So what they noticed that if muscle to fat ratio was significantly higher in patients with advanced fibrosis, in stepwise backward logistic regression, they noticed that 0.005 was the independent factor associated with advanced fibrosis. In their area under the curves, MFR less than 0.75 had a decent sensitivity and specificity to be associated with more severe NASH. This needs more work in terms like area under the curve is modest 0.70. They concluded that NASH patients with advanced fibrosis have higher transaminases, they perform low physical activity, and they also have low muscle to fat ratio. Now, looking into some novel insights on the mechanisms of sarcopenia, work from Cleveland Clinic by Dr. Dasrathi and their group showed that there is cluster molecular response to hyperammonemia that mediates sarcopenia and cirrhosis with accelerated skeletal muscle senescence. They had previously shown that ammonia is a mediator of liver muscle axis and a causal factor in sarcopenia. Also, previous work had been evaluated about the role of hyperammonemia. So they tried to investigate the role of hyperammonemia in causing metabolic and molecular perturbations in skeletal muscle, but also the global alterations at the multiple layers. They call it the vertical integration, and across the models, which is cell, animal, and human, which they call as the horizontal integration. And that work is not known. So they use a multi-model, multi-omic, unbiased approach to experimentally validate and identify novel molecular interactions in the pathogenesis of sarcopenia. Here are the main results, that there were molecular responses that did show distinct clusters based on temporal responses. The mouse proteomics data said the major pathways that were enriched included the HIF1 alpha, apoptosis, and senescence signaling. And similarly, the mouse RNA-seq also showed that the differentially expressed genes with functional enrichment of calcium, death receptor, cell cycles regulation, and apoptosis signaling were the key signals. When they compared and merged and integrated vertically and horizontally the mouse muscle and human muscle data of differentially expressed genes, they shared enrichment of cell cycle regulation, senescence, HIF1, and oxidative stress pathways emerged. They also noticed that hyperammonemia increased the calcium flux, if alpha and P21 with unchanged in the cell viability PARP1 and the cleaved caspase-3 compared to the control myotubes. This is what they indicate by the vertical integration and the horizontal integration. The vertical integration is of data generation, variety of tools from the seq analysis, proteomics, then data analysis, data validation, and evolving into the novel targets. Those are all showing at different time points, different temporal associations, which is the vertical integration. The horizontal integration is the myotubes, the mouse, and the human with cirrhosis and control. So that is the summary of their main work, elegant presentation. The same group, again, further investigated the role of hyperammonemia-induced mitochondrial dysfunction causing skeletal muscle senescence and sarcopenia. And they also noticed that this is reversible by ammonia-lowering interventions. As noted earlier, ammonia is a cytotoxic metabolite and a mediator of the liver-muscle axis. They report that muscle hyperammonemia causes skeletal muscle mitochondrial oxidative dysfunction, which is a known mediator of post-mitotic senescence. They were determined if ammonia-induced mitochondrial dysfunction causes skeletal muscle senescence, and if ammonia lowering can reverse the senescence-associated molecular phenotype. So in main results here is the electron transport chain complexes and dysfunction in the complex 1, 4, and 3 in the electron acceptor site were noted with downregulated green and upregulated red. As can be seen here that when the ammonia was lowered, many of these greens were shifted, and then there are the change towards upregulation of many of these key mitochondrial pathways, suggesting that lowering of ammonia reverses the dysfunction that is happening at the level of mitochondria. These were the key two pathways, including some of the glycolysis, senescence pathway, and nerve-mediated oxidative stress response, combination of downregulated and upregulated. These were the key pathways that were changed and altered. In summary, they also did the same vertical and the horizontal assay, and then in vertical they did sample collection, and then intervention was L-ornithine and Lola with rifaximin, and multiple omic analysis and integrated platform were performed and then validated. And then they discovered novel target both at the mitochondrial function, the cell senescence, and the TC cycle intermediates. Another elegant work from Professor Daslati's lab. So in summary and conclusion, they said ammonia causes global perturbations in mitochondrial functional genes and its senescence marker. Hyperammonemia also induces a reversible mitochondrial dysfunction with senescence phenotype and molecular pattern in sarcopenia of liver disease. In summary, they concluded that ammonia is a mediator of skeletal muscle senescence, contributes to sarcopenia and cirrhosis, and ammonia-lowering therapies have the potential to reverse mitochondrial dysfunction-associated SAMP and sarcopenia and cirrhosis. Final segment was related to frailty, and I again wanted to highlight the role of frailty both in pre-transplant and post-transplant population, and with the focus how the measures of frailty can be implemented in an outpatient and setting and broader application for patient care. So this elegant work from Dr. Duarte's and group from Pittsburgh explores the novel way of developing a patient app utilizing the current challenges in COVID pandemic, where patient interaction and patient evaluation was somewhat limited. And this led to discovering of new ways and assessment of frailty in a transplant process. So what they really did was a very novel work. They developed an app that utilizes and integrates with the Fitbit. And with that app, they are able to develop the stride length in the liver transplant candidate. And those stride lengths were compared and validated to actual stride lengths compared, and there were no significant difference. It was a very high concordance of 0.85. And they also evaluated in this model the liver frailty index, height, albumin, and the large volume paracentesis, and developed that the patient, the mobile device wearing on the watch or the smartphone app can be actually very highly correlated with actual true measured 6-minute walk test, as shown in both these graphs. And when the liver frailty index is not available, the model had age, height, albumin, hemoglobin, and large volume paracentesis. This is the equation that they had for the model that performed equally well with a rho of 0.75, which was similar to the one where the liver frailty index was available of rho of 0.80. So Based on this test, they are able to propose that this can be further evaluated and validated in clinical setting, where estimating stride length in liver transplant candidates can remotely track frailty, and which is quite comparable to the 6-minute walk test. And this is utilizing the personal activity trackers. So there's a lot of potential. It needs validation, but very promising study. I thought this is worth bringing here. The other important aspect was how the pre-transplant frailty can still impact global functioning on health after liver transplant. And this multi-center functional assessment in liver transplant or frailty study from, again, Jennifer Lai and their group shows it's a multi-center study from around 8 of the centers. They used the SF-36 questionnaire and broke down into 2 big domains, the physical and the mental subdomains. And they compare that those with the frail, which is the dark boxes, compared to the white boxes, which are non-frail. There's almost all physical domains were significantly impacted with frailty. Post-transplant as well. So the pre-transplant frailty was determinant to their post-transplant global functioning outcome, mostly physical. None of those differences were observed statistically different in mental subdomains like emotional well-being or other measures. They also noted that in the activities of daily living compared to the frail versus non-frail, it was nearly double in 1 year post-transplant, which is quite concerning even after 1 year of transplant. And more concerning was that more than one ADL was observed. Difficulty in performing the activities of daily living was significantly higher in those that were frail at the time of transplant compared to those that were non-frail. So they concluded that the pre-liver transplant frailty was associated with worse physical functioning and health-related quality of life even 1 year after liver transplant. Presence of frailty after liver transplant was also associated with worse health-related quality of life, mostly physical but not mental. Their data suggests that interventions in therapeutics that target frailty, both pre and or early post-transplant, may help to improve the health and well-being of liver transplant recipients. Very interesting work and worth exploring further. Now, when frailty is being affected, could there be ways that this can be targeted and intervention be planned to minimize the impact of frailty, as we just saw even in the post-transplant setting? So this pilot data or study comes from the Northwestern group that they looked at the home-based liver frailty intervention or LIFT to decrease frailty in liver transplant candidates. Primarily, their goal was to evaluate the feasibility of the study, and they wanted to see whether there can be any waitlist or post-transplant mortality impact, frequency of hospitalization, duration of hospital admission. But in this pilot data, these measures are currently unavailable. What they noticed was that this liver frailty or LIFT intervention consisted of a physical therapist evaluation, including measurement of the liver frailty index, individualized home exercise prescription, exercise tracking using smartphone application, email reminders to exercise, and weekly telephone check-ins. Patients were also provided light dumbbells like 2-pound exercise bands and a home dynamometer or monthly remote LFI measurements. The primary outcome was to evaluate if there is any change in liver frailty index over time and adherence to the exercise regime. And it was considered to be good adherence if more than 50% of exercises were followed, and partially adherent if more than 20% of the exercises were performed. They noticed subtle improvement changes. Since it's a pilot study, data are not yet mature, but they concluded that LIFT, which is a home-based frailty intervention tool, is feasible and scalable intervention to decrease frailty in liver transplant candidates. Of course, further data are needed to determine if it improves pre and post liver transplant clinical outcomes. So similar work was performed in India. This was coming from the center in Chandigarh under Professor Veender Singh and their group. They looked at the two groups of patients that had standard medical therapy and compared that to standard medical therapy versus home-based nutrition therapy, intensive nutrition therapy. As shown here on the results section, one can clearly see that at 6 months, the data are the red boxes. There is a decrease in their liver frailty index, as well as the nutritional status. Key difference was the survival at 6 months, and they noted that group B, which was standard medical therapy, compared to group A, which was standard medical therapy with a home-based nutrition intervention, there was a significant improvement in survival at 6 months in those that received intervention in addition to standard therapy. So that summarizes my review of these three big things, and I hope you were able to grasp some of the key data that were presented, studies that showed the impact of nutrition in pre-transplant to post-transplant realm, similarly for sarcopenia and frailty, and some promising home-based interventions for frailty and sarcopenia that may evolve into key directions in the coming years. Thank you for your attention.
Thank you, Dr. Puri. And I believe there's a question from Dr. Jayanti, is the effect of diet on exercise on central visceral obesity. And is it possible to address that question?
So are you able to hear me? Thank you so much. So in relation to the data that were presented, I didn't see any specific intervention related outcome on the visceral obesity, but certainly like in our practice, we do see patients who undergo lifestyle and diet modification. One of the big changes is the visceral obesity with significantly preserved muscle mass.
Yeah. Any comments or questions to Dr. Puri from our moderators, because he's taken time out to be with us live from all the way from the US. So moderators, any questions, please, or any comments? Excellent talk. Thank you.
Yeah,
Thank you very much.
From Hyderabad Global Hospital. I want to thank Dr. Puri for the wonderful lecture on most important topic I feel in intervention in cirrhosis is nutrition and sarcopenia assessment and improvement of frailty, because it's a cirrhotic is a hypercatabolic state, and you're very nicely available. But what I could catch here is none of the studies have shown any interventions except for the lift intervention, which has been shown in the last part of improving sarcopenia. Whether we can combine nutrition with frailty improvement and the therapeutic interventions and see the translation in the outcomes in these patients, especially those who are waiting on the CADOR waiting list. Because most of the mortality in this CADOR waiting list is because of the lack of nutrition and the ongoing liver cirrhosis and the multiple complications and recurrent sepsis, which actually worsens the nutrition. So I think that is one area where we should concentrate on. And I would also like to thank you for the wonderful talk on fatty liver, the study from where you emphasize on the role of low carbohydrate diet and teleconsult by teleconsultation, we are monitoring the low carbohydrate diet, because I feel that is the most important intervention for fatty liver NASH. Then only come all the drugs in the therapeutic armamentarium.
Yeah, so thank you for the comments from the moderators. This session is behind time slightly, so we have to close. Thank you, Dr. Puri, for being live with us. And thank you, everyone, for joining us for this session. But we will move on now to the next session, which is the Deepak Amrapurkar oration. And sadly, he's no longer with us, a very close friend since my MBBS days. And for this, I would also invite the very esteemed panel of our course director, Dr. Sarin, who's the chair of the ILBS, and of course, he was the chair of um, the MCI, well awarded Padma Bhushan, and Dr. Y.K. Chawla, who's the chairman academics at KIMS, Bhubaneswar, also a very accomplished senior professor, and of course the director of PGI Chandigarh, and Dr. V.K. Dikshit, also a great academician who heads the Department of Gastroenterology at BHU. So, Sarin sir, over to you for this oration. Dr. Kim, of course, is a phenomenal figure with almost hundreds of research papers in areas of hepatitis C, NAFLD, transplantation, and he's based in Stanford.
Thank you, Vinay. With reverence to my dear friend Deepak, who is not with us today, but is loved, and it seems as if he is sitting next to us and watching and speaking for the conference. For Ray, it's an honor for us that Professor Ray Kim is joined and is giving Dr. Amrapurkar oration. It's a true tribute. Ray is a very accomplished clinician scientist who gave us the MELD sodium, and now he is bringing us the new generation of, I guess, MELD 3.0. So let's hear from Ray, and of course, I would like everyone to see how the journey of MELD has come up over the years in last 2 decades. Over to you, Vinay, for the oration.
Thank you. And as we have already introduced Dr. Ray for the Deepak Amrapurkar oration, so let us start with the slides, please.
I would like to begin by thanking Professor Sarin and Ms. Amarapurkar for giving me this opportunity to present today. I'm going to talk about MELD 3.0 as the latest update in the MELD score system. I would like to begin by historical background, Child-Turco-Pugh score, original MELD and MELD sodium scores as a historical background, and talk a little bit about unintended consequences of the MELD system as an organ allocation system. Then transition to how we developed MELD 3.0 score, its development, validation, and its characteristics, and end with some suggestions for further improvement of the MELD score, as well as lessons learned. I would like to begin with a proposal that, in my view, there are 3 categories of prognostic factors in liver cirrhosis. First is biochemical dysfunction. Liver as a biochemical organ. When it dysfunctions, you can detect that in the blood test. And obviously there's a portal hypertension associated with liver cirrhosis. And when these two are combined in the later stage of disease, you experience extrahepatic organ system dysfunction. So if you look at the individual parameters, biochemical dysfunction may be expressed by bilirubin and INR. Portal hypertension, hepatic venous pressure gradient, and extrahepatic organ systems may be represented by sarcopenia and frailty. And then there are some parameters that are in between, such as albumin reflecting biochemical dysfunction as well as extrahepatic organ systems. Encephalopathy and ascites may encompass all 3 dimensions, but maybe the first 2. And then sodium intersects between portal hypertension and extrahepatic organ systems as it reflects renal function as well as total sodium content. So the gold standard has been Child-Turco-Pugh score. It remains one today. And just showing you this paper from 1973 that showed this system, and includes two clinical parameters, hepatic encephalopathy and ascites, and as I just alluded to, it reflects portal hypertensive clinical complication side, whereas bilirubin, albumin, and prothrombin time represents biochemical dysfunction. And with the 3 points for each category, you get CTP class. Obviously, everybody knows class A is points 5 and 6, B 7 to 9, and C is 10 to 15. So this is well known. I'm going to come back to CTP score later in my talk, but I would like to acknowledge Professor Roger Williams, who passed away unfortunately last year, such a legend, and it is remarkable to realize that he was a senior author for this paper written in 1973, and maybe it's time for us to start calling this score Child-Turcotte-Williams score in honor of his achievements. Now, a little less than 30 years later, Patrick Hamath came up with the MEL score, and it started with a survival model to predict surviving elective TIPS procedure originally, that was then transformed into the famous MEL score, and I had the honor of assisting developing this score. And as you can see here, MEL score is based on the 3 laboratory parameters reflecting the biochemical dysfunction in terms of bilirubin and INR, and then serum creatinine reflecting extrahepatic organ system dysfunction. It doesn't capture the clinical or portal hypertensive complications of the clinical picture, as well as perhaps as Child-Pugh score. As we were devising MEL score, we had to get rid of the cause of cirrhosis that was originally included in the TIPS model. So that was the original MEL score. It worked was that you included creatinine, bilirubin, and INR into the equation, where creatinine originally was capped at 4 milligrams per deciliter, and you combine the score, and it produces a linear, beautifully linear relationship between MEL score and the risk of death. As MEL score increased, risk of death increased proportionately. Then a few years later, there was a recognition that serum sodium plays an important role in addition to MEL score in prognosticating these patients. And one peculiar thing with hyponatremia was that as MEL score increased, the importance of serum sodium decreased, and statistically this is called interaction. There is an effect modification occurring between MEL score and serum sodium level. So when the MEL score is really low, for example 6, hyponatremia at 125 adds as many as 13 points to the MEL score, leading to a total of 19. If the sodium is normal, then you get 0 points. And likewise, if MEL score is 40, even if your serum sodium is very low, you don't get extra points. So it's a bit complex relationship, but it recognizes that hyponatremia plays an important part in patients with lower MEL score. So taking advantage of that, we were able to produce a bit more accurate MEL score by including serum sodium. The MELD was incorporated into the organ allocation system in the US, and the effect was positive and fairly immediate. In 2002, the policy was implemented, and even before it was fully implemented, we could see the waiting time decreasing dramatically, because prior to that, organ allocation was based on waiting time, first come, first served basis. So many people with very low score went on the waiting list and ended up waiting for an organ for a long time. Now with MEL score, that was not necessary, and early listing practice went away, and there was a dramatic decrease in the waiting time. And waitlist mortality also decreased over time, but there are many factors that affect waitlist mortality, including disease epidemiology, competition for organs, and things like that. So the trend is less clear, but I'd like to believe that there was a positive impact on mortality in a significant fashion. So those were direct consequences of what we were expecting by utilizing accurate predictors of mortality in organ allocation. So we have more rational and efficient system to distributing organs to persons who need it most. Another effect that came up a bit later, that was recognized later, is MELD score became an equalizer between patients with different socioeconomic background. So in this paper, before MELD was implemented, Black patients had much higher risk of dying or being removed from transplant list for being too sick. So the ratio was 1.51, indicating that Black patients were 51% more likely to have adverse consequences of waitlisting compared to white individuals. Post-MELD score, it went away. The difference went away. And the reason for this is, again, in the prior time when access to healthcare system and being able to put yourself on the waiting list as early as possible, was an important predictor of what happens to you. But when MELD was implemented, it didn't really matter how you got there. Once you get there, the sickness was acknowledged. So that was without hepatocellular carcinoma. Same story with hepatocellular carcinoma here. Black people had higher risk of mortality. It became equalized after MELD score. If you look at the flip side of the probability of receiving a liver transplant, the reverse was true. Black patients were less likely, 25% less likely to receive an organ than a white candidate. That went away in the post-MELD era. In the hepatocellular carcinoma here, the difference was not significant, but overall the story is that this disadvantage of minority patients who had more difficult access to healthcare system, that went away by this objective measure of illness. So that is positive. But then there was an inadvertent effect of MELD score when it comes to male and female difference. In the same paper, when they looked at access to liver transplant and mortality, it was shown that before the MELD score implementation, male and female transplant candidates had equal chance of death. After MELD was implemented, the risk of death was 30% higher in women than in men. Before MELD score was implemented, the chance for women to get a transplant was 20% lower than men. After implementation, it went down to 0.7, 30% lower chance of receiving a transplant. And the data are replicated in our own paper. When you look at the transplant rate, males were higher. When you look at death, female was higher. And removal for being too sick to transplant, female line is on top of that of men. So this was an unintended consequence of MELD score disadvantaging women against men in terms of mortality risk and chance to receive a transplant. And why would that be? There may be a few explanations, but the most important one is how creatinine reflects renal function differently between men and women. This figure shows the gap between men and women, even if their GFR is the same. And if you focus on this lighter yellow area, you can see the gap is anywhere between 1.3 and 2.4, meaning that depending on where the GFR was, there was a 1.74, 2.4, that gap difference in MEL score, simply because women's creatinine was lower because of their smaller body size. So we ended up disadvantaging, taking away 1.3 to 2.3 points of MEL score from women, female candidates, than in men. So that was not a positive of the MEL score. So when we talk about how good a model is, there may be two dimensions where we address that. And the first construct is discrimination. And this is the ability of the model to rank patients according to the risk of death. For example, a patient with MELD of 20 should have consistently higher risk of death than one with MELD of 15. So that's accepted, but that's discrimination part of how good the model is. And this measure is important for organ allocation priority because you want to be able to rank patients correctly according to their risk of death. Calibration is another concept, and that addresses the ability to estimate the exact probability of death. So, for example, a model should have accuracy in terms of, for example, MELD of 20 having 90-day mortality of a certain number, 30%, not 70%. The model would be very useful if it can nail down the probability percentage accurately, not random. And this is not very important for ranking people, but it is important for patient management and counseling in being able to provide, okay, your prognosis is going to be 30%, not 70%, for example. So with that, if we look at the calibration part of the MEL sodium score, the blue bars here are the observed mortality. The red bar is predicted with sodium, and yellow is predicted with MELD sodium and MELD. And the x-axis is MEL sodium score, decile 1 being very low MEL sodium score, and decile 10, 32 and above. And this is the probability of death at 90 days. And you can see that as the decile goes up, as the MEL score goes up, the predicted and observed mortality goes up. And the point is that MEL sodium is better than MELD when you look across and observe that the red bars are closer to blue bars than yellow bars are close to blue bars. So that's point number one, and you can demonstrate that in these tall bars. And you can see that there is a discrepancy between what's observed and what's predicted for high MELD patients. And again, calibration is less important for organ allocation, but in high MELD patients, the MEL score tends to overestimate the risk of death than what is observed. And we'll come back to this point a little bit later. The second construct was discrimination. And this is ranking patients correctly. There are 4 lines here, and these 2 top lines are discrimination called concordance statistic for MEL scores, MELD and MEL sodium, and the dotted lines is everybody, including men. And here in 2005, in women, both scores had a concordance of about 0.87, meaning that if you have 2 random individuals and look at their MEL score, 87% of the time, the woman with higher MEL score had an earlier death than another person with a lower MELD score. So that's how you interpret this concordance statistic. But the point of this slide is that it seems that the concordance or the discrimination or the accuracy of the model seem to have decreased over time between 2005 and 2015. And the reason is not 100% clear, but the potential explanations may be that there is a disease epidemiology changing. As you know, as hepatitis C is more easily treatable these days, there are more patients with non-alcoholic fatty liver disease and alcoholic liver disease going on the waiting list and receiving transplants now than before. So there may be differences there, and that may be related to the fact that patients are older, especially fatty liver patients, and they have more comorbidity. And one big one might be chronic kidney disease, where they have higher levels of creatinine, whereas the creatinine that we think about in the context of the MELD score is more of acute kidney injury. So the relationship between creatinine and mortality may break down in patients with CKD as opposed to AKI. So those are the potential explanations. But because we have this seemingly decreasing accuracy of MELD score as a result of disease epidemiology change and inadvertent consequences of sex disparity in estimating mortality, we embarked on a new project trying to update our score using newer data and paying attention to the sex disparity. And to make the long story short, this is the final equation, and we have made a calculator that's online that's available at this location, and this paper just came out last month in Gastroenterology. So I will tell you how the score was developed now. That in updating MELD score with modern data, we used data from liver transplant registrants in the US between January 2016 and December 2018, 3 years of worth of data. We had 34,000 individuals. We excluded a number of patients, including exception cases, those that don't have end-stage liver disease, and patients who are multiple liver candidates or prior liver transplants. We ended up with 29,000 patients. We divided them in the 70-30 random split. We developed the model in the development cohort and validated the model in the second cohort. In the next few slides, I'm going to demonstrate the relationship between a particular variable and then the risk of death. So on the y-axis, we have a risk of death. On the x-axis is bilirubin in logarithmic scale. So we'll have to kind of imagine what the real number for that may be. And then here the continuous curve represents the main effect, and the dotted lines are confidence intervals, and here the what we call RUG underneath represents density of cases. So in the case of bilirubin, you can see that the relationship between log bilirubin and log risk of death is essentially very linear and reminiscent of the relationship with the MELD sodium data. But anyway, the bilirubin can be modeled with a linear concept. Similar with INR, a little bit more undulation, but pretty linear over a wide range of INR values. Creatinine is a little bit different, that there is a linear component at the beginning, but as creatinine goes up further, there is a ceiling. And what we determined was that it's about between somewhere 2.5 and 3 that the effect reaches a plateau, and we elected to take 3.0 as a new creatinine upper bound. And please recall that the prior MELD sodium had a creatinine cap of 4, and this may reflect the fact that the kidney injury in the new era may have a different connotation than in the previous era. This is sodium, and the effect of sodium is essentially unchanged compared to MEL sodium model. Albumin is a new element in our score, and it has an interesting shape that as you go down from normal range, the risk of death goes up. But having too high albumin is also not good for the patient, and we modeled the hyponatremic range, which is the more physiologic reflection of liver failure, between ranges of 1.5 and 3.5. There may be concerns about albumin in the transplant model because if low albumin gives higher MEL score and thus gives advantage for transplant, would physicians withhold albumin infusion when it is medically indicated? The answer to us is that in settings where albumin is beneficial, they are HRS or AKI or SBP patients, and albumin is mostly indicated when the serum creatinine is high. In our equation, I don't want to be too mathematically complicated, but because of the interaction here, the effect of albumin decreases as creatinine rises. So you notice the coefficients between albumin and albumin-creatinine interaction is almost exactly the same in opposite direction. So as the creatinine goes up, the albumin score decreases. And in fact, if the creatinine is greater than 2.8, the sign changes that low albumin actually starts lowering MEL sodium 3.0. So we didn't design it specifically with this effect in mind. This is what the data told us. So fortunately, if a patient is in need of albumin because of their AKI or SBP and their creatinine is high, it's actually in the patient's interest to receive albumin, not only from the medical outcome standpoint, but also because it will help the patient with increasing MEL score. So going back to discrimination, concordance statistics as we compare MEL sodium versus MEL 3.0. Herald versus UNO is just a technology, how you calculate the C statistics. And regardless of which methodology we use, MEL 3.0 has significantly higher concordance in both development and validation cohorts. And then we looked at the calibration. Now, we talked about the 90-day mortality in the MEL sodium calibration. We begin to realize that 90-day mortality is more or less irrelevant for patients with a really high MEL score. Most our patients receive organs with MEL scores higher than 30, and those patients either they make it in within a month or not, and 90-day mortality is not very helpful. So we focused on short-term mortality, 30-day mortality with this model, and we divided the patient into 5 deciles and compared the observed versus expected. The dotted lines are expected survival, and the stepwise Kaplan-Meier is observed survival. And you can see there is a close correlation between the two estimates and observed values. There is still a little bit of overestimation of mortality in the highest quintile, but much better than the overestimation that we saw with 90-day mortality. And I'm not showing you what would it be for MEL sodium, and we can refer to this in the paper that MEL 3.0 does better than MEL sodium in terms of calibration as well. So I just want to walk you through a few examples that at the first two I'm trying to demonstrate the effect of sex. So this is a mildly decompensated patient with bilirubin of 2.5, sodium 131, INR 1.0, creatinine 1.2, and albumin 3.8. So MELD is 12, MELD sodium is 18, and MELD 3.0 is 17 for the woman, and 16 for the men. So 1 point difference, and this is what's calculated to be the 30-day and 90-day mortality. Slight difference there. Then the second bunch is to demonstrate the difference in albumin, which is a new variable. So these examples are moderately advanced patients with a bilirubin of 6, sodium 131, INR 1.5, creatinine 1.5, one individual albumin 3.5, the other 2.2. Obviously, these scores are the same because of albumin not being part of those scores, but if you go to 3.0, 1 point difference between those two individuals. And then the most severe cases here, we show the effect of creatinine. Here 1.8 for this person and 2.8 in this situation. You can see the effect of creatinine on MELD 3.0 as well. So it progresses as you expect, and now with albumin and albumin and creatinine ceiling being lowered, you can see a little bit of a different feel than compared to MELD. So before we implement new scores into national policy, we have a great tool called LSAM, Liver Simulated Allocation Model, and we put through MIT 3.0. This is just one slide that show that in the simulation model, we will still see a difference in transplant rate between female and male candidates here, significant difference between the two. And then with MELD 3.0, the model suggests that there will be equalization to access to transplant. And we also considered no albumin 3.0 model based on the concerns for albumin, but we're going to go forward with MELD 3.0, and we are receiving input from the public to move forward with this policy, hopefully to be implemented in the next 12 to 18 months. In the last few minutes, I'd like to propose we might be able to modernize Child-Pugh score or Child-Turcotte-Williams score. I showed you this original version, but in order for this to be really, really accurate, you need to have two things. One is there needs to be equal weights between variables. So having 5 variables in this fashion, it assumes that all these five variables have equal weights. And then if you look on this side of it, these need to be equidistant between score categories. Otherwise, the impact of different scores will be different between different variables. So let me demonstrate that with real data here. And this is the same data that we used for MELD 3.0, and I showed you these figures. So if you plot where you get 1, 2, and 3 points for bilirubin, and this is where the thresholds are. So one can imagine this is 1 point, this is 2 point, a little bit higher, but then 3 is a very, very wide range, and depending on where you are, you don't get enough recognition for the high mortality associated with high bilirubin. That's point number 1, narrow and skewed window. And if you compare bilirubin and INR has a higher slope, and 1 point increase in bilirubin and INR has a different impact on the risk of mortality, but we treat them equally in the CTP score. And albumin, as I alluded to, is nonlinear, and the way the categories or the thresholds are set up, 1, 2, and 3 here, it doesn't really reflect the risk of death based on the modern data. Next, if you think about the clinical variables and laboratory variables having equal weights, this is an experiment that we did. looking at the biochemical aspect of CTP scores versus clinical aspect of the score. So bilirubin, albumin, INR is categorized as biochemical, ascites and hepatic encephalopathy as clinical, and we sort of subdivide the CTP scores. For example, CTP score 7b would be both extra points coming from biochemical parameters. 7c will be at least one coming from clinical variables. You recall that CTP score 5 and 6 are considered compensated cirrhosis, and they need to sort of aggregate together. But when we look at 6C and 6B, mortality is clearly different. And in fact, 6C and 7C aggregate with CTP score of 5, whereas 6B and 7B aggregates with 8C. So CTP scores driven from clinical extra points are much more benign than the same scores derived from biochemical abnormalities. So not all the scores are the same in the current format. When we did Cox regression, there's almost twofold difference between 6C and 6B, and again 7C and 7B. So not all CTP scores are created equal. So one way to deal with that is to introduce MEL 3.0 and add clinical variables in a Cox regression multivariable setting. And this is the result when we did that. MEL sodium, obviously a predictor, and ascites grade 3 came in 22% higher risk of death, hepatic encephalopathy grade 1 to 2, 14%, 3 and 4, 68%. We threw in age, try to maximize prediction, and when we did that, the C-statistical concordance increased from original CTP score, which was 0.77, to 8.2, 8.3, and finally 0.85, having all these variables. And one might cringe at the number of variables if you're a purist with parsimonious model, but we can get better results with the coverage with all these variables. And I would argue that having all these variables actually cover the whole gamut, not only biochemical, portal hypertension, but also extrahepatic organ systems. And as you know, there are more data, such as frailty and sarcopenia, that addresses this construct that may add to this equation as well. So I'd like to conclude by calling this precision hepatology. We talked about CTP score versus MEL score. MEL and MEL sodium traditionally has been well-validated objective predictor of mortality, but it had unintended consequence of sex disparity in liver transplant. In addition, epidemiological shift in liver disease in the US seems to have decreased the accuracy of the MEL sodium MEL scores. So we came up with MEL 3.0, which improves model fit, also addresses sex disparity. Now, overall, between black and white difference and men and women difference, these objective policy instruments, we're pleased to see that they contribute to social justice. We need more data and better analytic tool to improve our outcome predictions, and one example might be CTP variables being added to MEL 3.0, which improve the model still. One minor aspect of that might be we could still gain some mileage by introducing objective definition of ascites and encephalopathy, and that work still goes on. So that's what I have for you. Thank you very much for your attention. Happy to answer any questions. Thank you again.
Thanks, Ray. I would like to profusely thank you for this very complicated topic which you have made simple. And we all look forward to implementation of 3.0. I would like Dr. Chawla and others to take the discussion, but I have just one question. Normally, albumin below 2.5 in a cirrhotic is considered bad, but you want to put it between 1.5 to 3.5. Can you explain a little more that a low albumin is still beneficial for a transplant candidate?
Professor, again, thank you very much for the honor to be here. That's a very good question and a very complicated question. So, and the current standard for organ allocation doesn't think about the post-transplant outcome. The rule is about, can you identify who's going to die first? So your point is very well taken that patients with very low albumin may not do really well after the transplant. But if you look at the data, the curve that I showed you, we can demonstrate that there is almost linear pattern of mortality increase going from 3.5 to 1.5, which you think about, as you point out, is a very, very low number, 1.5. But the data, enough data are there to indicate that there is a linear increase in that part.
So we don't worry with 2.5. We just need to maintain other variables like creatinine and other things. Is that correct?
So that's the part where I sort of a struggle to explain where the creatinine and albumin interaction comes in. So patients who have low albumin and have complicated clinical picture, either HRS or SPP, and most of those patients have increased creatinine. So once the creatinine starts to go up, too low albumin penalizes the MEL score. So in that situation, giving albumin is the right answer and will preserve the MEL score at a higher level that reflects the clinical picture. I hope that makes sense.
Yeah, okay.
Wonderful, Professor Kim. Wonderful talk. Good seeing you. As I just posed a question to you, that sarcopenia is considered to be very important. You've also given an answer in the chat box. Is there any way that we can include sarcopenia in addition to what you mentioned, objective criteria for encephalopathy and ascites, which would make MELD even more accurate as a prognostic indicator?
Yes. As Dr. Puri expertly explained in the previous talk, measuring sarcopenia in an objective fashion requires complicated machine. It's either basically CT scan or he demonstrated bioimpedance machine, things like that. So if there's a widely available objective data set variables, we should include them. Well, our thinking is a little bit constrained because we're thinking about tools that could be utilized for organ allocation. And that means that it should be available 24 hours a day, regardless of where you are in rural settings and urban settings and things like that. So directly measure sarcopenia would be challenging in the near future, at least. But your points are pre-albumin type of laboratory variables has a potential to be included, but it needs to be obviously tested and validated.
Thank you. Thank you.
Yeah.
Thank you, Professor.
May I say something?
Of course, Dr.
Yeah. See, you know, the mortality, the waitlist mortality is very, very high in patients with ACLF as compared to the non-ACLF patients. And the factors which are important are the bilirubin, ILR, creatinine, then the ascites and encephalopathy. These are the factors which are different. So we'll have to go beyond MELD3. Not restricting only the creatinine, we'll have to look for, give importance to the ascites as well, then encephalopathy, then the sodium also plays an important role, and the most important is the MAP. We have to consider all these factors and improve this MELD to include all these features.
Yes, your point is very well taken, Professor Singh. all of those are, so that's why I try to take a step back at the beginning and have a comprehensive perspective of all the different components. And like MAP would be the third category of extra hepatic organ system function. So that would be very important. The goal of MELD is not to come up with the best predictor model. It is to come up with something that can be implemented on a system-wide basis. So we are going through a bit of a schizophrenic thinking process ourselves. Should we deliver the best possible model for all circumstance, or do we sort of preemptively constrain ourselves to something that that can be nationally implemented? So we may actually have a sort of a departure of the two different types of model, not to make things too complicated, but there needs to be a clear sort of a recognition that the purposes of the traditional MELD type of thinking is different than coming up with the very best, most accurate model, including ACLF patients. Your point is very well taken.
Thank you. Professor Kim, we had a really excellent oration. Like in the original MELD, as you said, in the US, there was a, because of a sex disparity, you modified it and now it is more relevant. Could be any difference in the rest of the world also? There is a sex disparity. Is it relevant to the other countries also as far the sex disparity is concerned, or is it just more relevant for the US?
So as far as I know, the relationship between the renal function and creatinine is altered by sex of the individual. So in my mind, it should not be affected by the race or ethnicity or location of the patient. It is inherent to the fact that given similar body size, females tend to have smaller muscle mass generating creatinine to generate the serum level. So that's the fundamental biological presumption. But your point is well taken that I would like to see the score being validated in many different parts of the world to make sure that that is the case. The other aspect that I didn't talk too much about is that women were disadvantaged because the body size, that too big a liver cannot go into a small woman, whereas a small liver can go into a large man. So women are disadvantaged along those lines as well. So they get a double whammy. They not only get low MELD score, but when their MELD score is up, the selection for organs is limited. So at least the new MELD score addresses the one part of that, and hopefully that will negate some of the differences.
Thank you.
Thank you, Dr. Kim, for being with us today live, and I thank all the moderators for this, for being with us for this excellent oration. Thank you very much. And now we have to move ahead to the next session. Thank you for being with us.
Thank you.
So I thank the audience for staying connected on this very nice Sunday morning. And because coming up now next is the talk on drug-induced liver disease, for which the moderators are going to be Dr. Deepak Agarwal from the Globe Medicare Lucknow, and he's the director there. Dr. Harshad Devar Bhavi is a consultant at St. John's, and Dr. Samir Parikh from Leelavati, Mumbai. So we have this talk on Delhi by Dr. Laurie Liv, and she is actually based in the University of Southern California, a very avid researcher and a lot of publications. So let us hear it from her.
I would like to thank Dr. Saran for my invitation to participate in Hot Topics at AASLD. My name is Laurie DeLev. I'm from the University of Southern California, and I'm president-elect of AASLD. The governing board of AASLD prioritizes disseminating the science of liver disease around the world, and I'm therefore delighted to participate in sharing research presented at TLMDX. The abstracts I'm about to share were chosen by the scientific reviewers of our scientific program committee as among the best submitted to TLMDX. The first one I would like to present is Abstract 221. This abstract comes from Korea and examines genetic risk factors for isoniazid, INH, inducing drug-induced liver disease, abbreviated DILI. They performed a genetic association analysis on 112 tuberculosis patients, 35 with DILI and 77 controls, by sequencing 403 pharmacokinetic and pharmacodynamic genes and 1,000 ancestry-matched population controls from the Korea 1K database. The identified high-risk genotypes were validated in a replication cohort of 155 participants, 27 with DILI and 128 controls. They also performed in vitro studies in HepG2 wild type cells. HepG2 is a cancer cell line, and in a cell line knockdown for ATP7B, which is one of the genes they identified as a genetic risk factor. We turn to the findings. The N-acetyltransferase 2, or NAT2, ultra-slow acetylator homozygotes had an increased risk of INH hepatotoxicity with an odds ratio of 5.6. This risk for ultra-slow acetylator genotype was first reported a few years ago. What is new is that the co-occurrence of NAT2 ultra-slow acetylation with homozygotes for a copper transporter loss-of-function genotype ATP7B mutation amplified the risk of INH hepatotoxicity with an odds ratio of 32.5. In vitro experiments confirmed the potentiated toxicity of copper and INH in HepG2 cells with a 3,500-fold increase in hepatotoxicity in HepG2 cells with co-occurrence of ATP7B 832RR mutation with NAT2 ultra-slow acetylator genotype. The population frequencies of both this ATP7B 832RR and NAT2 UA were well correlated with the globally reported incidence of INH-induced DILI, providing genetic epidemiological confirmation. During the presentation, Michael Shilsky, who was an expert on Wilson's and on copper, pointed out during the discussion that heterozygosity for ATP7B mutation is not rare, but biochemically hard to detect, and wondered whether it would be worthwhile screening for ATP7B heterozygotes prior to INH therapy. Abstract 1201 comes from the groups of Raul Andrade and Isabel Lucena in Spain, and is the first of two abstracts on the microbiome in DILI I would like to review. The premise is that gut microbiota alter drug metabolism and the immune system and may play a role in DILI. They compared the gut microbiome in patients with DILI, non-DILI-induced acute liver injury, and healthy controls. As you can see in the top right of the slide, the Chow Richness Index, which is a measure of diversity, shows decreased bacterial diversity in patients with DILI that was significantly different from healthy controls. The Simpson Diversity Index also shows significant difference among the three groups, but only acute liver injury was significantly different from healthy controls. The colored bars in the middle of the slide provide a wealth of information about differences in specific families and genera in the three groups, but at this point I don't know what to do with the information. The authors conclude that the gut microbiota in DILI differs from healthy controls, but is less different than that of patients with acute liver injury. The similarities in DILI and acute liver injury include several families and genera involved in maintenance and overall gut function, but there's no information in the abstract to support that statement. Abstract 1229 from University of Pennsylvania also examines the gut microbiota in DILI. They note that hepatic P450 and phase 2 enzymes differ between germ-free and conventionally housed mice, and also that a high-fat diet may increase P450-2E1, although published data have been inconsistent. This abstract characterizes the impact of the gut microbiota and its interaction with diet on carbon tetrachloride hepatotoxicity. Of note, carbon tetrachloride is metabolically activated by P452E1 to the trichloromethyl radical, and detoxification occurs by glutathione conjugation. Mice were fed either a normal fat diet or a high-fat diet, 2 non-absorbable antibiotics in the drinking water, and carbon tetrachloride either once as a model for acute injury or twice weekly over time as a chronic injury model. What were the findings? In the top middle, panels A and B show ALT and AST are highest in mice given a single dose of carbon tetrachloride plus a high-fat diet and antibiotics. And panel C shows the greatest injury in that same group. Panel D shows decreased survival in the chronic model of carbon tetrachloride given twice weekly with high-fat diet plus antibiotics. In the bottom middle panel, you see that CYP2E1 gene expression is increased by antibiotics and a high-fat diet, but gene expression of GCLC, the rate-limiting enzyme in glutathione synthesis, is unchanged. The findings show that the gut microbiota and a high-fat diet act synergistically to augment CYP2E1 expression and enhance carbon tetrachloride-induced DILI. Abstract 1206 comes from Nagachalasani's group at Indiana University and looks at dietary supplement-induced liver failure over the last 26 years in the US. I'm not sure this is directly applicable to an Indian audience, but perhaps there are some nuggets of information of use to you. They examined waitlisted patients between 1995 and 2020 using data from UNOS, which is the organization that manages the U.S. organ transplantation system. They specifically looked at patients with drug-induced acute liver failure, abbreviated DIALF on the slide. Of note, using the same approach for 1990 to 2006, herbs and supplements only accounted for 0.5 to 1.8% of all drug-induced acute liver failure not due to paracetamol. They looked at the waitlisted patients in UNOS between 1995 and 2020, excluding patients with cirrhosis and drug-induced liver failure due to paracetamol, and looked specifically at herbal and dietary supplements. What were their findings? 2,146 individuals were identified. Table 1 shows fewer pediatric patients and more male patients. In the bottom half of Table 1, you can see that antimicrobials were the most common of the non-paracetamol agents, and there was a decline in frequency of antiepileptics, propylthiouracil, and mushroom poisoning over time. Herbal and dietary supplements increased from 3% to 24% of all non-paracetamol cases of drug-induced acute liver failure, a dramatic increase. Figure 1 shows that 5-year post-liver transplantation survival improved over the 3 time periods indicated by the 3 lines in both paracetamol and non-paracetamol drug-induced acute liver failure. This abstract notes a decline in frequency due to antiepileptics. The next 2 abstracts I will review looks at this more in depth. Abstract 1199 is from an NIH-funded multi-center group called DILIN, the Drug-Induced Liver Injury Network. The first author on this abstract is Nagachalasani, who is the senior author on the abstract I just presented. The study examines the key clinical characteristics and outcomes of patients with liver injury due to antiepileptics enrolled in the DILIN prospective study over the last 20 years. They have predefined eligibility criteria for enrollment and undergo structured evaluation at baseline and at 6 months or longer. Causality and severity are adjudicated in a systematic fashion, it says. I assume that means they have a standard protocol for doing this. Between 2004 and 2020, 2,286 patients were enrolled, and 1,711 of these were adjudicated a definite, highly likely, or probable DILI. Among the 1,711 patients, 66 patients, or 3.86%, had DILI due to antiepileptics, 18 due to lamotrigine, 16 due to phenytoin, 11 due to carbamazepine, 10 due to valproate, 4 due to gabapentin, and 7 others. The authors state that the frequency of DILI decreased over time and show a helpful line in Figure 1. Although the p-value is 0.701, you will see that the second and fourth gray bar in Figure 1 are the same. When I see this, I would say that the frequency was higher from 2004 to 2007, but I don't see a trend from 2008 on. Lamotrigine and phenytoin are the most common causes of antiepileptic DILI, but we don't have a denominator to assess number of prescriptions to know whether the risk with either lamotrigine or phenytoin is higher than with other antiepileptics. They state that 60% of cases occurred after a rapid dose increase, but provide no data to show this. Liver injury was moderate or severe in the majority, and 3 individuals required liver transplantation. Fever, rash, and eosinophilia were more common with antiepileptics than with DILI from other drugs. Outcomes such as death, liver transplantation, and chronic DILI were similar between DILI from antiepileptics and other drugs. Abstract 1221 is a collaboration between Einar Bjornsson's group in Iceland and Naga Chalasani's group at Indiana University, and it is again a look at antiepileptics. In this abstract, they note that 18 new antiepileptics have been approved in the US over the last quarter century, and all but one have a lower risk of DILI, as indicated by the US liver tox DILI likelihood score. What is that? Well, Jay Hoofnagel from NIH is the senior editor and primary author of a website called livertox.nih.gov. And in the US, LiverTox is considered a key resource in the area of DILI. I use it all the time. This abstract look at LiverTox, that website's DILI likelihood scores for 31 antiepileptics marketed in the US. These LiverTox likelihood scores are based on the literature. Category A is well-known, well-described, and well-reported. Category B is known or highly likely. Category C is probably linked to DILI. D is possible, based on fewer than 3 case reports, and E is not believed or unlikely. So the likelihood scores are based on the literature. Lipophilicity, reactive metabolite generation, and daily dose for each drug were collected from the published literature. On the bottom left of the slide, you will see the dose-based DILI score and a reference to this score, that is, to the pharmacological score. The authors examined the relationship between the DILI risk score, that is based on the pharmacology of the drug in question, and the LiverTox DILI likelihood score. At the top of the slide, under the title Results, you can see the distribution of LiverTox DILI likelihood score for the 31 antiepileptic drugs currently on the US market. Regrettably, the abstract never provides the name of these 31 drugs. Exact logistic regression shows no correlation between likelihood scores and DILI risk across categories A through E. However, when the DILI risk score, based on the pharmacological features of drugs in category A, which you will call is drugs with well-known, well-described toxicity, were compared with category E, which is unlikely, the odds ratio is 3.6. Similarly, when anti-epileptic drugs in category A were compared by exact logistic regression with categories B through E, the DILI score predicted the odds to increase 3.6 times per unit increase in DILI risk score. The conclusion is that lipophilicity, daily dose, and formation of reactive metabolites increases the risk for liver injury by anti-epileptic drugs. This is perhaps predictable, but it's good to actually have data on this. Abstract 1220 is a Japanese study that looks at the clinical features and histological findings of immune-mediated hepatotoxicity, abbreviated as IMH on the slide, in Japanese patients treated by immune checkpoint inhibitors, abbreviated ICI, for solid malignancies. This is a single-center study on the onset and characteristics of immune-mediated hepatotoxicity among 344 Japanese patients who received immune checkpoint inhibitors. 21% of the 344 patients had pre-existing autoimmune diseases. The pie chart on the bottom left of the slide is probably too small for you to read, but shows the type of cancers. 45% of the patients had lung cancer, and other parts of the pie show patients with head and neck cancer and melanoma as the largest sections of the pie, next largest sections of the pie. The major immune checkpoint inhibitor used was anti-PD-1, PD-L1 monotherapy in 327 cases, but 7 cases were anti-CTLA-4 monotherapy, and 2 cases were anti-PD-1, anti-CTLA-4 combination therapy. At the top of the slide, under results, the table shows that 9.6% of patients had immune-mediated hepatotoxicity greater than or equal to grade 2. The median time to onset of immune-mediated hepatotoxicity was 40 days, and median number of doses was 2. 55% of liver injury was cholestatic, 36% was hepatocellular, and 3% was mixed. In the multivariate analysis shown in the table in the upper right corner, history of immune checkpoint inhibitor therapy had a hazard ratio of 6.4. Combination immune checkpoint inhibitor therapy had a hazard ratio of 3.6, and pre-existing autoimmune disease had a hazard ratio of 4.2, and were all independently associated with immune-mediated hepatotoxicity. Anti-nuclear antibodies and serum IgG were not associated with immune-mediated hepatotoxicity. Immunofluorescence staining in the middle of the bottom of the slide shows mainly CD8 T lymphocytes in the second column, and in the third column you can see that they stain for granulysin, suggesting a cytotoxic phenotype. The survival curves on the bottom right of the slide show that patients who experience any type of immune-related adverse event had significantly longer overall survival, but there was no significant difference in overall survival due to immune-mediated hepatotoxicity. In conclusion, in this Japanese cohort, immune-mediated hepatotoxicity was higher in patients with pre-existing autoimmune disease. Histologically, CD8 positive T lymphocytes seem to be involved in the development of liver injury. The increased risk of immune-mediated hepatotoxicity due to pre-existing autoimmune disease suggests an immunological mechanism underlying immune checkpoint inhibitor hepatotoxicity. The final abstract I would like to present is abstract 1200 from the Dillon study, which I mentioned earlier is an NIH-funded multi-center study on DILI. This study examines the clinical features, liver histology, and outcomes of 105 patients with sulfonamide hepatotoxicity. The cases reviewed were ones adjudicated as definite, highly likely, and probable, and that were enrolled in the Dillon Perspective and in retrospective studies between 2004 and 2021. Liver histology, when available, was centrally reviewed by David Kleiner. As you can see in the bottom left, 93 cases were due to trimethoprim sulfamethoxazole, 9 due to sulfasalazine, 2 due to dapsone, and 1 due to sulfadiazine. The abstract states, but it is not shown in the slide, that the median age of the trimethoprim sulfa cases was 48, with 7.6% of cases occurring in individuals under the age of 18, and 52% of cases occurring in females. The median drug latency was only 20 days. The median ALT at DILI onset was 381, and alkaline phosphatase was 258. 76% of patients were jaundiced, 24% had peripheral eosinophilia, and 47% had a rash. The most interesting data to me are shown in figure 1 on the bottom. This figure shows the liver injury pattern by age. Individuals under 18 were much more likely to present with hepatocellular injury, whereas individuals with increasing age, there was a shift towards cholestatic injury. In individuals over 60, cholestatic injury became the most common presentation. The third column of the slide shows a table concerning steroid therapy in patients treated with trimethoprim sulfa. Patients giving steroids were significantly more likely to be female, have a rash, have a higher initial INR and peak ALT compared to untreated controls matched by initial bilirubin levels. The steroid-treated patients had a more rapid rise of ALT, bilirubin, and alkaline phosphatase improvement, so more rapid improvement, but are also more likely to die, namely 22% in the steroid-treated versus 0% in the untreated. Under that table, the text states that 12 cases due to other sulfonamides had a longer median latency, 75% hepatocellular injury, and none required liver transplantation or died. In conclusion, trimethoprim sulfamethoxazole is characterized by short latency, frequent immunoallergic features, and potentially severe outcome. 1/3 of patients overall had a hepatocellular pattern, and this pattern was more common in younger patients and with more severe disease. Thank you, and I'll be happy to take questions.
Thank you, Dr. Laurie, and thank you for being with us live to answer the questions. Are you there, Dr. Laurie?
Yes, I'm here.
Okay, yeah, thank you. So one of the questions right away is, what is the role of bile acids in the pathogenesis, co-pathogenesis of DILI? Another question is, sometimes if the diagnosis is obscure, where would you position liver biopsy in the diagnosis of DILI? The patient may not always remember the drug.
Both excellent questions. I think the role of bile acids is something that we think occurs in cholestatic liver injury. Don't know. Mainly, we tend to think of it as drugs that impair bile acid transport, and so the mechanism of toxicity and the hepatocyte in particular is thought to be related to bile acids. So that's why drug companies look for inhibition of bile acid transporters when they're developing drugs. Your second question is liver biopsy. And that's, I think most of us would think that there rarely is a reason to do a liver biopsy to diagnose drug-induced liver disease. You can find a pathological picture, but it really doesn't narrow down what drug it is. And I think most of us would say it really doesn't play a role.
We have the very eminent panel here. Does the panel have any questions or any comments? Because she's joined us on a Saturday evening from California. So I think let's make the most of this opportunity. The panel, please.
Yeah, thank you for giving me the opportunity to ask questions. Dr. Dilevi, thank you very much for the excellent talk. And I also enjoyed your talk on sinusoidal obstruction syndrome at the AASLD.
I really thank you.
Although it was quite late in India when I watched it. So my more of a comment than a question, and that is that when you give these patients drugs for...
I'm losing sound.
And there are good studies that show that gut microbiota can be altered by the drugs that you take. So that is why I think Raul Andrade's study did not find a difference between patients who took the drugs and versus those who did not take the drugs. They, in fact, even did not find the difference between those who developed liver injury with drugs versus those people who took the drugs but did not develop liver injury.
I'm sorry, I lost your sound during part of this. I'm not quite sure. You said it was a comment, not a question.
Yeah, I was saying that drugs themselves can alter the microbiota.
Yes.
And one of the reasons Raul Andrade's study did not show a difference between people who took the drugs and developed liver injury versus those who took the drug and did not develop liver injury, and they compared this group with those who did not, those who were normal controls, who never were exposed to drugs.
Right. Yes, your point is well taken. I have nothing to add. You're absolutely right.
Do we have any questions? Any more questions? There are no questions in the chat box.
I have one question more.
Absolutely.
And Dr. Divili, you rightly mentioned about the Dillon group study about the denominator being absent from when compared to the numerator. And we have, in India, we use this first generation anti-epileptic drugs all the time. They are more than 100 years old, some of them. They're extremely cheap, and you have an excellent safety profile. That's when you see the large and millions of doses that have been taken. So, although I now understand that there are some studies in the US where they are more and more using the second generation drugs, but I think the first generation drugs, at least in developing countries, will always hold forth.
Yeah. I think that was the point I was making when, I like your cat. I think that was the point I was making, that you can say that there's a decreased incidence, but your point is exactly right. If the denominator is higher in the older drugs or is lower in the older drugs, now people are moving to the newer drugs, you're going to see a shift in incidence. So, fewer new drugs being used, lower incidence.
So I think there are no more questions. And thank you, Dr. Laurie, for being with us. Have a great weekend and stay safe. Thank you.
Thank you. I'll actually be back for another talk in a couple hours.
Oh, yeah, I know that. Thank you. So now we take leave of this session and move on to the next session. And that, again, is going to be by Dr. Kim Ray. We know he's a very eminent hepatologist based in Stanford. And we have already heard him during the oration. For those who have joined us now, he has just finished the Deepak Amrapurkar oration sometime back. And on the panel for this complications of portal hypertension update will be Dr. Ramesh Rupray and Dr. Virendra Singh. Dr. Ramesh Rupray was the head of the department at SMS and is based at Fortis, and Dr. Virendra Singh, of course, professor and head of hepatology at PGI Chandigarh. So let's have the talk, please.
Good morning. I would like to thank again Professor Sarin and the organizers for giving me the opportunity to address you this morning. My topic here is portal hypertension, an update from the recent liver meeting. What I would like to do is to give you a brief review of the new AASLD guidance for ascites, SBP, and hepatorenal syndrome. Then summarize a number of TLM, our liver meeting abstracts, and in the categories of ascites and albumin use, hypertension in non-alcoholic fatty liver patients, some comments on sarcopenia, and end with palliative care. And I'd like to summarize the new information by a few take-home points. So this is the new guidance document that just came out this year. I had the privilege of leading this group of leading investigators and thought leaders. And we summarized the diagnosis, evaluation, and management of ascites, spontaneous bacterial peritonitis, and hepatorenal syndrome. This is an update from the most recent version, which was 2012. So a lot of updating occurred with this. Why don't we take a step way back and talk about pathophysiology at the beginning. There are three key things that start this disease pathophysiology process. And the central thing is splanchnic vasodilatation. And that with portal hypertension and bacterial translocation from the gut completes the picture. With a number of reasons that occurs with endothelial dysfunction and shear stress in the vascular space, splanchnic vasodilatation in patients with liver cirrhosis and hepatic decompensation leads to arterial underfilling, and the body senses that there is not enough circulating volume and inactivates vasoconstrictor and antidiuretic factors. The first effect of that is sort of a shock response. The body conserves sodium, and sodium is retained. Plasma volume is expanded, which is the intended consequence of that reaction. And then when that's combined with increased lymph formation from sinusoidal pressure as a result of portal hypertension, you get ascites in the abdomen. On the other side of the graph, you have renal hypoperfusion as a result of intense vasoconstriction locally. When that is combined with bacterial translocation and systemic inflammation as a result of cytokine activation and so forth, you get hepatorenal syndrome. In the middle is, again, volume response. The body tries to conserve water by increasing aquaporin 2 expression. You get dilutional hyponatremia. So these are important and cardinal complications of cirrhosis and hepatic decompensation: ascites, dilutional hyponatremia, hepatorenal syndrome, and spontaneous infections. The first part of the guidance, we talk about assessment and management of ascites, and we try to operationalize the definition of how ascites is to be evaluated, and we simply state grade 1, 2, and 3. Grade 1 is the kind of ascites that is only detectable by ultrasound, and we don't do anything with that because there's no evidence that treating that degree of ascites really helps anything in terms of long-term outcome. Grade 3 is marked distension, symptomatic ascites that requires large volume paracentesis. So that is the mainstay. Large volume paracentesis is the mainstay for medical management of grade 3 ascites, and once the volume is decreased, you may transition to medical management, including salt restriction and diuretics, which is the main tool for grade 2 ascites, which is everything in between grade 1 and grade 3. You would want to do sodium restriction less than 2 grams per day, and diuretics, spironolactone with or without furosemide. You need to monitor weight and electrolytes in the blood. Weight loss goal will be 1 kilogram per day for patients with edema, less than that 0.5 with those without edema. So that's all you're familiar with. Now take a step forward. Refractory ascites is more difficult to control, and this is ascites that cannot be mobilized or early recur that cannot be prevented. There are two kinds of refractory ascites: diuretic resistant, and that is lack of response to sodium restriction and maximal doses of diuretic treatment, whereas diuretic intractable is the kind that is associated with development of diuretic-induced complications. We try to again define this in a more specific way, so they are listed here, those terms. Recurrent ascites means ascites that recurs at least on 3 occasions within 12 months period, despite treatment involving sodium restriction and adequate diuretic treatment. Early recurrence is, out of those recurrent ascites, a reappearance of grade 2 or 3 ascites within 4 weeks of initial mobilization. So we hope to standardize this terminology and this definition so we can communicate better and be able to treat patients in a more effective fashion. Now, with those definitions, how do you diagnose and manage refractory ascites? Patients with grade 3 ascites while on diuretics, there are 3 things. 1, you need to assess for diuretic response and complications and determine whether the ascites is truly diuretic resistant or intractable. A useful tool in that is urine sodium measurement or urine sodium potassium ratio that gives us a good clue as to the patient's compliance with dietary salt restriction, and you want to ask the patient for that and confirm that there is a compliance with that restriction. So if the patient is compliant and the urine sodium is low and the patient is either diuretic resistant or intractable, then you have refractory ascites. The most immediate tool to treat refractory ascites is obviously large volume paracentesis. You need to give albumin in an appropriate amount. In patients who have decent liver function and there's no other contraindication, you need to consider TIPS for those patients. If there is significant hepatic dysfunction, liver transplant would be the preferred approach for these patients. So now, this is the first abstract that I will discuss from the recent liver meeting, and this study was done at Harvard. And the title says, spironolactone but not furosemide is associated with the development of hyponatremia in patients with cirrhosis and ascites. Is the 100:40 ratio truly optimal? They had a fair number of patients, about 200 patients, and they compared those who were taking high-dose spironolactone greater than 100 milligrams versus low-dose less than 100 milligrams. And they noted that hyponatremia is much more common in patients who were taking high-dose spironolactone. And the most immediate reaction to this is because patients who are on higher dose, they are sicker, they have high MEL score, and there are other reasons why they would develop hyponatremia. And there are some other parameters in comparison. It doesn't look like that way. The number of admissions the same, death rate is similar, and so forth. So this may be an isolated or unique aspect of spironolactone side effect. They measure time to develop hyponatremia between patients who are on low dose spironolactone versus high dose, and they had a significantly different time to hyponatremia here, and their conclusion was, don't get obsessed with a 100:40 ratio. A fixed lower dose of spironolactone may be preferable to a specific ratio of that 100:40 ratio when managing patients with cirrhosis and ascites. I think that the take-home, which I'll summarize at the end, is that just be aware of this and don't go blindly with the ratio. You need to obviously evaluate the patient in a holistic fashion. So I thought this abstract was helpful. Related topic is albumin. We use albumin a lot in patients with liver disease. This is not a new information, but I think it's useful to review post-translational modification of albumin. As you know, there are more than one function to albumin. We think of it as a colloid agent to increase the oncotic pressure of the plasma. But there is the non-oncotic property of albumin, which is mainly binding with a bunch of things like toxins, cytokines, fatty acids, oxidants, and things like that. So the oncotic property of the albumin may be determined by the amount of albumin in the blood, but the non-oncotic property may be influenced by the quality of albumin, whether the albumin is native or has it been degraded by different chemical modifications. And this diagram shows the numerous sites where albumin may be altered by a different chemical reaction, such as oxidation, glycation, cystination, and so forth. And there is also truncation on both ends of the peptide chain. So albumin changes over time, and the rate at which, or the degree to which albumin changes, may be more pronounced in patients with end-stage liver disease. And the data are shown here. This is, again, several years old from hepatology, where they analyze the different sort of a degraded forms of albumin. So this is native albumin that is unaltered, but compared to that, for example, cysteinated albumin leads to loss of antioxidant activity. N-terminal truncation leads to loss of chelation function, loss of free radical scavenging activity, and so forth. So when they correlated these isoforms with the clinical manifestation, they found that cysteination and N-terminal truncation here was associated with increased instance of ascites and bacterial infection, whereas sulfonylation and cysteination was associated with renal impairment as well. So the quality versus quantity, it seems to be real. And the same investigators then really correlated the properties of albumin with patient heart endpoints and compared to healthy controls who had higher proportion of native good quality albumin. Patients with cirrhosis and hospitalized decompensated patients had progressively lower proportion of good quality albumin. And when they compare patients with high levels of high proportion of good albumin versus not, they were able to demonstrate even survival difference. So that's interesting. This is an abstract that was presented by a manufacturer of albumin, and they present that long-term albumin administration increases effective albumin levels in patients with decompensated cirrhosis. So they use the term effective albumin the same way as I call them good quality albumin. This is a sub-study of a 12-week albumin trial, 20% albumin. The low-dose group received 1 gram per kilogram every 2 weeks, whereas the high-dose group 1.5 gram per kilogram weekly. So the good quality albumin in terms of milligrams per ml, healthy controls had much higher concentration of effective albumin compared to decompensated cirrhosis. When they compared low dose versus high dose group, you can see that the good quality albumin increases more rapidly in high dose albumin group. This is a 12-week trial, and I was somewhat struck by the fact that there's a relatively long tail here, that it takes about 8 weeks for the patients to go back to their baseline, and most impressively, that the proportion of good quality albumin was associated with improvement of Child-Pugh score during the treatment trial. So this is a very intriguing data. There's a commercial conflict of interest a little bit, so you need to take some caution about the data, but this makes sense that not just the quantity of albumin, but if you replace the existing albumin with high quality albumin, you might be able to improve the patient outcome. So believe it or not, this albumin is story is pretty hot. And as many of you know, the ANSWER trial is something that was presented 2-3 years ago out of Italy. This was an open label randomized trial in patients with uncomplicated, mostly ambulatory patients with uncomplicated ascites. And the trial was to give albumin 40 grams per week up to 18 months versus standard of care. They use the term standard medical therapy here. But anyway, that's the comparison. The primary endpoint was survival. They demonstrate that compared to standard medical care, when you add albumin infusion, you can demonstrate that significantly higher serum concentration can be achieved with albumin. The main finding was indeed there was a survival benefit of using albumin long-term in this particular group of patients with a significant p-value, and the hazard ratio is almost 50% reduction in mortality in their multivariable analysis. So that is the ANSWER trial. Another trial called a TIRE trial came out this year in New England Journal of Medicine. This was a randomized trial in hospitalized decompensated patients. So a little bit of different patient population than the ANSWER trial. Again, 20% albumin, but they had a target serum level of 30 grams per liter, or 3 grams per deciliter, up to 14 days versus standard of care. Their endpoint was a composite: new infection, kidney dysfunction, or death. And their study, unlike the other study, was negative. As you can see here, composite primary endpoint was no different between the albumin group and standard care group, no difference. And when they broke that down to new infection, no different, kidney dysfunction, no different, and death, no different, regardless of their time frame. So different outcome of seemingly similar two studies. And there's another study that had a negative comparison as well that I'm not showing in this presentation. One note that the total amount of albumin infused was about 200 grams for the duration of the study in the albumin group, and much lower at 20 grams in the standard of care group. And this is obviously albumin used as a part of standard care as indicated by guidelines. But if you dig deeper into the data, you find this. So this is again similar to the other study, serum albumin level. And you can see that patients who received albumin had much higher concentration than standard of care group. And you may remember that in the other study, standard care had about 3 and albumin was about 4. So these are people with lower albumin levels, and that makes sense because these are hospitalized decompensated patients. But what I think is important is this daily mean amount of albumin used. And you can see here standard of care group had daily treatment of up to 10 grams per day, whereas albumin group used much higher, but standard of care group received a fair amount of albumin as well. And you wonder whether that may be an explanation for the lack of difference between the two groups, because you believe in the good quality albumin being infused in the order of 10 grams per day. That might be sufficient to replace the dysfunctional albumin that these patients may have. There are other differences between those two trials. For example, the etiology of liver disease, most predominantly alcohol in the inpatient study, whereas the Italian outpatient study was mostly hepatitis followed by alcohol. Patients were much sicker in the first study. Here, MELD of about 20 compared to about 16. But if you break that down to creatinine levels, look very different. Bilirubin levels, even more different than the creatinine values. So these are important things to take into account, because as they were presented, mortality was higher with viral hepatitis patients, high Child-Pugh score as expected, MEL sodium score, and so forth. So not exactly apples and apples here, and more data are needed to understand the role of albumin or long-term albumin in this situation. There was an abstract out of the ATTIRE trial that we just reviewed, and the topic was not albumin, but was rather on antibiotic use. And the analysis was about antibiotic treatment in the absence of clinical diagnosis of infection, and that did not prevent development of nosocomial infection in that trial. So there were a total of 777 in the trial participants. 563 had no infection at baseline. Some of them received antibiotic, the other did not, and this was not study specified, so it was an individual clinician's decision. And these are no antibiotic group, and this is an antibiotic group. And there were some baseline differences in terms of variceal bleeding, hepatic encephalopathy, and so forth. But the conclusion here is that the instance of new infection, instance of kidney dysfunction, and instance of mortality did not differ between the two groups, and the authors conclude that antibiotics in these patients not diagnosed with infection did not reduce nosocomial infection or improve other outcomes such as renal dysfunction or mortality, and they suggest that there is an urgent need for greater antibiotic stewardship in acute decompensated patients. In my mind, this is not only for the sake of that patient, but also the patient community, where multi-resistant organisms are playing an important role in the pathogenesis of spontaneous infections in these patients. So that was a side story. This is relating to portal hypertension in non-alcoholic fatty liver disease. I think people have realized that patients can develop portal hypertension with non-alcoholic fatty liver disease even when their cirrhosis is not severe, or in some cases when they don't have cirrhosis. This is normal liver diagram. You have hepatocytes, then space of Dicey, and then there's sinusoid where portal blood is flowing from portal venule. Hepatic arteriole will contribute to that blood flow, and then you go to central vein and hepatic vein. There's stellate cells, endothelial cells, and Kupffer cells besides hepatocytes. In patients with NASH, you would see liver cells filled with lipid contents, and the cells will enlarge, and there will be also ballooning, degeneration going on, and we're familiar with these changes occurring predominantly in the central zonal area. And in addition, there will be extracellular matrix deposits and beginning of fibrosis in the central zonal area. There may be new angiogenesis, contractility of satellite cells, and so forth. So in non-cirrhotic portal hypertension, there may be non-cirrhotic portal hypertension in non-alcoholic fatty liver patients, and that may be driven by narrowing of sinusoidal space by steatotic hepatocytes, creating shear stress, which is source of all downstream effects of portal hypertension, accompanied by endothelial dysfunction. Additional factors such as ballooning, contractility, cell adhesion, vascularization, extracellular matrix depositions, they all contribute to portal hypertension mechanism, in addition to the traditional mechanism that's associated with all cirrhotic pathophysiology. NAFL may be a special case. This is an abstract that came out of Barcelona that said beta blockers induce lower portal pressure decreasing effect in patients with MAFLD cirrhosis than in those with alcoholic or HCV cirrhosis. So they did a classic IV propranolol infusion study and show that patients with fatty liver disease had lower decrease in hepatic pressure, venous pressure gradient in terms of percentage as well as absolute value, and that is summarized in this table. So the conclusion is that patients with fatty liver disease may not respond to IV beta blocker as well as other types of cirrhotic patients. This is a different abstract from Vienna, and the title is The Prognostic Value of HVPG Response to non-selective beta blockers in patients with NASH cirrhosis and varices. So they looked at 38 patients with NASH cirrhosis and varices. They measured venous pressure gradient at baseline and after some time of beta blocker treatment with a median of 52 days. And their response criteria was standard reduction of greater than 10% from baseline or lowering the pressure to less than 12. They looked for variceal bleeding, decompensation, liver-related death over time. And going out to about 2 years, they found no difference between non-responders to beta blockers versus beta blockers responders with regard to these outcomes. So combining the previous abstract that shows that fatty liver patients don't seem to respond to beta blocker as well as other types of cirrhotic patients, and now this one says even if they respond to beta blocker, they may not achieve desired outcome benefit as we are familiar with other types of fatty liver, other types of cirrhosis. Why that might be, and this is a discussion part of the first abstract from Barcelona, and some of the things that we already discussed. It may be related to associated disease such as metabolic syndrome, cardiovascular comorbidity. Their pathophysiology may be different. Sinusoidal structure alterations due to steatosis, exactly what we discussed. Endothelial dysfunction, also we mentioned. And then chronic inflammatory signal from microbiota changes in patients with fatty liver disease may also play a role. We don't know exactly whether these abstracts are going to pan out as a firm data set that we can follow and believe in or not, but it's an interesting signal that we may need to be careful using beta blocker in patients with NASH cirrhosis. Continuing on the theme of non-alcoholic fatty liver disease, sarcopenic obesity is a term that is often used in patients with NASH cirrhosis, and there's two components. One is low muscle mass and high BMI. So this diagram shows that roughly same amount of muscle tissue may exist in 3 different patients with different BMIs. So often we mistake patients with high BMI. They may have larger mass of muscles, but not necessarily so. And you can actually have sarcopenia in the background of obesity. So the usual definition conceptually is low muscle mass, and a tool to gauge that might be things like skeletal muscle index in association with high BMI. This is difficult to detect without dedicated testing. It is estimated that 20 to 35% of patients with cirrhosis may have this. NAFLD is a strong risk factor, and it's an independent risk factor for poor outcome, such as mortality. So that's sort of a summary of what we know. There was an abstract to operationalize that definition. It doesn't necessarily make it easier, but at least help us understand what's important. So they are zeroing on sarcopenic visceral obesity. We just talked about sarcopenic obesity. As you know, fatty liver patients have visceral obesity. So can we zero in on sarcopenic visceral obesity associated with fatty liver cirrhosis? So here again, we're trying to define sarcopenic obesity. Here, sarcopenia is defined as skeletal muscle index is area of all skeletal muscles in L3 cut surface of CT scan, and that is adjusted by the height of the patient. So males have a higher cutoff than in females. They are determining visceral obesity as a ratio between amount of visceral adipose tissue versus subcutaneous adipose tissue. They call VSR. And again, they have a standard ratio to tell whether they're visceral adiposity between men and women. some of the data are shown here. Skeletal muscle index. In the first row, visceral adipose tissue amount is here. Subcutaneous adipose tissue amount is here. And then you calculate the ratio between the two. And you can see that there's a difference between men and women. And the amount of sarcopenia here, visceral obesity here, and the definition of sarcopenic visceral obesity is shown here: 15% among women, 12% among men. So a little bit lower than what we discussed in terms of the overall obesity, but the figure here down here shows that you can really zero in on sarcopenia and visceral obesity as the most dangerous, as poorest outcome here, clearly different than the other groups. And between non-visceral obesity and sarcopenia, what's more important is sarcopenia here. Patients with sarcopenia without non-visceral obesity, they did also poorly compared to patients who did not have sarcopenia, regardless whether they had visceral obesity or not. So more understanding about this pathophysiology of what drives poor outcome in patients who are overweight and obese, but also sarcopenic. This is an abstract that tried to make measurement of the patient's frailty easier and real time. So the title of the abstract was Estimating Stride Length in Liver Transplant Candidates, a Novel Way to Remotely Track Frailty with the 6-minute walk test using personal activity trackers. So this is an investigator that has come up with a mobile app associated with a wearable, and by doing the calculation they were able to model the stride length and validate that through measured step length. So that's an intermediate endpoint. What they are trying to predict is the result of 6-minute walk test. And there are two models here. One includes liver frailty index and one without frailty index. If you look at the one that doesn't require hand grip strength, things like that, LFI, and you see the correlation between 6-minute walk test and their model, there's a pretty good correlation. So this is a proposal that by using the app and wearable device, you can estimate the stride length, which can correlate with 6-minute walk test. So without seeing the patient or without having the patient walk in front of you or with a clinic staff, you can monitor real-time patient's fitness and frailty by using these innovative devices. So obviously this is not prime time yet, but it's a new thing that I thought was interesting. On the theme of frailty and sarcopenia, low testosterone has been known to be important. This is a study from Australia that showed low testosterone levels vary by etiology of cirrhosis and are associated with adverse outcomes in a large cohort of cirrhotic men. So indeed, 766 patients, moderately decompensated patient with CTP score of 9 and MELD of 14, they measured total testosterone and free testosterone. They found that more than half was deficient in terms of the total and 80% deficient in terms of the free. The first finding that they report is that alcohol patients tend to have the lowest testosterone level regardless of total or free, and NAFL patients were close to that compared to other diagnoses who tended to have higher testosterone level than those two categories. When they try to correlate the clinical outcome, here they are comparing ALD versus alcohol versus NAFL versus others with regard to total testosterone levels, and they found that, as was shown in the other graph, other diagnosis was 3.6 times higher levels of testosterone, whereas NAFL patients were not statistically different. Child-Pugh C had a lower testosterone level. MELD was associated with lower testosterone level as well. This is a model predicting death or liver transplant, and as you expect, Child-Pugh C, MELD score were associated with those poor outcomes, but adjusting for those known things, total testosterone was significantly associated with those poor outcomes, and this is a liver decompensation predicting with testosterone level, again, statistically significant impact on the development of hepatic decompensation. So this is something that we need to pay attention to in male patients with cirrhosis. I'm just giving you a heads up and a plug for our newest guidance document, and this is about nutrition, sarcopenia, and frailty, and it is available online. And this is a summary table for how to manage those important complications of cirrhosis. You may want to do liver-specific measures such as treating the underlying etiology, managing ascites and hepatic encephalopathy. Ascites is important because of nutrition. Hepatic encephalopathy is important because ammonia plays an important role in the pathogenesis of sarcopenia. You need to correct both of these complications. A practical tool, physical activity, personalized activity prescription, including frequency, intensity, overall duration, and type of exercise. You need to work with people who know how to prescribe those exercise programs. For nutrition, 35 calories per kilogram in non-obese patients, high protein diet, 1.2 to 1.5 grams per kilogram, micronutrients, frequent small meals. Don't force patients not eat well because of unpalatable low-salt diet. Obviously, working with a dietitian is important. Again, testosterone important in men, and other behavioral factors to improve overall patient's health. The last section will be about palliative care. This is a hot topic, at least in the US, that palliative care can make the patient feel better, improve quality of life, and give the patient dignity towards the end of their life. This is an abstract that came off Cornell, looking at patients with cirrhosis and hepatocellular carcinoma, and they looked at readmissions in those patients. So this was a nationwide readmission database, a large number of patients with cirrhosis and HCC. 30% had one readmission, 20% had multiple readmissions. There is a predictive model or analyze the predictors of those outcomes, single readmission versus multiple readmissions, adjusting for the usual variables that are known to affect readmission of those patients. Palliative care consult was a statistically significant factor that reduced single readmission and multiple readmissions. So there's not only a patient-facing benefit of palliative care, but also system-facing benefit that these patients don't need to come back to the hospital and over again, which may be very important in this era of the pandemic when hospitals are short. This may be perceived as blasphemy in hepatology, that patients with large volume of ascites, you don't put in an indwelling catheter because it will get infected, it will cause all kinds of problems. But it may be a useful tool in the palliative setting. So this is an abstract that has a title that says home-based tunneled peritoneal drainage system as an alternative treatment. As you can see here, a catheter with a subcutaneous tract that it's supposed to insulate the ascites from outside bacteria. Clinical outcome shown here is that patients who had the catheter had actually better survival in terms of 90-day survival. There were patients who had the catheter removed. The 90-day explant-free survival is about 50%, and patients who had the catheter removed, about half them was for infection, and smaller number for dysfunction and accidental removal. I think that was interesting. In patients with who don't have access to alpha pump, which is the case with the US, this may be a useful tool, and the median explant-free survival in this particular data is close to 2 to 3 months. The last abstract that I show you is a similar data in the US. The one before was from Germany, and this is a much smaller study, 12 patients with indwelling catheter. You can see here most of them had alcoholic liver disease. Some had HCC, median MELD of 23, CTP of 12 points. Median number of large volume paracentesis 2.5 in the preceding month. So these are pretty sick patients, and they received this catheter, and they were treated, were followed with hospice care and so forth. But I was surprised to see the mean survival was 14 days. So the other abstract, it was 2 to 3 months. Here in the US, you seem to use this very late in the course of the patient progression, and this may be something that we need to think more about and work with our colleagues in palliative care to implement in a more timely fashion. So in summary, I talked about portal hypertension in fatty liver patients. There are unique mechanisms apart from liver fibrosis, and response to and outcome of non-selective beta blocker therapy in these patients may be different. I spent some time talking about ascites and albumin, quantity versus quality. At this point, I recommend following guideline recommendations in albumin use, which is basically large volume paracentesis, hepatorenal syndrome, and spontaneous bacterial peritonitis. Long-term infusion, the jury is still out there, not ready for prime time. Think about antibiotic stewardship in our patients who are susceptible to infection. We just talked about palliative catheter drainage, which may be appropriate in some patients towards the end of life. Beware of diuretic-induced hyponatremia, particularly spironolactone. Sarcopenia, frailty, we need to be aware of this entity and have some good degree of suspicion. Diagnostic tools are a bit tricky at this point because sarcopenia is defined by CT at this stage. We just talked about the mobile app to try to estimate patient frailty in a real-time but remote setting. Testosterone we talked about. Comprehensive management involving nutrition, prehab and rehab specialists. Palliative care, patients' quality of life and dignity are improved or preserved with these interventions. It also reduces hospital resource utilization as well. Thank you very much for your attention, and again for this invitation.
Thank you, Dr. Kim, and thank you for being live with us to answer any queries and questions. And I see that you answered quite a few in the chat box, and thank you for that. And now I believe that the panel might have some questions for you and might have some comments.
Dr. Excellent talk as usual. The first time also you gave a very good talk, and this time many new informations have been there. But commercially available albumins, how we can judge that which is the type of good albumin or not a good albumin?
I pretend not to be an albumin expert per se, but my understanding is that all of the products are human albumin that is taken from a healthy volunteer. And presumably they're all enriched with good quality albumin. So I don't think there's any product-specific difference that we need to be careful about. It's the innate albumin that patients produce, and their disease process tend to degrade the albumin quicker in liver patients than in healthy controls.
Yeah, Dr. Kim, thank you very much for the excellent lecture. And now, see this aldactone, the higher dose of the aldactone decreases the sodium. What is the explanation for that? Our understanding has been that the hyponatremia is a major cause because of the furosemide. But here it is a little different.
I I think you have more expertise in this than I do, Professor Singh. I do not know. It's an observational data here, and you know, my limited experience in dealing with patients in the clinic is that it feels like individual response is different. Some patients become hyponatremic on Lasix or furosemide, and others on spironolactone. So it was an interesting abstract. I don't know if we can discuss sort of a fundamental pathophysiology based on the abstract at this point. But again, your point is very well taken. Thank you.
This is regarding the another problem which we face. If we are talking of the long-term albumin therapy, maybe 1.5 gram per kg in a week or 2 weeks, then giving this albumin, suppose a patient weighs somewhere around 80 kg, which may be often seen in your population of US. And for that, we'll have to give somewhere around 120 grams. And 120 grams means 600 ml of 20% albumin. It takes a long time to infuse such a high albumin. And you never know, because we are not very minutely observing these patients. Some of these patients may go into LVF. So this is a major problem. I don't know how common it is there in your country.
It is not common at all. I don't know how much it costs to give albumin in India. It is exorbitantly expensive in the US. So it is difficult sometimes even to get albumin for the established indication for SBP typically. So they make sure that we don't give enough albumin to cause pulmonary edema or LV failure by just the pure reason for the cost. So all these data are based on experiments, and the abstract was not published. So obviously the full data, I'm not sure, you know, what exactly they did, but the entire study, they did not specify the amount of albumin. They had a goal level, which was 3 grams per deciliter or 30 grams per liter. So that is achievable. But giving 1.5 gram per kilogram every day, that is not only difficult to achieve, but dangerous, honestly. I agree with you.
Dr. Kim, there's a question about what is the role of Vaptans in this whole business?
Yes. Again, Professor Singh has a whole lot more experience using Vaptans than I ever do. I confess I've never prescribed a Vaptan in my career because a single pill costs $300 in the US, and no one goes there. But I think the totality of data that I read is that Vaptans are a useful adjunct to diuretic and water restriction, to hyponatremia management. I think the Japanese investigators have been very aggressive using Vaptans as an adjunct to diuretics, even in patients who don't have hyponatremia but have large volume ascites. I'd like to turn to Professor Singh and ask for your wisdom.
Yeah, see, it's a wonderful drug, I tell you. But you have to be very careful when you are using the Vaptans. One, that there should not be a low MAP, there should not be the renal dysfunction. If there is a low MAP or renal dysfunction, don't use the Vaptan. Otherwise, this is going to deteriorate the condition of this patient. And otherwise, if there is an indication, you can use it, and once you start in the doses of maybe 15 mg a day or maybe 30 mg. The urine output is so much, it looks like as somebody has opened a tap. See, the sodium level goes up. So what I do, I use the Vartan in a low dose, and if it is possible, I combine it with the maybe 2 days prior, I give the Midodrine and then build up the map and then start the tolvaptan. And in our study, we used it for 3 months. Nothing happened. The hepatic dysfunction is not a major problem, which is a worry in that study, because of which the black box warning has been given. But that was a study in which they gave it for years together and a very, very high dose. So I think we'll have to look back at the use of tolvaptan or the other Vartans also. In these patients, it's a very useful drug, but only thing is that the cost here in US is very, very high. In our country, it's very cheap drug. So we use it whenever we require.
Thank you, Professor Singh. Yes.
Just 1 minute. Don't Dr. Kim wish to give some comments on the branch chain amino acids in sarcopenia?
Yes. So that again, I would like to give a plug to our new guidance document. Branch chain amino acid has multiple roles in patients with liver cirrhosis and ascites. It has been shown to improve ascites and albumin to a certain degree. And as you know, patients with hepatic encephalopathy, it has been shown to improve to a certain degree. But when it comes to sarcopenia, BCA is an important has an important role in relation to lowering the ammonia level and restoring myogenesis in the skeletal muscle. So it's an important tool. My challenge with patients in the US is there are so many different preparations. It is difficult to find what's palatable, what's sustainable in our patients. It's very bitter if you don't have the right flavor. So that's the difficulty, practical difficulty that we have encountered.
Thank you, Dr. Kim. And I think we have to stop this exciting debate in the interest of time. Thank you for joining us. I thank the panel for being with us this morning. And we have to move on to the next session. Thank you very much.
Thank you. My pleasure.
The next session is, we're not going to have a break because we are behind schedule, is going to be by Dr. Shiv Sareen. As all of you know, the chairperson at the ILBS, very esteemed teacher who has been awarded the Padma Bhushan by the government of India, and so the Bhatnagar Award. And of course, he set the MCI as a chairman, and then introduced the NEET examination, bringing uniformity to medical studies. A lot more to his biodata is never ending, actually, and growing by the minute. And for the session on critical care hepatology, I would have two moderators, Dr. Manav Wadhwan from BLK, and is the head of the department and a senior director there. And of course, Dr. Sunil Taneja, professor of hepatology at PGI Chandigarh. So over to Dr. Sareen for the next session.
Thank you, Dr. Vinay. Can you see my slides?
Yes, sir.
Okay. Bring greetings from the ILBS. The slides used have been supplied by authors or were prepared by me from the abstracts which are published. I'll walk you through some very exciting and brief data. This abstract gives you predictors of mortality in cirrhosis patients admitted to the ICU with suspected sepsis, a single center experience from Cleveland Clinic. And this is how you assess whether a patient should go to ICU or what you should do in first 6 hours in the ICU. They took up patients and retrospectively analyzed the baseline and resuscitation factors associated with mortality among cirrhotics admitted to ICU with sepsis. 98 patients, 64 died. 56 of the 64 died in the ICU. Why? 12 hours prior to ICU transfer in your ward, the survivors had more crystalloids, had a higher heart rate, which to me looks a bit problematic. For me, anybody cirrhosis who has a higher above 100 heart rate is worrisome, but here they say crystalloids, higher heart rate, lower bilirubin, acceptable, lower SOFA, understandable, and lower MELD sodium, understandable. If you have such a patient 12 hours prior to ICU transfer, the chances of survival are significantly better than those who died. Now, the patient has reached the ICU. Those who survived in ICU had a higher lactate clearance. Now, we generally look at lactate clearance as, oh, it has come from 4 to 3. Here, it is not the absolute number, it is the percentage of lactate clearance. So, let's say the patient had 5 and it has come to 4.8 or 4.6, it's better. And these patients may survive than who did not have a lactate clearance or had higher rising lactate. 2, grade of ACLF, understandable. Now, here are the predictors of hospital mortality. Please pay a bit of attention. Those who had diabetes, heart rate, as I told you. Now, respiratory rate, anything about 24. White cell count, understandable. Patients who had bacteremia had a better survival, because they were able to find the bacteria. SBP, poor survival, and a MELD lactate, which persisted to be high after ICU, had a poor outcome. So here you can see presence of bacteremia and identified bacteria gave a better survival benefit. My takeaway from this is patients who are in the ward, please triage them in the ward itself. Those who have high heart rate or respiratory rate, to me, it looks sicker. Then you have the residents and the consultant walk the patient from the ward to the ICU and monitor them for the first 24 hours based on these very important criteria of lactate clearance. The second is assessment in ICU. Clinical characteristics and outcomes in patients with cirrhosis requiring ICU transfer. So baseline characteristics and outcomes of patients before ICU admission. So 443 patients came to the emergency room. 80% with no ICU transfer, 13% transferred to ICU from emergency department, and 6% transferred to ICU from medical ward to the ICU within 7 days. So 3 categories. They went direct, they went to the floor, and then were transferred. So no ICU transfer means they went to the ward. These guys ICU transfer directly and ICU transfer between hospital and days 1 to 7. Now, if you see the difference in this group, you will realize that patients who came had higher mortality. ICU transfer, you can see that 25% versus 12%, 43%, 27%, 46% versus 34%. So patients who have come to the ward and then transferred have a worse outcome than patients directly going. So if you have a patient who requires admission, assess properly, triage them, because once they are in the ward, then you transfer them, mortality is higher. My takeaway is cirrhosis with sepsis, try and see, go to this ICU directly and then downgrade rather than upgrade to ICU. The third abstract is again assessment in ICU. And if you have a medical intensive liver unit, at least this was studied in the pandemic, what they suggest that now because of COVID, increased severity of illness for hospitalized hepatology patients have been observed. And they believe that a medical intensive liver unit with a subspecialty model needs to be developed. And this, I think many centers in India, including ILBS with a 40-bedded ICU for liver all the time, is very helpful. Now, what is the difference in the COVID pandemic? I'm not sure I'm overstepping with Dr. Sumit Asrani, but just as the ICU part, in 2020, in-hospital deaths were more. The patients who came with alcohol, maybe they were drinking more when they were not able to move out, was more. MELD sodium was higher in this group, and patients transplanted during same hospital admission. Now, this is a rarity in India. Patient comes to the ICU and they either die or they are sent out. But here, 3/4 of the patients were transplanted while they were in ICU. And I want to stress upon this. I hope our surgeons and our physicians make this a point, no readmission, settle it then and there. Again, assessment in ICU, severe alcoholic hepatitis is independently associated with worse survival in critically ill patients of ACLF. And this came from Indiana by Jennifer Peng. Very briefly, I will tell you, comparing demographic and admission characteristics between severe alcoholic hepatitis with ACLF. Their ACLF means organ failure. For us, it is ascites. Versus non-severe alcoholic hepatitis, non-SAH ACLF. So if the patient has alcoholic hepatitis or non-SAH, what is the difference? Here you can see sodium levels were lower in severe alcoholic hepatitis compared to non-severe. Their creatinine was higher, INR was higher, bilirubin levels were also higher in these patients. So severe alcoholic hepatitis with ACLF are sicker than other kinds of ACLF. Then the MELD scores are higher, their cliff is higher, but more importantly, and I want to stress, this correlates with what the definition given by APSL, that their severe alcoholic hepatitis did not have more kidney, brain, circulatory or respiratory failures. Only failure was liver, and that is high bilirubin and coagulopathy. So the severe alcoholic hepatitis in any part of the world will be determined, and the outcomes will be determined only by the liver failure part. They have higher bilirubin and they have higher coagulopathy. Having said that, at 30, 90, and 180 days, severe alcoholic hepatitis patients are less likely to live without a transplant. The mortality rates are 53% and higher. So remember that patients with severe alcoholic hepatitis and ACLF are sicker and need urgent transplant. Now, this work is by Dr. Rakhi and the group. This is an important study just to say how do you manage critically ill cirrhotic. Generally, we want a high MAP. Now, here is a MAP less than 50. The survivals are poor. MAP less than 80, 75, and C. Patients who have got a MAP of less than 65 are considered in shock. And they or even lower MAP people have very poor outcomes. And this is based upon that the MAP determines the amount of blood going into kidneys. If the duration of hypotension is longer, as you can see in hours, 5 hours, 10 hours, you can see that mortality increases in these patients. So try and correct your hypotension as fast as possible. Based on this is a single slide to show you the detail to assess the efficacy of high, that is 80 to 85, versus low, 60 to 65 MAP in patients with cirrhosis and septic shock, and their 28-day survival. The secondary outcomes were shock reversal and AKI reversal by day 5, and incidence of intradialytic hypotension. adverse effects of raising with vasopressors, the blood pressure, duration of ventilation, ICU care, and patient with cirrhosis and septic shock were 150. Here you can see that patients who had a high MAP had a 28-day mortality, not different. AKI reversal was nearly better. Intradialytic hypotension. So you can take these patients for dialysis and they can tolerate dialysis. Length of ICU stay not different. Shock reversal not different. Adverse events were higher. So what do we learn in this? That even if you raise the MAP and even if you improve the AKI reversal or maintain them on dialysis, the survival benefit is not there. So these are very sick patients. We should attempt to improve their MAP, but also with a guarded option. My takeaway is you must personalize MAP strategy and identify vasopressor responsiveness in first 6 hours. Look into tissue perfusion, and as I said, lactate, which is for us a very important marker, it is produced higher if the patient has sarcopenia. Look into urine output and SVR. Anybody where you can achieve an SVR above 600 is a good patient, may improve. Rapid improvement in MAP is required. Don't wait for 6 hours or 12 hours. And we need new markers. Responders were those who with target high MAP improved and reversed AKI. They were there, but whether survival, we do not know. Targeted strategies are needed to improve microcirculation. Now, this is a basic science work, but very interesting. Hepatic IRE1 mediated metabolic adaptation protects against cardiac dysfunction in sepsis. Don't think it is a hi-fi thing. It only says, how do you maintain your heart and simple fatty acid basis. I'll not go into details. Liver provides energy substrates such as lipid-rich particles to support peripheral organ function in sepsis. It is not sugar. It is the lipid which maintains the peripheral organ energy supply. Liver-mediated metabolic dysregulation is unknown. So what they did was hepatic endoplasmic reticulum, which maintains and generates lipids, and whether that ER is healthy or not. And is this the source which provides energy? And they used an inositol requiring enzyme 1-alpha, IRE1-alpha, which is a key regulator of ER. ER homeostasis in LPS induced and polymicrobial mouse model of sepsis, they used liver specific IRE1 knockout mouse. Results showed that IRE1 interacts with fatty acid synthase, which synthesizes fatty acids. Its deficiency sensitized mice to LPS and mortality. IRE1 deficiency diminished LPS-induced lysophosphatidylcholine secretion, an important lipid that is positively correlated with survival. Impaired hepatic ER-mediated lipid adaptation contributed to cardiac dysfunction, in part through reduced cardiac oxygen consumption and increased neutrophil infiltration. The baseline message is disruption of hepatic ER-mediated lipid metabolic regulation impairs sepsis-associated cardiac immunometabolic adaptation. Heart is unable to adapt to this stress if your lipid, which is required, which is produced by the endoplasmic reticulum of liver, is not available. Hence, lipid as a source of energy, which lipid we do not know, but at least lipid as a source. Therefore, yesterday I told obese people who come to ICU may survive better. Maybe they have more of available lipids. But whether giving intralipid will help, nobody knows. One work by Anand had shown that you can give omega-3 and it improves survival and reduces inflammation in patients with ACLF. I'll come to very interesting last two abstracts. outcomes after liver transplant. I hope I am not stepping over into what Dr. Patrick Kamath will say, but I wanted to introduce this concept with pulmonary hypertension. Now, pulmonary hypertension, mean PA pressure is more than 25, whether you do by echo, but more sensitively by right heart. Portopulmonary hypertension is pulmonary hypertension with pulmonary vascular resistance of more than 3 Woods unit and pulmonary capillary wedge pressure PCWP of less than 50. This is classical definition. To portopulmonary, this concept is added. Pulmonary venous hypertension. Those patients of pulmonary hypertension with PVR of less than 3 Woods unit and higher PCWP, more resistance, and transpulmonary gradient of less than 12. So these are more rigid lungs. If you have such a patient versus your classical portopulmonary. So what I am trying to show you, there are two types of portopulmonary. One which is still pliable with high pressure, one which is not pliable with higher pressures. And one, of course, is a mixed group. So they took 37 out of 1173 liver transplanted patients. Of them, 17. So dominant is the pulmonary vascular venous hypertension compared to portopulmonary, and 11 had mixed. Now see the outcome. Those who had the pulmonary venous hypertension compared to portopulmonary, in this group, all were alive after liver transplant. And in this, 9 out of 17 after liver transplant died. So bottom line message is, you must do a good right heart, check the pressure, PCWP, PA, as well as calculate the Woods unit and transpulmonary gradient. Therefore, we have to now understand portopulmonary, like hepatopulmonary is type 1, type 2, or even type 3. Portopulmonary can be classified into type 1, type 2, or type 3. They haven't done it, but we can mentally classify them. One more last study probably is rifaximin discontinuation in critically ill patients with liver disease receiving broad spectrum antimicrobial therapy. What happens is a patient comes, he was on rifaximin, he goes to the ICU, he gets all high end antibacterial drugs, he is discharged. But during the ICU stay of a week or two, he is still continuing on rifaximin. So what these people do was to see initiation or continuation of rifaximin for HE during broad spectrum antimicrobial therapy. There is very little literature. And they evaluated the safety and efficacy of a pharmacist-driven protocol. What they show that if you start the drugs maybe after 14 days. So now it says days alive and free of delirium and coma to day 14. Now, if you give such patients continuous rifaximin or start after 14 days, there is no difference. And you save huge amount of cost from $500 and maybe to 82. So 14 days you can wait till it is likely that patients' antibiotics might be working. This is the last an important abstract by Philip, where it says that gut microbiota, functional metabolism, and network topology in decompensated cirrhosis with and without infections. In fact, a similar abstract is also by Dr. Satyendra and Dr. Vikram Bhatia from ILBS. The aim was to characterize significant bacterial communities and their functional metabolism between infected and not infected decompensated cirrhosis. And what the investigators tried to identify bacterial groups and associated functional metabolites in the infection sites, episodes, inflammation, and outcomes. Here, those infection was absent and those it was present. One episode of infection in the past was present in many, two or more in many. Interleukin levels were higher. Cephalosporin use, piperacillin use, carbapenem use were higher, and death during same infection was more. But what is interesting is to see this. Infection infection is present or no infection. There is a huge difference in the bacterial repertoire. I can't read it out to you. I'll show that slightly in the end. Episodes of infection, and this is 0, 1, 2. In the spectrum is very different than non-infected. Site of infection, you have different bacteria. Of course, logical. Site of infection and significant bacteria, blood, lung, SBP, difference. And interleukin 6 levels, which we are used to now doing after COVID, less than 100 or more than 1000 picogram. To summarize this part, alpha diversity differed between no infection versus infection. Alpha diversity means the spectrum of bacteria, the different types of bacteria and diversity that you have. No infection versus 2 or more episodes, and IL-6 in infected subjects. No difference between infected, cirrhotic, survived or died. This is the take-home message. Those who are decompensated with no infections, they have good bacteria, bifidi or choriobacteria. And their upregulated pathways are endogenous antimicrobials, antioxidants, and good cytokines. And you have specific beneficial taxa associated with them, more diverse interactions, mutual exclusions, and concurrence between taxa. But those who are infected with bacteria or pathogenic bacteria, these included Leptotrichia, Neisseria, and Erwinia. Pathways which were upregulated were oxidative stress, not antioxidant. Endotoxemia, pro-inflammatory. And there were specific pathogenic taxa, and there were also mycoplasma, which we often forget. And urinary infection was amongst the commonest. Those who had repeated infections, just remember this, a high IL-6. And you have immune exhaustion. So what we come to it that if you do stool bacteria of patients who are coming to the hospital, try and characterize them based on bacteria. I think it may be a worthwhile exercise for us. With this, much more has to be done in critical care hepatology. I think today, on an average of the 3 years of training, 9 months to 12 months of our residents spend in critical care. And me, after having worked in this for almost 4 decades, I still feel like I'm still in the learning phase. Believe me, critical care hepatology will drive outcomes in patients with cirrhosis and infections. Thank you so much.
Dr. Vinay, please unmute yourself.
Sorry, that was a group. So thank you, sir, for sharing these papers. And may I ask the panel to now give their comments and perhaps ask questions and share their experience.
So, good afternoon, sir. Very interesting data, sir. And we all know that the critical care hepatology is really evolving, and a lot of liver intensive cares have been set up in India also now. So I think, sir, very interesting data which you showed on transplant straight away from the ICU. So in India, I think we would be really skeptical of taking such patients directly for transplant. They're so sarcopenic and frail, and usually they come at a very late stage. So what is your thought on that? And second question is, do you really have a triad system for your patients in liver ICU? For that matter, that if you have grade 1 ACLF, would get a preference over grade 3 or 4, or all the patients would straight away go to liver ICU? Because obviously the survival would differ between the two groups.
Yeah, very good question, Sunil. Firstly, our surgeons have still not come to the idea that patients with ICU admissions can be taken for transplant. They always work to have good outcomes rather than good patient outcome. The patient who has 5% chance of survival, if he survives with 50% chances, I think it's fairly good. But surgeons generally want their outcome is 90% survival. And that's the, kind of dichotomy. The triage part is we do not use the cliff, so we do not say ACLF 1, 2, 3, 4, but yes, ARC score. If the patient has ARC 11 to 15, he goes straight to ICU as of now. Patient has a ARC less than 10, he would go to the ward. However, patients are individualized. Generally, those with a high respiratory rate or have high tachycardia or saturation low will come to ICU. But still, we end up, many patients go to the ward and then they are transferred, and we are trying to improve, but these are learnings collectively.
So just one last question, sir. You talked about personalized map strategy, sir. So when we take the patient to the ICU, we quickly, we are just focused on map and we suddenly start looking at the blood pressures and try to target a high map. So can we have a strategy in the wards, or we should target a map in the OPDs by either giving midodrine or, kind of giving albumin infusions or regulating the dose of diuretics? Because I don't think so in OPDs or even in wards, you would be closely monitoring the map in such patients.
It's a very practical thing. Generally, all our patients who come to the OPD get their blood pressure done and map calculated. And patients by nurses are sent to the ER if the map is less than 65. They don't come to the consultant, the resident goes. Number two, in the wards, somehow we miss out, and patients are not either given albumin. Personalized map, I would stress upon in ICU care, because if you can achieve an SVR of 600 and above, my feeling is these patients can do well. But SVR of 350, 400, they do very badly. How to improve without increasing lactate remains a challenge. I had also looked at your beautiful randomized trial, but I am not presenting the home care nutrition, but since it was being presented by Dr. Puri, so I did not present. But that's an important message what Sunil and Dr. Viren Singh has done, is that when the patient goes out from the hospital, you do a monitored high intensive nutrition, and that reduces readmission critical care needs significantly, even up to 6 months time. Yeah, thank you.
Thank you, sir.
Sir, good afternoon. So that was very interesting set of papers you presented. I have a question on the severe alcoholic hepatitis paper which you presented, sir. So what in your practice would change if you are treating a SAH with ACLF versus SAH without ACLF? Would you differ with the steroid strategy differ? Would any other things change? What will be the management decision depending on ACLF versus no ACLF in severe alcoholic hepatitis?
It's a $1 million question, and Rakhi had just analyzed this. And earlier Shastri had done of about 1,600 odd patients, 1,300 were severe alcoholic hepatitis with ACLF, means ascites was there, 300 without. Those who had ACLF, means with ascites, they were sicker, their response to steroids were lower, and the chances that they would have a SBP or pulmonary complications were higher. As far as treatment strategies are concerned, we are struck because in them even FMT may have challenges. So we need to see that they do not have any ascites, no SBP, and then only FMT is given. Currently, what we do is such patients would go, if no pulmonary or cardiac or renal complication, for plasma exchange. However, that is very temporizing. And such patients, in my mind, within 7 days to 15 days should be listed for transplant.
Thank you, sir. Thank you.
Thank you. Thank you to the panel, and thank you, sir, for being with us. As you know, that we are so spellbound when Dr. Sareen is talking that I forgot to unmute myself. Thanks to the panel, and thank you, sir. Now we move on to the next talk, because Dr. Laurie Levy is going to talk on basic and transitional hepatology training. It's pretty late in the Western United States, but still she's joining us. And for this, I invite Dr. Philip Abraham, who is the consultant and head at the Hinduja Hospital, and also Dr. Shagan Bihari, who is at the ILBS New Delhi. And let's have the talk by Dr. Laurie.
My name is Laurie Delev, and we met when I presented the work on drug-induced liver injury presented at TLMDX. I'd now like to talk about the basic and translational abstracts presented at the meeting. There were numerous high-quality abstracts on basic and translational topics presented this year at TLMDX. The ones I'm presenting are not necessarily the best, but the ones I thought I could best convey to you in this forum. The role of the microbiome was a prominent theme at this year's TLMDX. Abstract number 3 comes from Jaz Bajaj's group at Virginia Commonwealth University. The premise of this work is to find a successful treatment to reduce alcohol craving, which would be particularly useful for cirrhotic patients who have few, if any, pharmacological options. This group previously found in a double-blind randomized clinical trial that fecal microbiota transplant, or FMT, from a donor enriched in Lactobacillus or Ruminococcacea significantly reduced craving and alcohol intake in men with alcohol-related cirrhosis. The fecal microbiota from these cirrhotic men is used in the study I'm about to describe. In this study, they examined whether FMT from these cirrhotic men can act as therapy to reduce alcohol craving in mice. The protocol is outlined in the top left panel of this slide. 30 germ-free male C57 black 6 mice received FMT from these patients. Received fecal microbiota from these patients prior to FMT, labeled pre-FMT, or microbiota from these cirrhotic patients after they received FMT, labeled post-FMT. Initial ethanol acceptance, intake, and preference were measured using a 2-bottle choice ethanol drinking assay. That is, each cage had both a bottle of ethanol and a bottle of water placed in their cage, and readings were taken at 2, 24, and 48 hours. Stool was collected for 16S RNA sequencing 15 days post-colonization and 18 hours after alcohol access. Correlation networks between bacteria and alcohol preference and intake were performed. The graphs with the gray and yellow bars demonstrate that post-FMT stools significantly reduced initial ethanol acceptance and 24 ethanol intake and preference compared to those that got pre-FMT material. These changes were linked with Ruminococcacea and a higher microbial diversity, as indicated by the blue line in the bottom right figure. The conclusions are, first, that FMT may be a promising therapy for reducing alcohol intake and craving, and second, that Ruminococcacea are associated with lower intake and preference for alcohol and germ-free mice. Abstract 5 comes from Chantal Housset's group at the Sorbonne in Paris. The aim of the study was to identify portal mesenchymal progenitors of myofibroblasts. This study is interesting, as you will see, because it allowed them to define a population of cells underlying specific types of liver fibrosis. Particularly in conjunction with the next abstract I will present, we could reinforce this concept that different liver fibrosis is linked to different cells providing the collagen. As shown in the top left of the slide, portal mesenchymal cells were isolated from the biliovascular tree of normal liver and analyzed by single-cell RNA sequencing. Based on the single-cell RNA-seq data, a set of surface markers was established and used to isolate mesenchymal cells that generate portal fibroblasts. In the middle of the left slide, you can see the trajectory analysis allowed them to define and isolate a small cell population defined by surface markers. This population consisted of portal mesenchymal stem cell-like cells according to their mesenchymal stem cell attributes, namely high clonogenicity and trilineage differentiation potential. At the bottom of the left side of the slide, you can see that these markers were used to distinguish portal mesenchymal cells and derive myofibroblasts from hepatic stellate cells by bulk RNA sequencing and to examine their fate in murine and human liver fibrosis. They identified a 7-gene expression signature, including SLT2, which you can see in the heat map at the bottom, that distinguishes portal mesenchymal stem cells in their myofibroblast progeny on the one hand from hepatic stellate cells and activated hepatic stellate cells. On the right bottom of the slide, you can see that they used this gene signature and expression of SLT2 to show that portal mesenchymal stem cells are present in the perivascular portal region in normal liver, shown in red indicated with arrowheads, and largely expand with progression of fibrosis, contributing to the myofibroblast populations that form fibrotic septa and sustain their vascular scaffold. At the top right, you can see portal mesenchymal stem cells increase, but hepatic stellate cells don't, in mice treated with the DDC diet, a cholestatic injury, and the choline-deficient amino acid-defined diet, or CDAA diet, leading to fibrosis, and in the middle right, in humans with NASH and PSC. So this abstract demonstrates that portal mesenchymal cells are a small cell population with stem cell features and a perivascular portal distribution in normal liver that can be highly expansive and underlie fibrosis progression in different types of liver disease. Abstract 171 from Fujiwara et al. From the University of Southern California used single-cell RNA-seq to examine vitamin A positive and vitamin A negative activated hepatic stellate cells and activated portal myofibroblasts in the mouse model of alcohol-associated hepatitis. The studies were performed in collagen 1A1 GFP transgenic mice using the 7-week intragastric feeding model of alcohol-associated hepatitis to induce F2 fibrosis. To trace LRAT-positive cells in alcohol-associated hepatitis, LRAT-Cre ROSA26M transgenic mice were subjected to the intragastric feeding model, and livers were examined by immunohistochemistry for GFP. The t-SNE clusters in the top left under main findings show the appearance of LRAT positive, Thi negative, fibulin 2 positive in the alcohol-associated hepatitis model. There was a 44-fold expansion of these cells in alcohol-associated hepatitis. The top right image shows that these cells have the highest collagen 1A2 gene expression. In the bottom right, you can see that tracing LRAT positive cells in the LRAT-Cre ROSA26 transgenic mice detected GFP positive, fibulin 2 positive cells in fibrotic septa and in the boundary of injured areas of alcohol-associated hepatitis. Their conclusion is that in alcohol-associated hepatitis, highly fibrogenic LRAT positive, fibulin 2 positive subpopulations emerge, which appear to originate from LRAT positive hepatic stellate cells via myofibroblast cell fate shift. I did not show their data on bile duct ligation, but these cells were less common in that model. Taking these last two abstracts together, it appears that not all hepatic fibrosis is created equally. Abstract 155 from Adhikari et al. At the Catholic University of America in Washington, D.C. is entitled Microtubule Modifications that Alter Protein Trafficking are an Early Marker for Alcohol-Induced Liver Injury. I will foreshadow what I'm about to tell you, and the point here will become that there are two ways that microtubules can be modified, and that this is very important for liver function. As we all know, the liver is the major site of ethanol metabolism and is also most susceptible to injury from alcohol consumption. We know alcohol is metabolized by alcohol dehydrogenase to acetaldehyde, and also by CYP2E1 to acetaldehyde, along with highly reactive oxygen and hydroxyethyl radicals. Many of these reactive metabolites readily bind covalently to proteins, DNA, and lipids. More recently, alcohol exposure has been shown to induce protein post-translational modifications. Specifically, numerous proteins are lysine hyperacetylated upon ethanol exposure. Thus, covalent modifications of critical molecules may cumulatively cause alcohol-induced hepatotoxicity. Tubulin is one of the major targets for such modifications. The authors previously demonstrated that alcohol-induced tubulin acetylation correlates with defects in polarized hepatic protein trafficking. The current study questions whether tubulin acetylation or acetaldehyde adducts alone or together can explain alcohol-induced defects in protein trafficking. They also looked at whether tubulin acetylation occurs in human samples. Studies were performed in WIF B cells. The WIF B cell line is a highly differentiated and polarized rat hepatoma hybrid, which forms bile-canaliculi-like structures. They induced acetylation by overexpressing tubulin-specific alpha-TAT1, which is alpha-tubulin acetyltransferase 1, in polarized WIF B cells. Acetaldehyde was added directly to induce adduct formation. What did they find? Both alpha-TAT1 expression and treatment with acetaldehyde significantly impaired tubulin function, notably microtubule-dependent secretion, transcytosis, and clathrin-mediated endocytosis. Either approach led to similar levels of impairment to that observed in ethanol-treated cells. In human liver, rat liver, and cultured WIF B cells, tubulin acetylation was increased 2 to 3-fold in ethanol-exposed samples. Liver from patients with NAFLD showed no increased tubulin acetylation. The authors conclude that tubulin modifications by these two paths are not additive, but that these two pathways compete for critical lysines, leading to defects in protein trafficking. The translational implication is that changing cellular acetylation levels may be a feasible approach for alcohol-associated liver disease. Abstract 73 by Kozumi et al. From Osaka University in Japan is entitled Thrombospondin 2 as a biomarker for non-alcoholic steatohepatitis and advanced liver fibrosis. So this is a study of thrombospondin 2 as a possible non-invasive biomarker of NASH and NAFLD fibrosis. Thrombospondin 2 is a matricellular protein that mediates cell-to-cell and cell-to-matrix interactions. In the adult, it is synthesized in connective tissue, and more importantly, it is produced in response to tissue injury. The authors performed whole transcriptome analysis of liver tissue from 98 biopsy-proven NAFLD patients and identified a variety of secreted proteins that had upregulated gene expression in NASH and/or advanced fibrosis. Based on these studies, they examined the diagnostic potential of thrombospondin 2 as a candidate protein in 213 histologically characterized NAFLD patients. Transcriptomic analysis identified thrombospondin 2, abbreviated TSP2, encoded by its gene THBS2 as upregulated in NASH and/or stage F3 to F4 NAFLD fibrosis. Intrahepatic THBS2 mRNA levels showed that high Aurochs of 0.915 and 0.957 for diagnosing NASH and advanced fibrosis, respectively. THBS2 positively correlated with inflammation and ballooning, according to NAFLD activity score, serum AST, hyaluronic acid levels, and NAFLD fibrosis score. THBS2 was associated with extracellular matrix and collagen biosynthesis, platelet activation, caspase-mediated cleavage of cytoskeleton proteins, and immune cell infiltration. Serum thrombospondin 2 expression was also significantly higher in NASH than in fatty liver, simple fatty liver, and increased in parallel to fibrosis stage. The Auroch for diagnosing NASH and advanced fibrosis was 0.776 and 0.856 respectively. Serum thrombospondin 2 positively correlated with NAFLD activity score, serum AST, hyaluronic acid levels, and NAFLD fibrosis score. Serum thrombospondin 2 was also an independent predictor of NASH and advanced fibrosis in multivariate analysis, and additionally stratified NAFLD patients according to the risk of adverse hepatic outcomes, specifically liver cancer and decompensated cirrhosis. Their conclusions are that thrombospondin 2 and its gene, THBS2, are novel biomarkers for NASH and advanced fibrosis and could be potential therapeutic targets of liver fibrosis, although they provide no support for the latter part of that statement. Abstract 49 by Chuek et al. Is from Lyon in France. As you can see on the slide, the title is Circulating MicroRNAs Improve Early Diagnosis of Bacterial Infections and Acute Decompensation of Liver Cirrhosis. Circulating microRNAs, abbreviated MERS on the slide, have been studied for the diagnosis of sepsis in the general population, but no data has been reported for cirrhotic patients. The current study aimed at profiling circulating microRNAs in acutely decompensated cirrhosis to identify MERS signatures associated with bacterial infection-triggered acute decompensation, and the ability of these signatures to predict secondary infections and mortality. The investigators prospectively included 81 patients with alcohol-associated, NAFLD, or HCV cirrhosis in 2 French academic medical centers. Inclusion criteria were hospitalization for acute decompensation with sample collection within 72 hours of admission, which yielded 57 patients, and compensated cirrhosis without sepsis in 24 patients. Profiling of plasma microRNAs was with nanostring encounter technology, which is a variation of a DNA microarray that provides a digital count of transcript numbers within each sample using color-coded molecular barcodes. What did they find? Of the 57 patients in the acute decompensation group, they excluded 9 patients with uncertain cirrhosis and compared 17 with bacterial infection at inclusion versus 31 without sepsis. 1-month mortality was 23.5% for the sepsis group and 7.4% for the non-septic acute decompensation group. Figure 1a shows that 34 microRNAs were differentially expressed between the acute decompensated patients with versus those without bacterial infection. Figure 1b shows that they developed a sepsis score that included neutrophil count, CRP, and microRNA 362.3p that could diagnose bacterial infection with an area under the curve of 0.83, and that outperformed each of these components separately. From my limited reading, this microRNA is involved in cell proliferation and micromigration, but I'm not sure how that fits in this situation. Figure 2 on the top right shows that 127 microRNAs were differentially detected between acute decompensation patients who developed nosocomial infections and acute decompensation patients without suspected or confirmed sepsis during the hospitalization and who were not treated with antibiotics. Most of the top differentially detected microRNAs in this group were involved in regulating immune responses. Finally, 5 microRNAs could predict 6-month overall survival in acute decompensation independently of MELD score. An example of this is LET7G shown in Figure 3. The conclusion is that microRNAs might improve early diagnosis of bacterial infection and predict outcome in cirrhosis patients with acute decompensation. Abstract 51 by Kumar et al. From the Cleveland Clinic examines whether skeletal muscle senescence contributes to sarcopenia and cirrhosis. The title is Hyperammonemia-Induced Mitochondrial Dysfunction Causes Skeletal Muscle Senescence and Sarcopenia, which are reversed by ammonia-lowering interventions. Muscle hyperammonemia causes skeletal muscle mitochondrial oxidative dysfunction, a known mediator of post-mitotic senescence. As the title implies, they examined whether ammonia-induced mitochondrial dysfunction causes skeletal muscle senescence, and if lowering ammonia can reverse the senescence-associated molecular phenotype, abbreviated SAMP. Studies were performed in murine myotubes treated with ammonium acetate, followed by ammonia withdrawal. In vivo studies were performed in the hypoammonemic portocable anastomosis, PCA, and sham-operated rats treated with or without rifaximin L-ornithine L-aspartate daily by oral gavage for 28 days to lower ammonia in vivo. Molecular responses were determined by RNA-seq and untargeted whole cell and isolated mitochondrial proteomics. Senescence-associated molecular phenotype was assessed by senescence-associated beta-galactosidase activity and staining, and expression of P16 Inc., P21, and phosphorylated P53 in the myotubes and in the gastrocnemius muscle from the rats from the in vivo study. The figures on this slide show a wealth of information, and I will only point out a few points relevant to the author's main points. In Figure D, you can see upregulation, shown in red, of the senescence pathway in hyperammonemic myotubes and muscle tissue from the portocable anastomosis rats. The square boxes connected to that, to the right of Figure D, break out the components of the senescence pathway with increased senescence-associated beta-galactosidase activity in myotubes and muscle tissue, senescence-associated beta-galactosidase staining in myotubes, and greater expression of P16 Inc., P21, and P53 protein expression in both hyperammonemic myotubes and in the gastrocnemius muscle of portocable anastomosis rats. Withdrawal of ammonia reversed skeletal muscle senescence-associated molecular phenotype and sarcopenia in hyperammonemic myotubes and muscle tissue. The authors conclude that ammonia is a mediator of skeletal muscle senescence, contributes to sarcopenia and cirrhosis, and that therapies to lower ammonia have the potential to reverse mitochondrial dysfunction-associated senescence-associated molecular phenotype and sarcopenia in cirrhosis. Abstract 151 by Diaz et al. From Duke University is the next one that I'd like to present. The ability of the liver to regenerate is critically important for maintaining organ homeostasis and for the liver's unique ability to recover from injury. We know that liver regeneration is impaired with aging, but the underlying mechanism is not well understood. This abstract evaluates the hypothesis that hedgehog signaling becomes dysregulated in hepatocytes during aging, resulting in impaired regeneration and therefore enhanced vulnerability to damage dysfunction, that is, decreased resiliency. The study compares the hepatocyte response to partial hepatectomy in old and young mice and identified differences in regenerative responses, gene expression, and signaling pathways. The study then manipulated candidate signaling pathways in young mice, performed partial hepatectomy, and determined whether the changes in the signaling pathways reproduced the impaired regenerative phenotype seen in old mice. In young mice, liver regeneration is accompanied by significant activation of the hedgehog signaling pathway. As expected, liver regeneration is inhibited in old mice. Old mice exhibited lower hedgehog pathway activity than young mice before partial hepatectomy and failed to increase hedgehog signaling after partial hepatectomy. In the bottom two panels, you can see that when they disrupted hepatocyte hedgehog signaling by deleting smoothened, abbreviated SMO, in young mice, this phenocopied defective regenerative responses of old mice with decreased energy homeostasis and cell cycle and inhibited recovery of liver to body weight ratio. In the top right corner, the top two graphs showed that old mice, in black boxes, have decreased mitochondrial mass and telomere attrition. In the bottom two graphs, you can see that young mice with deletion of smoothened show the same decrease in mitochondrial mass and telomere attrition. The conclusions are that that hedgehog signaling becomes dysregulated in hepatocytes during aging, resulting in impaired liver regeneration and therefore enhanced vulnerability to damage and dysfunction, i.e., decreased resiliency.
Thank you, Dr. Laurie, for being with us at this very late hour and seeing some of the questions in the chat box as well. I can have comments from the panel now and the questions, if any, to.
So when may I just have the ball rolling? Can you hear me?
Yeah, we can.
You can see from the chat box that people have commented mainly on the microRNAs. Dr. Jayanti and Dr. Shiv Sarita have asked questions. So my point is just an open question to Dr. Dalli. We have two broad areas that you talked about. One is FMT and the microRNAs. So you can see that the application for these two modalities, one as therapy and the other as diagnosis, is so widespread. In all these years of research, have you spoken to anything specific about this? Like alcohol use disorder, for example, has so many components to it. And we're talking about FMT being therapeutic. Any comments on this? How long do we expect? How do we have the organisms identified? How long do we expect the effect to be there? Because AUD is a lifelong condition. Any comments on that?
Yeah, I don't know what the duration of response is. I did see a couple talks by Jaj Baraj on this. And I can't tell you what the interval was when they had to repeat this. I can tell you that FMT is becoming easier. They're now, I don't know in India, but in the United States, you can now actually just buy the capsules. So I think, we're getting a better handle on which bacteria really make a difference. In this case, let me try to say it properly, Ruminococcus actiae. I just slaughtered that word. I do every time. But that seems to be a particularly beneficial one. I think as we narrow it down more and more and can refine the donors of the FMT, if you can pop a capsule of FMT from a really good donor, and that can reduce your alcohol craving, I think that might be a very safe and potentially very effective way of dealing with alcohol craving.
And the second question is about the microRNAs. Again, we've been identifying microRNAs in various conditions, and you talked about two of them, TSPs and the one for identification of infections. Even in progression of fibrosis and liver disease, there are so many microRNAs that have been identified, 122, for example. So once again, are we talking about a specific microRNA, or are we talking about an array as an application for the future?
I guess I'm not exactly sure which abstract you're talking about with the microRNAs. I'm talking about circulating microRNAs. You're talking about that one? Yeah, the circulating microRNAs, they really narrowed down to 5 different ones at the end. And the ones that seem to be most important, not all 5 were, but the ones that seem to be most important were related to immune regulation, which I guess is not really surprising. That would be the area, but I think it's still a field in flux. I think this was a very strong abstract, which I presented. The fact that it could predict 6-month mortality was just blew my mind. What else do we have that can predict 6-month mortality? So I think we're getting closer and closer, but both of these fields, I think, still need a lot of work. And there are a lot of really good scientists from many different places working on this. But I think when you don't really fully understand how something works, you can find correlation, but you have to fine-tune causation for some of these things. So I think we'll find more answers for a while, and then it'll be fine-tuned more. I think both of these things, I think, are very promising.
Very interesting papers, though, and a wonderful presentation, of course. Very good concept papers you've chosen.
Thank you.
Dr. Bihari?
Yes. So my query is related to the myofibroblast, like perivascular myofibroblast. This is a uniform phenomenon. Basically, in other organs also, you will see the myofibroblast around the vessels. So is there any specific thing about the portal myofibroblast, or this is similar elsewhere in the body?
Well, remember, you didn't see one of the abstracts I presented. Again, I apologize. But basically, two different groups saying two very different things in different types of fibrosis. So the second abstract came from me. It's a Fumoto's group. He is a stellate cell biologist. And most people in the field have always felt the stellate cell is the source of, people don't call them myofibroblasts in that field, they call them activated stellate cells. So the dogma has been it's all hepatic stellate cell. Chantal Housset has said for a long time, no, I think the portal myofibroblast also contributes. And I think what she's shown now is that we have these cells living in normal liver, they're surrounding the vasculature, and they are important in certain types of fibrosis. What really surprised me, and that's why I really like this, is that we saw this in things like NASH. I wasn't surprised that you might find this in something that is a portal cholestatic injury like DVC, but that NASH would mainly come from the portal myofibroblast really surprised me. So I think we're going to find, I don't know about other organs, I'm not a specialist in other organs, but I think what this tells us is that hepatic stellate cells are not only the answer, and that if we keep looking in the same models, which most people do, most people look at carbon tetrachloride, or they look at alcohol or things like this, and they find the same answers. But I think if you look at a wider group of fibrotic disorders in humans, that we will find that different populations are the origin. Did that answer your question?
Partly, actually. Thank you.
Okay.
So
you're muted.
Vinay, I think you're muted again.
Sorry. Thank you for being with us. I thank the panel, and thanks Dr. Laurie again for being with us today at this late hour. So now we move on to the next session, I guess. And that session is on artificial intelligence in liver disease by Dr. Sumit Asrani, who's also live with us today. And it's always exciting to have human intelligence discuss artificial intelligence. And for the panel, we have Dr. Arup Saraya, who's the Director and HOD of Gastroenterology at the All India Institute of Medical Sciences, Dr. Ashok Chaudhary, who's the Associate Professor at the ILBS New Delhi, and Dr. Karambir Chaudhary, a Senior Gastroenterologist at the Woodland Hospital at Kolkata. So let's have it from Dr. Asrani.
Thank you again for sticking till the end of the program. This is the second to last talk before you hear from Dr. Kamath. And I wanted to give you updates about what was presented regarding artificial intelligence and the liver at the liver meeting 2021. And once again, my name is Sumit Asrani. I'm Associate Professor of Medicine and the Medical Director for the Center for Advanced Liver Disease at Baylor University Medical Center in Dallas, Texas. I wanted to start off with a primer on artificial intelligence, because this is relatively new to me over the last 2 or 3 years. And if we look at our lives, this has already been ingrained in things that we do. When we order from Flipkart, Amazon, Google, when we use Siri, when we use Google, when we use Alexa, we're sort of used to this concept of machine learning and this concept sort of pervading most of our lives. And Sundar Pichai also mentioned that machine learning is a core transformative way by which we're rethinking how we're doing everything. We are thoughtfully applying it across all of our products, be it search, ads, YouTube, Google Play, and they're in the early days. But as there's thinking in a systematic way, machine learning, if not already there, it's going to be applied in every single area. And we're seeing this also in medicine. And this was a New England Journal article in 2019 that talked about the promise of machine learning in medicine. where the thought is that the wisdom contained in the decisions made by nearly all clinicians and the outcomes of billions of patients should inform the care of each patient. That is, every diagnosis, management decision, and therapy should be personalized on the basis of all known information about a patient in real time, incorporating lessons from collective experience. Now, that is a tall task, but already we've been on this journey. And if we sort of, compare how we think about mathematical modeling and the way we've approached medicine, traditional approach is, programmed with rules, if this, then, and sort of, coming up with these themes. And on the other hand, you have machine learning and AI, where you're trying to model learning from examples, where you have inputs and outputs. And these may not always correspond to underlying biological pathways that we're used to or the way we think about. And the ability that machine learning provides is the ability to examine complex, non-linear relationships at many different levels. And the theme I want you to take away is that AI is sort of pattern learned from data. And when we say artificial intelligence, we're probably talking about three different aspects. One is natural language processing, where something can actually go through our notes and pick up themes, ideas, and put that together. Two is machine learning, and I'll talk about this in a second. There's supervised learning, there's unsupervised learning, there's reinforcement learning, and then there's deep learning, which sort of builds on this in terms of neural networks. So think about machine learning as supervised, unsupervised, and then neural networks and deep learning. Now, supervised, this is what many of us are used to, where we're looking at data to assess relationships between input data and labeled outcome data, right? Many of the things that we look at, like the MEL score or other sort of categorical scores, are linear or logistic regression in terms of modeling. We know that. Then add to it decision trees and multiple decision trees. That is also supervised. Then you have unsupervised machine learning, which is you sort of have a data set, and what we're trying to do is pick out, how do these data elements cluster, or what is the main component driving things? So that's principal component analysis, where you're using the underlying structure or distribution in the data to learn unknown patterns. And then finally, you have the neural networks and deep learning. And the two things I would like you to think about is, one is artificial neural networks, which sort of captures complex linear, non-linear relationships. And it also captures multiple layers of interaction. And then convolutional neural network, or CNN, I'm going to call it CNN, which applies to, let's say, imaging or pathology. Okay, so artificial neural networks I'm going to use to think about data, CNN to think about sort of, imaging or pathology. So applications, this is just scratching the surface in 2021. So starting from, up here, up top, we're looking at, applications from prediction of fibrosis, complications, mortality, to sort of genetic and epigenetic features and looking at, how do we look multi-omics, to natural language processing and gathering a lot of data from electronic health records, to real-time biomonitoring, to pathology-based recognition of patterns, to radiology-based recognition of patterns and liver masses. And here, sort of on the right, this figure from another recent publication, which I encourage both, to read both of these papers, looks at, measurement of liver fibrosis, analyzing biopsy data, predicting disease progression, and then diagnosing focal liver lesions. So let's get into, what was presented with that background on machine learning and AI at the meeting. And there were four big themes. So one was prediction of high-risk NASH. Two was prediction of changes in fibrosis based on biopsy or imaging. Three was prediction of decompensation and HCC. And four was prediction of mortality. So first one I wanted to discuss was machine learning model outperforms non-invasive tests to detect NASH-related fibrosis. In this study, the group looked at fatty liver patients over a 10-year period and looked at the biopsies that were scored by the NASH Clinical Research Network, and the outcome was fibrosis stage greater than 2. They collected 26 variables that were divided into demographic variables, clinical variables, and lab values. And they started with 1,000 biopsy-proven patients, 80% training cohort, 20% test cohort, looked at these 26 variables, applied machine learning models, and what came out of all these things after they tested this was that the best model sort of was something called random forest. And what random forest is again, we talked about supervised learning, is you have multiple decision trees, not just one, and the output of the random forest is the class that is selected by most of these multiple decision trees. And in this random forest models, the variables that sort of came out is many of the things that we would have expected: AST, platelet, type 2 diabetes, the ratio, age, surprisingly hematocrit, and then albumin. And these are just plotted in terms of which were driving a lot of the impact. And here are the results of the modeling. So if you looked at random forest as compared to 2 other kinds of modeling, random forest seems like had the best performance characteristic, which is shown here in orange. And it even did better than FIB-4 or NAFLD fibrosis score. The question again, with any of these modelings that you'll see again and again is, how do we apply some of these models that, that come out through AI or machine learning? Building on this theme, this one looked at digital pathology with AI analysis that overcomes limitations of current scoring systems in fibrosis regressions for NASH with advanced fibrosis. And the background of this is a paper by the group that looked at sort of a training and validation group at biopsy data, and they quantified elements of fibrosis, inflammation, ballooning, steatosis, and overall about 200 to 250 different characteristics. Of these, about 50 to 60 characteristics were selected for fibrosis, inflammation, ballooning, and steatosis, falling and making this sort of model construction, looking at the fibrosis element, the inflammation element, ballooning element, and steatosis element. And visually showing that in one of the examples from the paper. So what you can see is you're analyzing the pathology images digitally, and you're looking at different components with regards to collagen, lumen, thin tissue, thick tissue, looking at the distribution, you're looking at the density, you're doing a morphologic analysis. And finally, based on this, you can sort of, come up with these, different subsets that identify fibrosis, steatosis, inflammation, and ballooning, and also help quantify it. And for this abstract, what they looked at is 198 paired biopsies from about 100 patients from a clinical study. And they looked at the liver fibrosis, the Q fibrosis, using some of these techniques, both at baseline and end of treatment. And the end result was that the fibrosis regression was better captured by this Q fibrosis. And let me walk you through this. So what I want you to do is first look at panel A. So this was, if we just stage the fibrosis, we would have said that regression, which is in green, was seen by 30% in the placebo, 27% in one dose, 20% the second dose. Same thing with baseline fibrosis. But now, if you looked at Q fibrosis, what you're seeing is that the amount of regression picked up with Q fibrosis, instead of being 30%, is 40%. And in some cases, for stage 3, with this higher dose, initially thought to be 17%, actually was 83% regression. This again needs to be validated, but again, proof of concept that maybe this picks up more subtle changes in fibrosis. Whether this is associated with outcomes in the future remains to be seen, especially if things are repeated. And also with changes in fibrosis, I'll just concentrate on excuse me, on figure D. What you can see is if you look at the width of the septa, that changed more, or the width decreased more in the patients that had a decrease in fibrosis stage as compared to those that increased in fibrosis. So you can see this pattern with width of septa, with other changes in continuous variables, as well as compared to our routine assessment of fibrosis regression. And this was one of many presentations on similar themes. So here you had, how do we identify NAFLD? How do we grade autoimmune hepatitis? Another one on digital pathology, cardiovascular disease, looking at balloon hepatocytes, and looking at liver fibrosis in a low prevalence population. So again, similar themes that were imaging and pathology related abstracts. The third one I wanted to highlight was machine learning being more accurate than conventional risk scores to predict hepatocellular carcinoma in patients with chronic viral hepatitis. So here is a large study from our Hong Kong colleagues. Here the methods were to compare the accuracy of novel machine learning methods with existing risk scores to predict HCC in a territory-wide cohort of chronic. So in this study, the methods were to compare the accuracy of novel machine learning models with existing risk scores to predict HCC in a territory-wide cohort of chronic viral hepatitis in Hong Kong. Here they looked at about 150,000 patients with chronic viral hepatitis and split the group into training and validation cohorts. They used 46 parameters to develop machine learning models. And what you can see just glancing at this, some make sense: age, platelet, albumin, bilirubin, AST, ALT, AFP, INR. But then you're also having figures that one would not have thought. Renal malignancy, cervical cancer, breast cancer, lymphoma, certain kinds of medications. But this is an example of, machine learning sort of using multiple parameters to figure out if there are themes that can be coalesced. However, as a side note, now imagine if you're trying to apply this to a population which may not have all these variables available, then will this change the way the machine learning works? And here are the results, and a lot of numbers, but training, validation. On the rows are the different kinds of models. And what I want you to look at is just the validation cohorts. If you look at the 46 parameters or 26 parameters, the best performance was actually by this method called ridge regression. And what this method does is it avoids overfitting and it accounts for multi-collinear variables in the model. But yes, it is better. But if you can imagine 0.84 versus 0.83 versus 0.83 versus 0.82, they're sort of in the similar realm. Regardless, this kind of model worked better. And here is the model, machine learning model, as compared to conventional HCC risk scores. And the performance of this model was better as compared to the other models. However, just glancing at this list of sensitivity and specificity, positive predictive value, negative predictive value, you can see that there may be overlap with other scores in addition. Here was a study by Dr. Verma on behalf of AARC group, one of multiple AARC related studies presented at AASLD to look at sort of predicting outcomes in patients with acute and chronic liver failure. And here looked at the 50 medical centers, 11 years of prospective data, with the outcome being death at 7, 30, and 90 days. And again, multiple models or modeling techniques were evaluated. And what we can see is if you look at the blue bars, this is the AUC for all these different kinds of models. I know it's hard to read, but if we just said, 0.8 and above is great, 1, 2, 3, 4, but 8 or 9 models were above 0.8 to predict a 30-day mortality. So many of them worked well, but of them, the best one was gradient boosting. This method sort of implies you start off with decision trees and then add one at a time to improve fit with multiple decision tree models. So this one sort of worked best. And if we compared it to the standard models for 30-day mortality prediction in the data set, and if you just look at the third column, which is AUC, AARC AI with 10 variables as compared to the day 7 other two models, the performance of this model was better. But what you can see, the specificity was about the same. Sensitivity is still low across the 3 models. But again, proof of concept that an AI-based model may be better. And from what I understand, hopefully there'll be a web calculator to help and assess this in clinical practice. And then a final thing to talk about is deep learning based on EKGs or ECGs. The ACE score predicts hepatic decompensation and liver-related mortality in patients with cirrhosis. This was led by Dr. Ahn and colleagues at the Mayo Clinic. And the background behind this is that there are EKG correlates for cirrhosis-related outcomes, prolonged QTC, low QRS voltage, decreased interval variations, short TPTE intervals, where many of these sort of change or have been associated with worsening disease severity. And let me walk you through what they have presented so far that was recently published in the Red Journal. Is they had, again, the theme, what I mentioned was the convolutional neural networks looking at image patterns. 5,000 patients with cirrhosis, 20,000 age and sex matched controls. Based on EKG analysis, one can come up with the ACE score. And this ACE score had excellent performance for classifying ECGs from patients that were from cirrhosis as compared to controls. And there was a positive association of liver disease, including MELD sodium, so that as the MELD sodium score increased, this ACE score increased between 0 and 1. And as a proof of concept, this increased as the patient got sicker prior to transplant. And as the patient got transplanted, this reset down to a lower level, suggesting resolution of liver disease. So this actually might be a very powerful model. In this work that was presented, this was 500 patients that were compensated between 1995 and 2020. After certain exclusions, about 470 patients, 2,000 EKGs. Looking at this ACE score based on each of these EKGs, after adjusting for relevant comorbidities, the outcomes of interest was either decompensation or liver-related death or liver transplantation. So cross-sectional analysis as well as prospective analysis. And what we see here is as the patient has different decompensation and multiple decompensations in cross-sectional analysis, the ACE score is higher for these categories. Next, what you see in prediction of liver-related mortality, one can see the separation by ACE score. This is not seen for liver transplantation, but at least for liver-related mortality, this can be seen after the first EKG. In mathematical modeling, looking at regression on the left, for looking at this figure first, unadjusted, adjusted, or fully adjusted, looking only at liver-related mortality, what you can see is that it is a significant predictor of liver-related mortality on adjusted analysis. And in looking at different kinds of models, ACE alone, 0.88, MELD alone, 0.85, which is pretty good. But if you combine both of them, this also allows us to predict the association better for liver-related outcomes based on EKG as well as MELD sodium. Bringing us back to the challenges of artificial neural networks that I hinted at during the talk is artificial neural networks and liver transplant. The way we thought about it earlier, about 2-3 years ago, was, are we all ready as a community for self-driving cars? Now, the challenges of AI is that you can have an a artificial neural network architecture that you develop, but it can perform inconsistently depending on the training data used. It cannot be assumed that the same model architecture will perform better in new populations, either spatially, that is, beyond the center where it was developed, or temporally, even beyond the time that it was developed. So this is something that we need to show, that does it perform across all centers? Does it perform across all time periods? And the second aspect is that neural networks are sort of susceptible to this black box effect, because we're talking about hundreds of layers of thousands of nodes, each with one equation that interact in complex nonlinear ways. So if we were trying to figure out what's driving the effect, we may not be able to. So the three challenges that I see with artificial intelligence in medicine. One is data set. So if we're building it on a data set, the data set needs to be representative and it needs to be diverse. We need to figure out how to handle missing data. So if a model is based on 46 variables, and then you apply to a patient population where you only have data on 15 variables, will that work? What about biological plausibility in some of the variables that are selected? And then, the prospective real-time data actually may vary based on how it was built. And we're talking about a large number of variables. Are we sure we can apply all of them in each and every situation? Two, it's built on past practices. So there is a chance for healthcare disparities to get worse. An example might be liver transplant for alcohol hepatitis. So this is increasing in the United States, and it often tends to be that patients that have resources, are young, who are white, who are rich, they tend to get transplanted, and often minorities don't get transplanted. So if we were building a neural network based on that, that might flag as minorities as having poor survival. And once we start using that kind of network and apply it for future data sets, that will give us a biased view, even though the reasons for that may be totally different. And then individual patients may have unexpected characteristics or be affected by environmental factors that are really hard to factor in. And then the third thing is we have to avoid laziness. We have to assess what is the clinical utility of what we're doing. Are we just looking for just a fancy car where something else may suffice? Will we end up relying too much on these kind of models, and will there be errors that we will not recognize? So I think AI and the liver is here, and it is exciting times as we start pushing the boundaries. I think the first practical application or implementation, which seems obvious, is maybe imaging or pathology based, but we must resist the temptation to unnecessarily overcomplicate things by using models when we may not need it. And this is sort of my, the way I think about this is, do I need AI, let's say in a situation, to solve my problem? And I call this a 2-minute test. So let's say I have a crying child who is hungry. I can get atta, I can make pasta, I can buy the fancy machines, and I can roll out fresh pasta. I can create this enormous gourmet meal with different kinds of pastas, with tomatoes, with olives, with onions, with whatever else you want to put in it. And yes, the hunger is solved. Or I can just use Maggie, and within 2 minutes, the hunger is solved. And so I think, as we think about AI, I really want us to think about, where are we applying this? And do I need AI to solve the problem, or in any given situation, is something like Maggie good enough, as an example? Thank you so much for your time, and I will now take any questions that you may have.
Thank you, Dr. Srani, and I believe you are with us from Dallas, and I think it's almost 2 a.m. there, and thank you for your patience. And may I now ask the panel to pose any questions or give their comments?
Thank you, Dr. Asrani. I think no question in the chat box. So people have understood the message well, I think. And you have clearly pointed out 2-3 things that we should know: the utility, strength, and pitfalls of machine learning. And I think you will agree that the posters which you have chosen, the first one, there was over-reliance in that paper on actually more than 80% was training data set. So there was over-reliance on that. So what do you think? What are the chances of overfitting or spectrum bias in these two?
No, that's a very, very important question. You know, spectrum bias is important. If I develop a model based on tertiary center data, which is a referral center, that is going to be different as compared to something in the community. And so that is definitely a big issue in this or any kind of model. And even if you looked at it, you know, in terms of the variables that were chosen, most of the effect was driven by AST and ALT. And so, yes, we're adding more masala, but how much is it really helping in the end?
So, any other questions or comments?
Yeah, hi, Dr. Sumit. Sir, as you suggested that 80%, but when you go for analysis, so most of the data is that they do training as 80%, the validation 20%. All AI papers that maybe I don't know. That is the problem, which previously all analysis related to AI is all by the engineers. That is why that is maybe difficulties, but I think now we are getting papers with the 80% as the training and 20% the validation. So I think the after number 77, there is one interesting, they have done two-step verification. They have done 80-20 for the validation. Then that validation they have done in a second set of validations. So that Professor Saryavarta is asking that maybe supporting that way. So we may get that way also some guidance, maybe, but we are all new into this area. So
no, this is definitely new. And I think we're just trying to figure out what is the best way to make sure that it is applicable outside the main center where anything is developed.
I fully agree. In fact, generalizability is poor because the type of data set we have from a tertiary center, and generally we do internal validation, even external validation data set is not available most of the time. And prospectively, we are not, if you go through the studies in gastroenterology, I think more than 80 or 90% studies are retrospective, not prospective. Not very clear-cut inclusion-exclusion criteria. So generalizability of these information, I think, is poor at the moment. That is my opinion. You may differ.
No, I agree, but I think it is exciting as a proof of concept. It's all new to us, and the prospective aspect of application, I think, is where it's key.
There's a small comment from Dr. Sarita and said we need international cohorts and multiple monitoring sets to overcome the missing data. And ARC is well set with the data. And I believe Nipun is using it at his center. So that is just a comment. And any more comments from the...
Sir, may I have one word with Dr. Sumit actually, and thank you so much for highlighting this topic. I really love this presentation. Sir, basically whatever models which we are using as of today, they are based on general logistic regression, and they are having the same problems which you have highlighting with the artificial intelligence. So the generalizability, whatever accuracy what they say is in the data set which they are using, right? Like say, for an example, MELT 3.00, it is based on the interactions, and there are different problems with the individual variables. So what is the benefit of artificial intelligence is that you need not to worry about the interactions between the variables. So your model itself is capable of handling that complex data. So that is the beauty of artificial intelligence actually. And regarding the derivation set and the validation set, it is the standard practice that the more data you give for training, the more better the model will understand the nuances, right? And subsequently, then you have to validate. So I think more data is required for training for every kind of machine learning model which we are seeing today.
No, Dr. Verma, I think you are spot on. there's nothing magical about, even MEL 3.0 as an example, right? You're still manipulating data, figuring out interactions. And even though on its face value, it looks fantastic, 0.83, 0.85, if I say I want to figure out between MEL 25 and MEL 27, who's going to die, the model performance is like 0.6. So it's not 0.8, 0.9. Yes, between 6 and 40, it might tell us, but not between 25 and 27. So AI is probably going to be helpful from some of the kind of work that you do. But I think the main thing is going to be, how do you make it translate into something easy to use? If it's not easy to use, no one will use it. And so MEL 3.0 has a beauty that we are used to thinking of a scale 6 to 40. We're thinking of a web calculator. So if you were able to convince the audience to say, you know what, we have something similar, you don't need to think about it, we do the thinking for you, that might be one way to translate your findings into a larger population.
So I believe that now we have, I think the moderators have had their fill of questions. And I believe, Dr. Astrani, that if we have this talk again after 20 years, you might have AI putting questions in your chat box and not the moderators. So thank you for being with us at this late hour. I thank all the moderators for being with us.
Thank you very much.
So now we move on to the last talk of today's and the final talk for this meeting. That's going to be by Dr. Patrick Kamath on liver transplant. And Dr. Kamath, as you know, is a professor at the hepatology clinic at the Mayo Clinic at Rochester, Minnesota, and a very widely published and a respected researcher. So let's get on with Dr. Kamath's talk. And for this talk, may I invite the moderators, who will be Dr. Sanjeev Sehgal, who is from Max, and Dr. Neeraj Saraf from Medanta.
Thank you very much for inviting me to talk on the best of AASLD liver transplantation. Again, I was hoping this could be interactive, but we'll manage, we'll do the best we can. So in this session, I'll go over what was presented at the plenary session, so the most important advances in liver transplantation in the previous year, and two very important papers, post-COVID vaccination outcomes in patients post-liver transplant and in patients with cirrhosis awaiting liver transplant. We'll also talk about outcomes of liver transplantation in the COVID era, and then I have a few questions which I would normally be interested in asking you and getting feedback right away, but if someone can email me your opinions on these things, I'll greatly appreciate it. I'm trying to learn what's happening in India about COVID and liver transplantation. Donor simvastatin and outcomes post-liver transplant. And very quickly, I'll go over access to liver transplantation in Europe for patients with ACLF3 and spontaneous survival in hepatitis B-related acute liver failure. So before I start, I want to thank all the lead authors. All of them were very kind enough to share their slides, and so I'm using their slides in this talk. So the first is on post-COVID vaccination outcomes in patients post-liver transplant. And so the question for you is, if you provide COVID vaccination to patients who have undergone liver transplant, will that be associated with a lower rate of COVID infection, symptomatic COVID, mortality? So the question is yes or no for these, or is it all the above, or is it none of the above? Okay, think about this and I'll provide you the results of this paper. So this paper is on COVID-19 vaccination associated with reduced SARS-CoV-2 infection and death in liver transplant recipients. The lead author is Binu John, and he went to medical college at the Christian Medical College in Vellore. So Immunocompromised patients, including liver transplant recipients, they were excluded from all the COVID-19 vaccine clinical trials. So there are no specific trials in patients who have been immunocompromised. Also, transplant patients are at high risk of severe disease. And there were reports of inadequate anti-spike antibody responses after COVID-19 vaccination. And that led to the approval of booster doses. And that was a particular problem in patients who were transplanted because they seem to have a lower COVID anti-spike antibody response. So patients had questions, and so had also their treating physicians. So if you recall, the data that drove recommendation for a third dose was based on antibody response after vaccination. And there are very few studies on transplant patients that can really, determine whether COVID-19 is reduced or COVID-19 related death is reduced after vaccination. And those studies have put various patients who have had a transplant together. But you have to understand that liver transplant recipients are less immunocompromised compared to other solid organ transplants. So what applies to, say, stem cell transplant or heart transplant may not apply completely to liver transplant. So that is the basis for this study. So the aim was in liver transplant recipients to determine the association of COVID-19 vaccination and one is SARS-CoV-2 infection, that is positive testing. Two is symptomatic SARS-CoV-2 infection, so that is really COVID-19, which is symptomatic. And three is COVID-19 related mortality. So this was the aim of the study. So they used the Veterans Outcomes and Cost Associated Liver Disease, what's called the VOCAL database, which is a really very good database follow-up for patients with cirrhosis. And the veterans are those who had served in the military previously. They are known as the veterans. So liver transplant recipients in active care from December 15, 2020 to September 12, 2021 were selected. And there were two groups. The vaccinated group are those who had 2 doses of either the Pfizer or the Moderna, both are messenger RNA vaccines, and at least 2 weeks since the second dose. So those are considered fully vaccinated. Unvaccinated are those who did not receive the vaccine at all or were partially vaccinated. So that is, they either had 1 dose or they had 2 doses but less than 14 days of follow-up. And the 14 days of follow-up is required to say complete vaccination, complete immunization, so fully vaccinated. And those who received the Janssen, which is an adenovirus vector vaccine, and I think that's similar to the AstraZeneca vaccine, and those were censored on the day of vaccination. So they were not part of the study because there were not too many patients who received the Janssen vaccine. So in the analysis, propensity scores were used. So this is a way of trying to match the 2 groups for other comorbidities that may determine their risk of mortality. And so other comorbidities would be age, sex, smoking, whether they had a combined liver transplant and kidney transplant or just liver alone, and morbidities like lung disease, hypertension, also looking for the type of immunosuppression that they had. And there's a way of calculating this when the analysis is made. So that's called the inverse propensity weight. So the outcomes that are looked at, like I said, primary outcome is, did they have the infection? And so this was truly SARS-CoV-2 positive. Secondary outcomes is, if they had the infection, were they symptomatic? And did they die of COVID-19? So statistical analysis, Wilcoxon and chi-squared. And I've gone over this in a little more detail because I think these are the sort of studies that you can also do. And hazard ratios were taken, again, controlling for covariates, age, BMI, race, etc. Now, the risk ratio is the ratio of risk after full vaccination among vaccinated to risk among unvaccinated. And vaccine efficacy is 1 minus risk ratio. So the lower the risk ratio, the higher the vaccine efficiency. So here, for instance, the risk ratio is the lower the number, the better it is. So here are the baseline characteristics of the vaccine and control group. 1133 were vaccinated, 791 were in the control group. These are the two types of vaccine they received. Little more Moderna vaccine than in the Pfizer vaccine. You can see these are statistically significant, but probably clinically unimportant differences. Important to note that there are very few females because these are all military, ex-military people. Age, again, little difference between the two groups, but probably not clinically important. Gender differences, again, this is part of health disparities where white Americans probably have a little better access to care than patients of other colors. And chronic obstructive lung disease, more likely vaccinated, and this is likely behavioral because if a person has COPD, they're more likely to seek vaccines. Again, if they had comorbidities, more likely to get the vaccine, so hypertension, kidney transplant, tacrolimus. Immunosuppression, different here, so a little more calcineurin immunosuppression in this group, and again, this may have driven the reason why patients had the vaccine. So some differences in the immunosuppression. So let's go to the results. These are the most important. So these are the variables: number of patients, control vaccine, number of events in the control and vaccine. Control group is a reference, and vaccine, this is the risk ratio. So 791 controls, 1133 vaccines, 67 tested positive, 43 in control, and 24 in the vaccine group. So the risk ratio here is 0.36, so that means really 64% lower risk of getting infected. Then we look at symptomatic COVID, 791 controls, 1133 vaccine, 40 had symptoms, 26 in the control group, 14 in the vaccine group. So the risk ratio here is 0.42 or 58% reduction. I'll show you these slides again. And then when it comes to COVID-related death, 791 controls, 1133 vaccine, 13 deaths, 11 in the control group, only 2 in the vaccine group. So risk ratio is 0.13, so efficacy is 0.87, so 87% reduction in risk of death. So the post-vaccination deaths, the first one was, like I said, there were 2, 80-year-old male, 9 years post-transplant on tacrolimus. He had compensated graft cirrhosis, ischemic cardiomyopathy, atrial fibrillation, chronic kidney disease. He had SARS infection 18 days after the second dose, so one can always argue maybe it was not completely effective. And the patient required mechanical ventilation, pressors, and dialysis, and ultimately died of respiratory failure. The other patient was also old, 82 years old, with coronary artery disease, diabetes, and chronic kidney disease, so all associated with higher risk. 8 years post-transplant on tacrolimus, had COVID-19 pneumonia 10 days after the second dose, again, partially vaccinated, and required non-invasive ventilation, but refused intubation, and that patient died of respiratory failure. So we know that the studies have shown that 54% of solid organ transplant recipients and 43% on antimetabolites mount an anti-spike antibody after COVID-19 messenger RNA vaccine. So not that high, so little more than half of recipients of transplant will mount a COVID-19 anti-spike antibody. So here, what you can see is, even though they may not have mounted the antibodies, and here they were not tested, there's a 64% decrease in COVID-19, 58% decrease in symptomatic, and 87% decrease in COVID-related death. And this is probably the most important here. So there seems to be a little disconnect between immunogenicity versus decrease in infection. So the reduction in SARS-CoV-2 infection and death appeared to be greater than suggested by antibody response, but this is from other studies, not from this study. So in addition to antibody response, there's possibly a role for T cell mediated response to vaccination. We know this occurs. So the same thing has been seen with influenza vaccine. The antibody response is not that good, but protection against influenza seems to be quite good and associated with a reduction in hospitalization and death. The limitations of the study is its retrospective design, so you can always have confounding factors. 96% males, and the authors have theorized that the anti-spike antibodies may have been low, or the T cell response may have been good, but these were not actually measured in the study. And every person was not systematically tested for SARS-CoV-2, and I'll tell you why in a bit, why that's important. And this is because they may have been tested outside the VA system. So they may have been tested in a private hospital, and so those records were not available. The controls in the database, they did not show up as having a vaccine, but they may have got a vaccine outside the VA system, and so that information could have been missed. The strength is the large sample size for a transplant population. It's nationally derived, so multiple sites, so it's not a single center study. They had adequate controls, and the results, I think, are very important. So to summarize, COVID-19 infection, 58% decrease after vaccination. Symptomatic COVID, 58%, I'm sorry, COVID-19 infection was 64%, symptomatic COVID, 58%, and risk of death, 87%. So probably important to vaccinate all your patients who've had liver transplant. But you also probably have patients with cirrhosis awaiting liver transplant. What about vaccination for them? So again, the question is COVID vaccination in patients with cirrhosis associated with lower rate of infection, symptomatic infection, mortality? Yes to all, no to all, yes to some. And again, this is from Binu John, looking at outcomes of post-vaccination COVID-19 after full or partial vaccination in patients with cirrhosis. So as we said previously, immunocompromised patients have been excluded from vaccine clinical trials. And patients who got transplant have a risk of severe disease and may not mount an adequate anti-spike antibody response. So the question is, should you actually vaccinate these patients before transplantation? So the study design, again, retrospective cohort study, vocal database, IRB approval, and these are the outcomes that were evaluated. Whether they had a positive COVID-2 test, whether they got symptomatic COVID, and whether there's a COVID-related death. So inclusion criteria, patients awaiting liver transplant, active care, excluded post-liver transplant. And definitions of full and partial vaccination. Full, again as before, COVID-19 diagnosed 14 days after second dose of the two vaccines or after a single dose of the adenovirus. This is the Janssen vaccine. So that is fully vaccinated. Partially vaccinated is if COVID was diagnosed 7 days after the first dose of a vaccine, but prior to full vaccination. So here are the outcomes. So looked at partial vaccination, complete vaccination, no vaccination. So primary outcome was death due to any cause within 60 days of diagnosis of SARS-CoV-2 infection. Secondary outcome was COVID-19 related death, hospitalization for COVID-19 related disease, need for mechanical ventilation, and outcomes were validated by medical chart review by 2 reviewers for all patients who were diagnosed with COVID-19. So statistical analysis, propensity scores as before to show you can compare post-vaccine and unvaccinated. And propensity scores, again, use the covariates as I talked before, age, sex, alcohol, chronic liver disease, and also for severity of liver disease. Audit C is alcohol use. And p-values calculated using t-test for continuous variables, Brown mode to compare medians, and chi-square test for binary and categorical variables. And then Cox proportionate hazard for time to death and time to COVID-related death. So it's important in these sort of studies to do what's called a sensitivity analysis. And when you look at a database and you find that patients had the vaccine but had infection, but you have to make sure that you exclude patients who developed COVID-19 before the vaccine was available. And then stratify the analysis, see if there are any difference between full versus partial vaccine, whether there's any difference between those who received the Pfizer and the Moderna virus vaccine. And these are the results. Overall, 3,242 unvaccinated and 254 post-vaccination. So small number of post-vaccine. So when you have a large control group and a smaller number of the group with interest, then you can propensity match 1:1, 2:1, 3:1. So you're trying to get many patients with similar characteristics to this group. And so when you have a large number, it's much easier to get patients. And so in here, they matched 2:1. So they could find 2 patients who were unvaccinated, similar in characteristics to every 1 patient who was vaccinated. So 508 and 254. 82 had full vaccine, 172 partial vaccine. Median age, 64, males like I told you before. And these were the characteristics post-vaccine. You can see there were more vaccines in some part of the country than in the other. And this is all sort of partly political. You know, some people are pushing for vaccines, some are not, some are opposed to vaccines. So that explains the differences between different parts of the country. So again, these are things that you can look at, you know, you can study in India, see whether it's any different part of the country, whether it makes any difference. So the outcomes post-vaccination and unvaccinated COVID. So here, this is post-vaccination and 254, unvaccinated 508. Deaths within 60 days, lower in vaccination, overall deaths, I mean, those overall deaths, COVID-related deaths lower, hospitalization about the same, COVID-related hospitalization about the same, but if they were hospitalized, lower risk for mechanical ventilation if they had the vaccine. So I'll give these are a summary of the results. Let's go over some details. So overall death, so unvaccinated in red, vaccinated in blue. So overall death, and you can see here COVID-related death, both lower with vaccines. So about 80% lower risk of overall death, and again, approximately 80% lower risk of COVID-19 related death. So in here are the specific numbers: full vaccination, partial vaccination, number of patients, number of events. So 35 events, that's deaths in full vaccination, 52 in partial vaccination. And you can see here, so both full and partial vaccination, significant reduction in mortality. And again, COVID-related deaths between full vaccination and partial vaccination, again, significant decrease in risk of death. So vaccination, full or partial, helps. What were the differences between the two vaccines, the Moderna 1273, control and vaccines? So in the Moderna group, reduction about 88%, and COVID-related mortality reduction 85%. Whereas in the Pfizer, reduction about 73% here and 73% here. So this comparison, numbers are not huge. It looks like the Moderna was better than the Pfizer vaccine. Okay, so this is Moderna, this is Pfizer. The patients who died after full or partial vaccination, you can see the age, because they were waiting for transplant. They're not as old as the post-transplant group. All had comorbidities in here. So to summarize, COVID-19 vaccine, this is from another study, 65% reduction in COVID-19 infection after 1 dose and 78 after 2 doses. Even if patients develop breakthrough COVID-19, post-vaccination COVID-19 is associated with a 79% reduction in death. And I think this is the most important part of the message. Even if you get infected, your risk of dying is lower. And the reduction was noted even after a single shot. So again, please ask your patients to get vaccinated. And the trend towards greater reduction of deaths from the Moderna than from the Pfizer vaccine. And in general, there appears to be some data that the Moderna vaccine, the 1273 messenger RNA, may be more protective than other vaccines against the Delta variant. And I don't know about the Omicron. There's information that the Pfizer vaccine is actually quite good against the Omicron variant. So post-vaccination, COVID-19, what could be the possible causes? So one is a primary vaccine failure. So the patients do not develop an adequate immune response. And this can be seen in post-transplant patients who mount a diminished antibody response to the vaccines. Cirrhosis in general is associated with vaccine hyperresponsiveness to several commonly used vaccines. And so the question would be, would you do better if you had compensated cirrhosis than decompensated cirrhosis? And I'll show you some data in a minute. Or you might be adequately vaccinated, but the infection is related to variants. So that is infections that occur despite adequate immune response to the vaccine. The limitation are that asymptomatic COVID-19 may be more common, but you're less likely to test for it. So this study cannot tell you whether they were more likely to be infected with Delta or not. Again, predominantly males. The numbers for the Janssen, the adenovirus vaccine, which I think the AstraZeneca virus vaccine is. So there are limited numbers of that. And the numbers to differentiate compensated from decompensated are small, but you do see some changes here. So compensated cirrhosis 589, decompensated 173. So the events 62 here. So overall deaths reduced more in compensated cirrhosis. So 81% reduction in compensated cirrhosis, 76 in decompensated cirrhosis, and COVID-19 related deaths. This is, I think, the result which is more important. 83% reduction in COVID deaths here and 53% reduction in COVID deaths here. So message here is, even though the data are not huge, try and vaccinate patients when they've got compensated cirrhosis rather than waiting for them to get decompensated cirrhosis. In general, vaccinate everyone if possible, and earlier better than later. And when they stratified the analysis, again, you can see that decompensated cirrhosis does a little worse than compensated cirrhosis. So to summarize, this is a retrospective cohort study, 1 to 2 propensity score matched for everyone vaccinated, 2 patients unvaccinated. And this study showed a reduction in mortality and reduction in overall mortality after both full and partial vaccination. And the reduction in mortality is almost about 80%. So keeping with the COVID theme, let's go to the next paper. This is more descriptive, and this reflects the US, does not reflect worldwide data. So this is early outcomes of liver transplant recipients during COVID-19 pandemic in the United States. And this is what everyone had realized, that when COVID was declared a pandemic, routine healthcare suffered. Everyone was finding difficulty in knowing what can you do to prevent COVID-19? What do you do for patients who are immunocompromised? How do we treat the liver transplant patients? What is the risk of transplant in these patients? All these were unknown, and I think patient care suffered a bit. So the aims of this study were to analyze the effect of COVID-19 pandemic on liver transplant in the United States. This was a retrospective analysis of data from United Network of Organ Sharing, or UNOS. So all liver transplant patients 18 and older for that 2-year period were included. And comparison was made between the pre-COVID period, so March 11th to September 11th, 2019, so about a 6-month period, and early COVID, so March 11th and September 11th, 2020. So this is early COVID, and this is pre-COVID. So these were the approximately 6 months that were compared. So what was compared was patient characteristics, so donor and recipient characteristics, and the outcomes, which are number of transplants, disease living, and variability across the country, patient survival and graft survival, hospitalization after liver transplant, how long did they come, what were the rejection episodes, death from COVID-19 infections, and what were the factors associated with poor outcomes. So if you look at the recipient characteristics pre-COVID and in the early COVID, not much difference here, but etiology was different, specifically higher number of alcohol-associated liver disease and lower HCC and a little lower NASH transplantation. But most important was the increase in alcohol-associated liver disease. The waiting days for transplant in the COVID era seem to be a little less, more dialysis, higher MELD at listing and higher MELD at transplant, and this probably reflects more patients with alcohol-associated liver disease. Donor characteristics, a little different. Donor BMI was higher, donor risk index a little higher in the COVID era. So sicker patients being transplanted, donor characteristics a little higher, donor risk index. And the outcomes, if you look at the transplants, you see initially transplants were lower, but then seem to pick up. But this variability occurs from year to year. And so it's not clear this is related solely to COVID. Patients had to travel longer distances. Ischemia time was therefore a little longer. Rejection episodes may have been a little different. So you can see acute rejection slightly higher. Survival, these are statistically significant, probably clinically unimportant, but in the COVID era, survival seemed to be a little lower. And you can see pre-COVID in red, and COVID era in green, and blue is pre-COVID living donor, and purple is COVID living donor era. So living donors initially seem to have been a little lower in most areas except here. So little change in COVID living donors. So if you look at survival here, this is for the first 30 days seems to be the same, but after 30 days in the COVID era, the patient survival was lower and the graft survival was also lower. And the association, so I told you, little lower survival and some comorbidities, need for ventilation, retransplant, and are all higher in the COVID era. So these are only associations. We cannot attribute cause and effect here. So to conclude, overall 4% fewer liver transplant during the COVID period. Alcohol-associated liver disease was the most common primary diagnosis during the COVID period. And during the COVID period, higher MELD, lower waiting list time, higher need for hemodialysis, and a higher rate for multi-organ transplant. So essentially, all these reflect higher MELD and all reflect sicker patients being transplanted and probably related to alcohol-associated liver disease. And the donors were slightly higher risk during that period. So to conclude, graft and patient survival at 90 days post-transplant was lower during the COVID period. And this difference was more pronounced after 30 days post-transplantation. Higher rejection and COVID was a primary cause of death in 5 patients, or 3% of total deaths during the COVID period. So in multivariable Cox rejection analysis, graft survival at 90 days, so COVID-19 period was one of the independent risk factors. Now, I just wanted to go over another paper, and that's in this month's issue of Hepatology, the December issue of Hepatology. So the impact of COVID-19 pandemic on liver transplantation and alcohol-associated liver disease in the US. And what has been found is since the start of the COVID-19 pandemic, alcohol-associated liver disease has become the most common indication for listing and the fastest increasing cause of liver transplantation. And so it's really important in difficult times to stem the rising tide of alcohol-associated liver disease because drinking really has gone up in the COVID period. And there's also an editorial on that paper. So pre-COVID, this is non-alcoholic liver disease and alcohol-associated liver disease. So more drinking in the COVID period and COVID also. So a few things changed. There was a new UNOS allocation policy, which I won't get into. And also transplant behavior changed. People were more willing in general to transplant for alcohol-associated hepatitis, and previously they were more reluctant. So in blue is what you'd have predicted the transplants, and in orange was what actually happened. So you can see many more transplants than you'd have predicted for alcohol-associated liver disease. and fewer for hepatitis C. So question for researchers in India, and I think this is important too. I think someone can really look at what has been the impact of COVID-19 on liver transplantations in India. And I have a few more questions which I'll come after the next presentation. And then there are questions regarding living donors in the COVID era in India. So if you have a SARS-CoV-2 PCR positive donor, would you accept that patient for transplant? What if they have minimally symptomatic COVID-19? Is that acceptable? What if they recovered from COVID-19? Is that acceptable for transplant? And so the UNOS has come out with a document on the risks and benefits of using SARS-CoV-2 organs, and I'll go over that in more detail. And this is, again, it's important to know what your thinking is on this. So all deceased donors are to be checked for SARS-CoV-2 by nucleic acid amplification test. So RT-PCR is one of the tests from a respiratory sample within 72 hours, but as close to possible to organ recovery to decrease the risk of unrecognized infection. So as close to transplant, check them for SARS-CoV-2. Now, we don't know whether there's any benefit in checking the SARS-CoV-2 antibody in the donor. So that testing, we don't know whether that is useful in saying it's safe or decreased risk of transmission to recipients. So no role for SARS-CoV-2 antibody testing. So this is again what is known about studies. Donors with resolved COVID-19 and a positive SARS-CoV-2 NAT test, 21 to 90 days after disease onset, they have a low risk of transmission because it's believed SARS-CoV-2 test can be positive after the infection has resolved, and this reflects really dead virus. Okay, so 21 to 90 days after disease onset, donor has recovered, low risk of transmission. Mild COVID-19, and you're seeing the donor over 10 days and less than 21 days after the date of disease onset and resolution of symptoms, again, low risk of transmission. Those are positive for COVID-19. So currently positive, does not look like they have any infection. They may be used, but not for lung transplants. Okay, so I think this is the danger. So in lung transplants, try and avoid using SARS-CoV-2 positive organs. If COVID has resolved and the SARS-CoV-2 is negative, very low risk of transmission. So should you use these organs or not? That again is a decision of weighing risks and benefits. So always balance benefits versus risk when you're using such donors. The sicker the patient is, the more likely you are to take a risk. And if they're SARS-CoV-2 positive donor, you might want to use monoclonal antibody after the organ has been transplanted. This is a recommendation, and I don't know what your practice is in India. Living donors, it's recommended that they self-quarantine for 14 days pre-transplant because everything is planned for a specific date and you don't want the donor to get infected and then have the whole transplant canceled. So the recommendation is self-quarantine. Again, I'd like to know what is being done in India. And in general, vaccinate potential transplant recipients early. Again, take-home message, everyone, healthy or unhealthy, try and vaccinate them as far as possible. There are very few contraindications to vaccination, so transplant as extensively as possible. This is a paper from Italy, donor simvastatin and outcomes post-liver transplant. So the question is, if you give simvastatin to the donor pre-transplant, is the liver outcome better? Yes, no, or well, maybe. So this is a study from Italy. donor simvastatin treatment is safe and might improve outcomes after liver transplant. So the conclusion is, well, maybe there is some role for simvastatin, but no proof. So why should you use simvastatin? So many lines of evidence. So in animal studies, if you use rat steatotic grafts, decrease hepatic injury and increase hepatic microcirculation. Remember, simvastatin seems to help endothelial function. In partial ischemia studies, early phase of reperfusion, decrease hepatic injury, less endothelial dysfunction. Late phase of reperfusion, less hepatic injury, less neutrophil infiltration, less apoptosis. What about in humans? Small study. So that I said was preclinical studies. No adverse events when simvastatin was given to the donor, and 1 week post liver transplant decreased ALT levels. So therefore, the authors decided to do a randomized control trial, and I really congratulate them for trying to do this. So the experimental group, so these were donors. So this is donation after brain death. They put in a nasogastric tube and gave 80 milligrams of simvastatin 2 hours before cross-clamping for liver graft recovery. So a little time for the simvastatin to be absorbed and perhaps reach the liver. It was a single center prospective double-blind randomized study between June 18th and April 2020. And the hypothesis was if you administer simvastatin intragastric to donation after brain death liver donors, it is safe and maybe the liver graft is more viable and it can improve early graft and recipient survival. So they thought they needed to enroll 66 patients to provide 80% power to detect a 15% difference between the two groups. So randomization was good using sealed opaque envelopes. Donor exclusion criteria were the typical exclusion for donors, pregnant or breastfeeding donors, autoimmune disease, ongoing systemic immunosuppressive drug, and malignancy or history of malignancy. Recipient exclusion characteristics, I've highlighted those that are important. Acute liver failure was excluded. Liver retransplantation and split or living donor liver transplantation were excluded because these have a little higher risk of complications. Primary endpoint was graft survival at 90 and 180 days. Secondary survival was patient survival, and I've highlighted what's important. An E-score, this is a paper in the Annals of Surgery, Early Allograft Failure Simplified Estimation Score. So if you're doing any studies on the graft, you may want to use the E-score. And they also use the Clavian-Dindo classification, and this is for post-operative events. And generally, this score looks at surgical and medical complications, including infections following surgery. It's not specific for liver transplantation. So good endpoint, survival of the patient and graft, as well as how did the graft function and whether there were any surgical complications post-transplant. They enrolled 58 patients, 29 in each group, and you can see that control and experimental group, really not much difference between age, gender, previous history of the donor, and really for the recipient too, really not much difference. So well-matched groups. Results, 3-month survival, not different. 6 months, barely significant, just significant. And if you look at the Clavian grading system, so that means post-operative complications, slightly better in the experimental group. So slightly better in those who had simvastatin. So simvastatin may have helped a little. The problem is that with the COVID, pandemic. They had to amend the protocols because of COVID, and so they had to end the study before reaching the full numbers. But maybe there is something there in simvastatin, and so I think more studies are required. And the question is, can you do this with living donors? Would be a rather simple study to carry out. And I think you have sufficient numbers of patients, and if you put a few centers together, I think you can have a very good study here. It doesn't require much work. So I think future targets, future larger studies are required, and try and find out the mechanisms by which these have occurred. Now, just very briefly, access to liver transplantation in Europe for patients with ACLF3. And so this was a study from many centers. And what they showed was, yes, some centers have better access to liver transplantation than others. And if you see, France has the best and Spain has very good access. And I think that is because they have a large number of donors. So there is inequity in access to transplant in various parts of Europe. So the question for researchers in India is, and let's not look across the whole country, look across just major centers, major metropolitan centers in India, which may have multiple transplant centers, and see for matched for socioeconomic status, matched for disease severity and everything else. Is there any difference in access to transplantation? And is there any difference in outcome for patients in India? So same disease, same socioeconomic status, do you do better in one place than the other? And I think it's not really to find out who's doing better, it's trying to find out what is accounting for the difference and what can you do to make it better. Okay, so this should be a quality improvement study. And then finally, spontaneous survival in HPV-related acute liver failure. And spontaneous survival is associated with hepatitis anti-B core antibody IgM and an immunoregulatory cytokine response. So the aim of the study was to determine the epidemiological, clinical, virological, and immunological factors associated with transplant-free survival. It was noted that detectable anti-core antibody, IgM, was associated with transplant-free survival. This probably reflects a flare of the hepatitis B. And I think with the resolution, the patients probably did not require liver transplant. And there are some immunoregulatory cytokine responses known. And those who had much more inflammation are the ones who more likely died, because I think these are the ones who went into multiple organ failure. Okay, so with that, thank you, and hope I can see you sometime for an in-person meeting.
So thanks to Dr. Kamath. I think he would not be here in person. And I would request the panel to give their comments. Dr. Saigal, Dr. Neeraj.
Yeah, hi, thank you, Dr. Thorat. Indeed, like this was a typical masterly talk by Professor Kamath, and he had, very elegantly brought out all the issues which we are discussing day in, day out about COVID-19 and liver transplant, which is really a hot discussion in our own practice these days. And the various, he's, really showed good studies. What I think is important for us as my own understanding, which I have understood the last 2 years, is our practice different from what the US data we get? The number of patients which have been presented, they are all mostly DDLTs. So if Professor Kamath was on live, I would love to know what is the, because the amount of bulk of transplant which have reduced in US, there's not much to the COVID, it's only 4%. So what are the LDLT practice in US? Because a couple of my colleagues were there was a difference in LDLT practice. It would be good to know about that impact. The vaccination part, I think, is very important, and we have been doing our own efforts and understanding as to how COVID vaccination is, effective in patients post-transplant. And we started doing as a trial patients who are 3 months post-transplant with stable graft function. And I realized that about 70-80% of them develop antibodies, but again, we don't know, is the antibody titer the level of any significance? I mean, 54% or 60%, which Dr. Kamath says, is a, we know that's a lower number post-transplant who develop the antibody response. Anything from 40 to 60% is a level of antibody making an important impact on the patient's subsequent acquiring COVID, and also the role of booster. So a lot of questions are there which are unanswered, but very good information which I've understood from Dr. Kamath's talk. And I think we have to develop our own experience and share it more and more as a collaborative national database rather than doing an individual center based study. That is my really main thing which I want to come to.
Thank you, Sanjeev. Neeraj, any comments?
Yeah, excellent talk by Dr. Kamath as always. So I think the basic message is, which he gave through the abstracts, was that we should vaccinate all our recipients and we should vaccinate all the cirrhotics. I think that is the bottom line. So we recently in India, we also have come up with the Liver Transplant Society of India guidelines on how to go about doing transplants in COVID, when to vaccinate them. And, and we are doing a multi-center, we have started a multi-center trial and collaborating data on the COVID experience across the country. We recently, we've just sent an abstract to the ILTS meeting, which is going to be held in May, on our experience with COVID in post-transplant patients. So this is predominantly in the second wave, because after that COVID had gone down substantially. So this is data till about June of 2021. So we had 157 patients who post-transplant patients who got COVID, and 80% had mild disease, 10% had moderate, and 10% had severe disease. And of the moderate and severe combined, so we lost about 17 patients, about 11% of the patients post-transplant. So that is, definitely higher than general population. And half of these patients were early on within the first few months after transplant. So I think the longer you are away from transplant, the chances of making, surviving after with the COVID is definitely better, because you're on probably less immunosuppression and, healthier. So we lost about half the patients who were within 3 months of liver transplant, and the others, I think comorbidities and higher age was a factor. So that's our experience, but we're trying to collect data from across the country. Let's hope that we can soon end the COVID data and have no more COVID, but that's the story till now.
Thank you, Dr. Neeraj, and thank you, Dr. Sanjeev, for being with us on this panel. And this meeting is now at its conclusion. I have a few announcements to make. Please, the viewers, and thank you for being with us throughout the 2 days. And may I request all those who are attending this meeting to please give us the feedback so that we can improve on in our future meetings. I would also like to thank the Amrapurkar family who has been helping us, especially Manisha Amrapurkar with the logistics along with Science First. And now I would invite Professor Sareen to give his concluding remarks on the meeting. And once again, thanks to all the speakers, all the moderators, and of course, all of you audience for staying connected over this weekend.
Thank you, Vinay, for the outstanding conducting the meeting for the 2 days. We had almost 17 hours of non-stop hepatology, and we had 20 sessions. 17 of them were 20 plus 2 orations, so that means 22 sessions of them, and 54 moderators. So and each and everyone showed up. That is a tribute to the science and the efforts. I also thank the 11 youngsters who had participated at India at AASLD. And yesterday, as the counts were given to me, we had by end of 10 p.m. 1160 people logged in, and many more might be listening from more than one stations. And today at the end, 400 people were still logged in 15 minutes ago. In the meeting, we had President-elect of AASLD, past President of AASLD, and to me, a legend, Dr. Jim Boyer, who gave his life's story, was also there. I want to feel very happy that we were able to create an environment of new science in hepatology. It makes us so humble to know that what we do not know. It also makes us learn few things, that we must work with more collaborations and more, data sharing. Nobody can take data. Very few studies from India. ARC is an example in Asia. We should have similar, many more studies. Each one of the moderators, investigators can, take a lead, and others can follow. There are so many things to be done. And lastly, AASLD brings us a new perspective in managing through the guidelines they prepare. We have very few guidelines from India, which should be India specific. With this, I enjoyed myself, learned a lot, and I want to thank Manisha and Science First and the sponsors, Reddy's, through Manisha and them, for making this meeting a success, and also to tribute to our dear friend Deepak, an excellent clinician, a researcher, and a friend. And I do hope we are doing justice to what he started with. And thanks again to Vinay for an outstanding anchorship of the meeting. Thank you all, and over to Vinay.
Thank you, sir. Without your stewardship, the meeting would not have been possible. And we all know that you're too modest to accept. And I thank the viewers once again. Thank you, everyone, for being with us. Have a safe weekend and a happy new year to all of you in advance. Thank you.
Thank you.